Good morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. As indicated in the calendar, we have several public hearings on various bills today, but before we get to those, I'd ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. First bill to be considered this morning is House Bill 704 FNA. The prime sponsor is Representative Mary Jane Wallner. And Representative Wallner, if you'd like to come forward, I would love to hear your testimony.
Thank you, Chairman McDonald and members of the committee. I'm Mary Jane Wallner. I'm a state representative from Concord, and I'm very happy to be able to bring forth House Bill 704. This is a bill that is really a funding bill. It's requesting funding for 4 well-established programs that support older adults and caregivers, and is an immediate way to assist families and help fill the gaps in New Hampshire's long-term services and support system. Family caregivers are the major providers of long-term services and supports and are essential in sustaining a viable long-term services and support delivery system. In New Hampshire, the CARE program provides families with much-needed assistance from the physical and emotional stress of 24-hour-a-day care. This program is administered through local aging and disability resource centers. The statewide respite program provides comprehensive training programs, and the funds are used to pay for needed respite services for caregivers. The bill also provides funds for 3 senior volunteer programs. The Senior Companion Program and RSVP both provide transportation and visits to isolated older adults. And the Foster Grandparent Program volunteers provide one-on-one support for children who benefit from the stability of the support of a grandparent. There are many people here today to testify on this bill, both people who are caregivers and people who know these programs very well. And they can go into much more detail than I can on each of the programs. I hope you will vote in favor of the bill and move it on to the Finance Committee. It is actually really an appropriations bill and needs to be in front of the Finance Committee as we consider the budget in the next few weeks. So I'm glad to try to answer any questions you have. You have the experts behind me.
Okay, thank you. Any questions? Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question. Just a simple question. Is this new funding or is this just restoring old funding?
This is making sure that the funding that has been in place for these programs stays in place.
Thank you.
Anyone else? No? Okay. Seeing no one other questions, so thank you. Moving forward, we have quite a few people signed up to speak, so I would ask you to try to keep your testimony to 3 minutes. And then that does not include questioning time, so that allows not only other people who want to testify the chance to testify, but it also allows the committee to have time for questions. So again, please take that into consideration. Also signed up to speak are Brian Clark and Wendy Altman from the Department of Health and Human Services.
Thank you. I'm Brian Clark. I'm counsel for the Bureau of Adult and Aging Services.
Good morning. My name is Wendy Altman, and I am the Bureau Chief for the Bureau of Adult and Aging Services at THHS. We are here and available to answer any questions of the committee. We'd also like to say that the intent of this bill is in alignment and in support of the supports and services that we offer through the Bureau of Adult and Aging Services. It's in alignment with our DHHS roadmap for our system of care for healthy aging and the work we do for our New Hampshire Family Caregiver Program and the ADRD, the Alzheimer's disease and related dementia work that we do within the Bureau to offer respite and support family caregivers around the state in conjunction with our Older Americans Act Family Caregiver Respite Program. And I'm happy to answer any questions as it relates to how we operate our programs and support volunteerism and how it aligns with our state plan on aging and the work we do with the Bureau.
Thank you. Representative Polazov.
Thank you, Mr. Chairman, and thank you for taking my question. So, am I right in assuming that ADRD is increasing in New Hampshire, and could you put some numbers on increase? And second question, as it relate to these programs, like what percentage of ADRD patients are treated by these programs, and is there any alternative where patients who are not treated in these programs where they could go? Thank you.
I believe the first question was related to the ADRCs and the operation of the program. Can you repeat that?
About Alzheimer's disease and related disorder, ADRD, with aging population, and generally, like, is it true that cases are increasing in New Hampshire, and can you give any numbers, like, are we looking into increased numbers in the coming years?
Yes, and I believe that there will be testimony coming forward from people who are experiencing and are able to access the grant and how it helps them. But overall, we serve a little over 250 individuals with our current aging Alzheimer's disease and related dementia respite grant. In addition to that, we serve a few hundred more through our family caregiver program. Currently, we are having a brain health campaign that's both going to medical providers and the general public, really to get education and outreach and an understanding of Alzheimer's disease and related dementia and early screening. So we expect, as a result of that campaign and based on the trends that we have for the people that we're serving, that we will need to have more capacity to serve individuals and assist caregivers.
Other questions? Representative Missouri.
Thank you, Mr. Chair. Thank you for being here today. So this $900,000 that I see in the fiscal note, are those caregiver or DHHS salaries, or are they just funds of overseeing the program?
The way we operate our family caregiver program within the Bureau is that the vast majority of the Alzheimer's disease and related dementia funding that is appropriated in the budget that you see here, it goes directly to respite grants. So the way we operate the program is that we leverage our Older Americans Act services and the matching general funds that are required for our Older Americans Act caregiver program to operate the contractors that provide caregiver support and counseling, and our financial management services contractor that administers the grants directly to the caregivers.
Follow up?
Yes, just quick follow-up. So this doesn't include, like, let's say, for example, a caregiver's salary. That's not included in this.
The respite grant would pay for an individual to provide direct care. So when we work with a family caregiver who needs respite, they will oftentimes need help finding a direct caregiver, or they may have somebody in mind. And we use our contractor to be the employer of record and pay for the direct care, for the respite.
Other questions, Representative Woods?
Thank you, Mr. Chair, and thanks for taking my question. What is the cycle? This is sort of filling in on funds you've had before. Is that something that comes up periodically? Is it going to be every biennium?
Yes, we do have an accounting unit and appropriation currently for both the Alzheimer's disease and related dementia general funds, as well as support for volunteerism, and that would come up every budget year.
It's okay. Follow?
Follow-up.
Now, is this budget, you've sort of alluded to other programs, is that sufficient to expand it both in terms of what's been referenced, an aging population, so the need is bigger, and we know that people that stay at home generally do better and less cost. So expanding it both in terms of just the numbers, but also the types of programs, is this budget sufficient to accomplish both of those?
It's certainly the appropriation that's proposed in this bill certainly builds the capacity to serve additional individuals. With the respite grant, we could probably serve a few hundred more respite grants, depending on the volume and the outreach and the results of our brain health campaign and the outreach and education that we do through the Bureau.
Thank you.
Representative Weber?
And just so I'm sure that we're all on the same page, am I correct in thinking that the vast majority of care is provided usually by family members at no cost to the public and at enormous cost to the family caregivers? And what we are trying to do here is give somebody who spends 24/7 with a beloved family member who may be very difficult to live with a small amount of time where they can breathe and be themselves and know that their loved one is safe.
Yes, I would agree with that. We see that, and there's many people here that can speak to their experience and the difference that it's made in their lives as a family caregiver, and that's really the vision and the goal for providing these supports, is to ensure people can stay at home in the community where they want to be, and that the people who are getting really that uncompensated service and care that's being provided, some relief and support, so that they can continue doing that.
Other question, Representative Kofalt?
Thank you, Mr. Chair, and thank you for taking my question. So would it be accurate to say that this program is potentially preventing some patients from being shifted to a much higher cost, in-home nursing care or, full-time care facility?
Yes, I would think that that's fair to say in terms of the caregivers who we see benefiting from the program and from the respite and the counseling and education that we're able to provide through the Bureau. That definitely is an outcome that we're seeing.
Representative Markell?
Thank you for taking my question. Ma'am, can you tell us about how many people do you expect to serve with this program in the state of New Hampshire?
Well, with the Alzheimer's disease and related dementia grant, we currently serve a little over 250 individuals. Our respite grants currently are about $2,000, which depending on what the needs are of that individual, it can give them a good amount of respite and support, but we can approve more if needed. So it is individual, and we would be monitoring how much we would be able to authorize for each family caregiver to receive that support. So we anticipate, a range of between 100 to another 200 individuals could receive that respite grant, depending on
Follow-up
what their
question?
needs are.
Follow up.
Thank you. And so how did you arrive at, okay, I heard you, what you just said in terms of your funding. How did you arrive at that number that you have in the bill here?
We use that to align with the parity or the grant that we offer through our Older Americans Act family caregiver program. So we benchmark, or that's the baseline for what we would offer for a grant. But if the needs are more, we are able to take that into consideration and approve more.
Thank you. No further questions.
Other question? Seeing no other questions, okay, thank you. Also signed up to speak is Doug McNutt from the Commission on Aging. Good to see you again, Mr. McNutt.
So, whoops. I'll be quick. For the record, my name is Doug McNutt. I'm here today representing the Commission on New Hampshire State Commission on Aging, which is fully supportive of this bill. In a prior life, I served in Wendy's position within the department, so I'm very familiar with these programs. And really what I want to emphasize this morning is these are programs that take advantage of small amounts of money, and in particular with the non-Alzheimer's funding, these are volunteers who are providing these services. So if you think about an aging population and how are we going to take care of them, for example, my wife does transportation services here in Concord for the Friends program. She's a volunteer. She does shopping for people. These are vital services that keep people at home and, again, at very low cost because we're talking about volunteers. And so given the fact that we have the kind of workforce shortages that we do, these programs are vital. And not only that, these programs take advantage of federal funding. Most of these agencies do their own internal fundraising. So there's a real bang for your buck in the small amounts of money that are involved, in this legislation. In terms of the Alzheimer's and disease-related disorders grants, that is a program that is very effective in terms of not only keeping people at home, potentially off Medicaid as well. So, there's a real value in doing this and taking advantage, frankly, of a volunteer force that is growing. In terms of Alzheimer's and dementia-related disorders, we know that as people get older, they're more likely to end up with dementia. So these are really important programs. I would argue they're real bang for your buck. And that's all I have to say. I'd be happy to answer any questions.
Thank you. Representative Nagel.
Thank you, Mr. Chairman. Thank you for taking my question. I've heard this from now 3 people, and I'm really curious. Do you have any idea, having been in that position previously, what percentage of the people that administer services are actually volunteers?
Well, when you're talking about the senior companion, foster grandparent, and RSVP programs, those are volunteers. When you're talking about the Alzheimer's program, we're talking about grants to caregivers to provide respite. So that's paid, but they're run through the Service Link program, which is run by the state. And so there's other volunteer efforts that are associated with that as well.
Follow-up?
Follow-up.
I'm curious, where do the grants come from?
So the senior volunteer programs are run by the what used to be called the Administration on Aging, and I don't know what it's called now, Administration for Community Living, I think. And those are grants that are funded to the states. And the senior volunteer programs are a separate federal program. There is a federal agency that runs all these senior volunteer programs. And the name escapes me at present, but that's where the funding comes from.
Other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Lily Wellington from the Friends Program. Ma'am, you've asked for 10 minutes. I can't give you that much
That's
time.
totally fine. I completely
Please,
understand.
3 minutes, please.
Yep. It was actually wonderful to follow Mr. McNutt. My name is Lily Wellington. I'm the Director of Volunteer Services at the Friends Program. It's my pleasure to speak to you today about 2 senior volunteer programs that we operate. One is the Retired and Senior Volunteer Program. That is what Mr. McNutt was talking about with the AmeriCorps Senior Grant. And the other is the Foster Grandparent Program. So I want to start with RSVP, which is what it's often reduced to. This is essentially a program. There are 6 operating currently in the state of New Hampshire, and our job is to assess where the gaps in each community are. How do we fill those gaps? With volunteers, specifically senior volunteers. So we are recruiting, training, and supporting anyone over the age of 55 who wants to help us meet these critical community needs. So for the program that we operate, we cover Rockingham, Merrimack, Belknap, and Stratford counties. One of our main components is around caregiving. Medical transportation has skyrocketed. The need for seniors, vulnerable citizens to get to and from medical appointments, I can't stress enough how significant it is. We received a phone call several months back from a woman who said, I can see Concord Hospital from my house. I can't get there 3 times a week for dialysis. She had no other option other than to go into long-term care. We, through a Hail Mary, we asked our volunteers if they'd be able to transport her 3 times a week for 6 a.m. dialysis. And in one day, we had 6 months of medical rides secured for her to and from dialysis. That saved someone's life. In addition, these volunteers are filling their days with something deeply meaningful, and they are the best advocates for this programming. We hear time and time again that they get more out of it than they could ever possibly give. I could speak for a very long time about the stories of impact. I won't. But long story short, this is keeping elderly, vulnerable citizens at home. We had someone who was discharged this week following an extensive abdominal surgery. She's 90 years old. She would not be able to return home if it were not for her volunteer shopper, who not only arranged to pick her up, he's going to pick up her prescriptions, he's going to grocery shop for her, he's going to make sure that she's settled in at home. She's 90 and she gets to go home. I also am here today to speak about the Foster Grandparent Program. So this is the other program that we operate. Again, it's using exclusively senior volunteers. This is an often misunderstood program. It's really classroom grandparents. So our foster grandparents, classroom grandparents are in schools across New Hampshire. They are in nonprofit preschools and daycares and after-school programs.
Go ahead.
Thank you.
You could start wrapping up, though.
Yeah, this is a program about deep meaning. They are serving anywhere from 5 all the way up to 40 hours a week. They receive a tax-free federal stipend for their service, as well as mileage and meal reimbursement. Keeps them active, keeps schools supported. They become an embedded part of the community. Thank you.
Okay, thank you. Any questions? Wow. It's unusual. Okay,
Thank you.
Also signed up to speak is Olivia Parzik, I believe it is, from the Alzheimer's Association. How many are there? Oh, sure. Did you all do separate cards? Yes. So also John Zimba? Okay, and Jenny Horgan. Okay, there we go. Yeah, start with 5. Well, there's 3 of you again, and we're asking each individual 3 minutes, so we'll give you extra time where there's 3 of you, so.
Thank you, Mr. Chairman, members of the committee. For the record, my name is Jenny Horgan, and I am the Senior Public Policy Manager for the Alzheimer's Association here in New Hampshire. In New Hampshire, there are 26,500 individuals that are living with Alzheimer's or dementia, and roughly 48,000 caregivers providing support to their loved ones. Caregiving, as has been mentioned repeatedly in this hearing already, is an incredibly challenging job. People who are caring for their loved ones with Alzheimer's or dementia are assisting their loved ones with daily activities such as bathing, dressing, eating, and then instrumental activities in the day-to-day such as paying bills, shopping, and transportation. More than 80% of the help provided to older adults in the United States comes from family members, friends, or unpaid caregivers. And in 2024 alone, caregivers in New Hampshire provided 77 million hours of unpaid care for loved ones experiencing Alzheimer's and dementia at an estimated economic value of $1.5 billion. In order to provide this care to their loved ones, caregivers of people with Alzheimer's or dementia experience higher rates of emotional, financial, physical, and emotional difficulties than caregivers of people who are caring for loved ones without Alzheimer's and dementia. Further, over 66% of caregivers of people living with Alzheimer's or dementia in New Hampshire have chronic health conditions. Over 28% of those caregivers experience depression, and almost 15% are in poor physical health. To help reduce the burden on caregivers, New Hampshire has the ADRD Respite Grant Program, which, when received, can assist a caregiver in acquiring alternative temporary care for their loved ones so that they may take a break while knowing that their loved one is safely cared for. These services can be provided in a variety of settings, including in a home, at a nursing facility, or in assisted living facilities. And this provides temporary relief that enables an opportunity for a caregiver to deal with their own, manage and improve their own health. New Hampshire's ADRD Respite Grant Program is one of the services that the Brain Health Public Awareness Campaign, as Wendy alluded to, is going to be highlighting. And given the fact that New Hampshire continues to age and we expect rates of Alzheimer's dementia to continue to grow, we do anticipate an increased need for this program. With HB 704, we will be increasing the funding to the ADRD Respite Grant Program, and it will not only help reduce burnout for caregivers that people who care for loved ones with Alzheimer's or dementia experience at very high rates, but it will also help delay individuals from needing to go into more costly living situations in a more restrictive environment. It is vitally appropriate, that when appropriate, if an individual so chooses, that they're able to stay at their home as long as possible, and preventing caregiver burnout for those caring for loved ones living with Alzheimer's or dementia is instrumental in ensuring that choice exists. So we're definitely in support of HB 704 and happy to answer any questions.
Thank you very much. Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question. Would you believe that I'm fortunate enough to work with high-level athletes, and one of the most important parts of training is called rest, and we actually pay them to do that. And I would say that it's wonderful work you're doing that allows these people to have that same opportunity to rest.
I would absolutely believe that, Representative. Thank you for the question.
Other questions? Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So I'm trying to divide 26,500 by 250. So it looks like this program serve approximately 1% of population who might need it. Is it accurate assessment?
Thank you for the question, Representative. Math is definitely not my strong suit, so I won't question your math. Certainly, it is a small population that is being served by this program, and that is definitely part of the reason why we're looking for an increase in funding. Specifically for that, we're so grateful to partner with the department with the funding that the legislature provided on the public awareness campaign to shine a light on this program so that more individuals who may be able to access it will be able to access it, ultimately benefiting them as caregivers, their families, and the state as a whole in terms of allowing individuals to stay in their homes longer if that's what they so choose to do.
Thank you.
Other questions? Representative Mazur.
Yes, thank you for taking my question. So I am looking back at the fiscal note, and it says, so fiscal year 2025, there's no allocations there. So what are you currently using for, currently being used for funding this?
So for the ADRD respite grant specifically, I believe, and I'm sure the department would be able to give more accurate numbers, but it's funded with general funds at $302 or so thousand. This would be a year. This would raise it up to about $550 to $100,000 for the ADRD respite grant specifically. And I will. Wendy is nodding that I am correct in that. So it would be a roughly an increase in this specifically for the ADRD program of about $250,000.
Representative Weber.
Thank you, Mr. Chairman. Thank you for taking my question. Do you happen to have off the top of your head, or could you provide us, or perhaps somebody in the department provide us, the cost of caring for somebody who receives Medicaid and who is in a nursing home and needs dementia care?
I do not have that number off the top of my head, Representative, but I'd be happy to get it from you or
I think
make sure.
it would be helpful in
Yeah.
terms of understanding the costs that the state is being spared if people
Absolutely.
can appropriately remain in their home with the appropriate supports.
I will make sure we get you that number, Representative. Thank you.
I will point out, Attorney Williams had given me numbers indicating that people aging in place, and again, that this could vary depending on their condition, but it's 24,000 if they stay in home versus 74,000 if they go to a nursing home. So I don't know if that's true in all incidents, but I guess that's an average number. So I don't know if that sounds.
I certainly would say that I think we're all definitely aware that allowing a person to be able to stay in their home if they so choose is at a much lower cost than someone who needs to be in a more intensive environment. And especially if someone is able to stay in a less intensive environment of care that's appropriate for them, and that's what they want to do, that is absolutely beneficial to them in terms of their situation as well.
Thank you. Other questions? Seeing none, okay. Thank you. Me too.
Good morning, Mr. Chairman and members of the committee. For the record, my name is Olivia Parzik, and I live in Bow, New Hampshire. I'm here today to testify in support of House Bill 704. I'm here today as someone who has lived the reality of caregiving at just 21 years old. My grandfather battled Alzheimer's disease for 4 years, and my family did everything possible to care for him at home. After his diagnosis in 2021, we made the decision for my grandparents to move in with us, ensuring that he had the support he needed, especially during the uncertainty of COVID-19. At first, we managed. My grandmother served as his primary caregiver, and we all stepped in where we could, but soon it became impossible. He could no longer be left alone. He wandered outside and forgot which house was ours. He became confused, anxious, and paranoid. Late afternoons and evenings with the sundowning were the worst. He would become angry and argumentative. My grandmother, exhausted, could no longer sleep in the same room because he didn't recognize her, and he would become aggressive. Nights were unpredictable. He would stay awake, wandering the house. We installed cameras, door sensors, and took shifts just to ensure his safety. Caring for him wasn't just a responsibility, it consumed our lives. Even when we hired help, we were never truly off the clock, but it provided my family with the small necessary breaks to keep up with work and school. Having even a few hours of respite allowed us to recharge and continue providing the best care we could. Supporting like this is essential for families navigating the relentless demand of Alzheimer's. It helps prevent burnout and ensures loved ones can remain at home longer with dignity and comfort. Alzheimer's care is not just emotionally exhausting, it's financially crippling. From October to December 2023, we spent $22,000 on home care for just 2 months. And that wasn't even 24/7 coverage. That cost exceeded the monthly cost of a nursing home, where meals and around-the-clock care were included. When my grandfather eventually transitioned into memory care, the financial strain only grew. $67,000 for 5 months at one nursing home, which is $13,000 per month. $48,000 for 4 months at another home for $12,000 per month. Families like mine will do whatever it takes to care for our loved ones, but it comes at an unbearable cost. The $2,000 program it barely scratches the surface, but this is still a lifeline. And as the New Hampshire Brain Health Public Awareness Campaign highlights this initiative, more families will discover this resource, meaning demand will rise. Without increased funding, many will be left without options. This issue is bigger than just my family. More than 11 million Americans provide unpaid care for a loved one with Alzheimer's, adding up to 18 billion hours of unpaid caregiving each year. The financial and emotional burden leads to devastating burnout. Nearly 60% of Alzheimer's caregivers report high levels of stress, anxiety, and depression. I urge you to support House Bill 704 and increase this funding because caregivers need care too. Thank you for your time.
Thank you. Any questions? Representative Nagel.
Thank you, Mr. Chair. Sorry for asking this, but how old did you say you are?
21.
Wow.
Yes.
Thank you very much.
Thank you.
Anyone else? Seeing no one else? Morning.
Good morning, Mr. Chairman and members of the committee. Thank you for taking the time to listen to us this morning. My name is John Zimba. I live in Epping. I am a lifelong resident of Rockingham County. I grew up in Newmarket, went to school in Newmarket, went to UNH, met my high school sweetheart in Newmarket, and we were married in Newmarket. We raised our family in Sandown, and the last 20 years have lived in Epping. Unfortunately, I lost my wife of 50 years to Alzheimer's in November 14th in 2022. I was her primary caregiver. A caregiver is someone who helps another person on daily activities or medical tasks. A generic definition, very nice, it's true. A primary caregiver for someone with Alzheimer's is much more than that. It's exhausting, it's ugly, and it's desperate. Those are the words that I would have to explain that. Think of an airline attendant telling you to put on your mask before helping those around you. And imagine there's only one mask and it's only good for your loved one. That's the example that I would give. Once I was so exhausted that I set the security alarm of my home, shut off my phone, and went to bed in hopes that my wife would get a few hours sleep. I would as well. I was awoken about 2 o'clock in the morning with the police at the bottom of my stairs with my wife. During the evening, she woke up, went downstairs, and proceeded to leave the house. The alarm went off, and it scared her, so she sat on the front steps. The alarm company called me, but my phone was off because I wasn't thinking. They called the police, and luckily the police came over and rectified the situation. That was quite alarming, quite honestly, because without the alarm system or without the care or without the quick response to the police department, my wife would have wandered off at 2 or 3 o'clock in the morning. During this time, I learned to take a shower in under 2 minutes, to brush my teeth while talking, to go to the bathroom with the door wide open, to take naps rather than restful sleep, and to pretend things were better than they actually were. Respite care is a temporary short-term service that provides relief to primary caregivers who are responsible for the ongoing care of a loved one with chronic illness, disability, or other health conditions. It allows the caregivers to take a break, recharge, and attend to their own needs. I was fortunate enough to have a couple of friends that helped me in that area. One very special friend took my wife once a week, every week. It allowed me to go grocery shopping, to run necessary errands, to go to medical appointments, dental appointments. I cannot begin to tell you how important that day was to me. Not to be confused with a vacation, respite care is desperately needed and much appreciated. Please support this bill. Thank you.
Thank you. Any questions? Representative Nagel.
Sorry, I have so many questions. Thank you, Mr. Chair. You've highlighted, the three of you and those before, you've highlighted a number of the problems that people incur by taking care of their family members. But I'm just curious, and this is very important to me because yesterday I actually took care of somebody that was injured. on a memory unit taking care of a combative patient. But I'm just curious, do you have any data on how many family members are actually injured by their loved ones and what the ramifications are of taking care of a combative person with Alzheimer's?
I don't have that data right now, but I'm certainly happy to look into it and see if we can track down that information for you. But I would, number of people who are living in their homes, those challenges, it's hard, as you alluded to, and as Olivia and John shared, people can be combative. It's such a horrible disease that really can result in that, and there is challenges with injuries and care.
Follow up.
Follow up.
So if somebody gets injured doing this, is there like a outside of respite, is there a fallback position or to help them because suddenly they don't have anybody?
For the primary caregiver who
Yeah.
was injured, not to my knowledge, no.
Other questions? Seeing none? Okay, thank you.
Thank you very much.
Also signed up to speak is Karen Hader, I believe it is. I don't know if I pronounced your last name right. Is it? Okay. Is it HATA, the last name?
Sorry, HATCE.
Oh, okay. Okay,
And Joseph Hatch, my husband.
thank you.
Good morning, everybody. My name's Karen Hatch, and this is my husband, Joseph Hatch. We live in Salem, New Hampshire, with our adult daughter, Michaela, who also experienced... Oh, sorry. Sorry about that. Sorry. Good morning. My name is Karen Hatch, and this is my husband, Joseph Hatch. We live in Salem, New Hampshire, with my adult daughter, Michaela, who experiences developmental disabilities and also requires 24/7 care. I'm a full-time caregiver for both my husband and my daughter. We appreciate the opportunity to testify today in favor of House Bill 704. My husband, Joe, experienced symptoms of Alzheimer's for several years prior to being diagnosed with that early onset Alzheimer's. In June of 2021, at the age of 56, he was diagnosed with early onset Alzheimer's. At the time, we were under the impression that it was going to be a slow process and we'd have time to prepare for the different aspects of the disease. But this was not the case for Joe. Sorry. He experienced a rapid motor decline. And in August of 2021, his job identified him as a safety risk, and he was no longer able to work. All the physical fun things that he was able to do, like snowmobiling, driving, making things out of metal, quickly disappeared in a matter of 3 years. And he is currently in the severe stages of Alzheimer's. And he needs 24/7 support in all aspects of life. Joe cannot be left alone. He's a wonderful person. He likes to come up and make a difference. I have trouble getting everything that is needed to be done around my house because he used to do a lot of things around my house with my daughter I take care of. And there's not much out there in the way of supporting someone so young with Alzheimer's to continue trying to live a quality life while keeping my house running. So I was at a loss what to do in the beginning and was so thankful when Tina Goulet from the Department of Health and Human Services contacted my family and told me about the respite program through ServiceLink and Gateways.
And I can't express the relief that it has been to get, we generally do 4 hours a week. My brother, who is retired, supports Joe, and he looks forward to it every Wednesday. As a matter of fact, he comes at 12 and takes him to the dump, to the grocery store, and they go out to lunch. And he looks forward to it as much as, you know, it benefits me. The respite, I'm able to do a little bit of housework and go to the gym to try to maintain my own health. This grant has served a twofold purpose. It's helped my husband maintain his strength by going into the community and building community around him, and also helps him to feel productive in the community. And it helps me to maintain my ability to take care of both him and my daughter. Currently, I receive $2,000 in respite, which lasts about 5 to 6 months. My brother, so what happens is when you apply for respite, you go through a company, which is Gateways and ServiceLink, and they will take a portion of it. So it's about, you get about $1,750. And my brother is paid $20 an hour. That helps to pay for like going out to lunch, taking him like the gas, the mileage. In the community, it lasts about 5 to 6 months. And most recently, because of my husband's decline, I have to get home modifications in my home. And so it puts me in a difficult situation to, like, I have to start funding my brother's to maintain the to maintain his ability to come to my house, along with getting a ramp, getting different things to help him be able to modulate in my home.
You could
So-
start, please start wrapping up, please.
Sorry?
If you could start wrapping up your
Sure.
testimony.
So I would hope that we would be able to access this grant year-round, and hoping that you would support this bill. Most recently, my husband participated in the ad campaign for early diagnosis, which we'll share with this legislative body, which illustrates how important it is to build community and to have a caregiver kind of free workforce, and hoping that you would support this bill, House Bill 704.
Thank you.
Thank you.
Are there any questions? Representative Nagel?
Thank you, Mr. Chair. Thanks for taking my question. Thanks for being here today. That's very nice of you. I had a question that something that you said really intrigued me. You said that they reached out to you. How did they find out about you?
I have my husband out in the community a lot, and I do a lot of things. Joe used to testify for different things relative to my daughter who is disabled, and I don't know how she learned about what was going on with my family. My husband had attempted to commit suicide when this first happened because of, you know, the way it was presented to him, and just basically a hopeless kind of disease. And so I do not know how she learned about that. And so, but it was a little bit of a security risk when he came back to the house, because it happened when I was on my walk in the morning. And so they helped me to put a security camera into my house. And I think that's how I learned of the respite program. I don't remember how she knew about it, you know. And so I was very grateful at the time that this was offered to help maintain my ability to keep my husband and my daughter both at home, you know, so appreciate that.
Representative McKay?
Thank you, Mr. Chairman. Would you believe how much as a committee we appreciate your coming today? This is not easy for you, and I understand that. And it helps us tremendously, at least I do, to support this legislation. Thank you very much for coming.
Representative Palazzo?
Thank you, Mr. Chairman, and thank you for taking my question. Can you talk to your experience of filing for this respite program. Like, did you have to, were there some requirements, like did you have to disclose your personal financial situation, or did you have to take any training to qualify this program, or was there any requirements making sure that you are vaccinated to be in this program?
No, there was no training. I think it's to help maintain your ability to, there is no training for this type of a disease. It's basically you're gonna learn it as you go. And the Alzheimer's Association helps a lot. They have a lot of videos on TV. They don't have a lot of support groups for people with early onset Alzheimer's. It's different. It's a different diagnosis because it's so young, and sometimes it happens quicker. I don't think there was, trying to remember, I had to apply for it, I believe. I had to do like an application for it. And, but I don't think there's a was there another question? I'm sorry if I'm not covering all your questions.
Generally, was it an easy process, and do you have like to file any reports like at the end of period? Is it easy program to apply?
You mean like any reports on what I do with him? You mean? No, I mean, they know I pretty much tell them. I do it with my daughter too. I developed a program so my husband can go out into the community and to be supported, to be able to, the community gets to know him, and they get to know, like you in the community, they get to know me, and they just will offer help sometimes, So it's a great way to get the community to know. A lot of times people get isolated in their homes, which is what's happened. A lot of people are afraid of the disease. It even happens with my brother. It's very difficult because as the disease progressive, you have to do all activities of daily living. And so when a person that doesn't have a lot of experience, because this is not, they're not making money, it's their time. So a lot of times the people they're not going to have experience in it, but it's like, instead of, like just keeping somebody at home or having them see somebody socially, it's really an important program to keep funded. And actually, it would be great to be able to do it throughout the whole year. The funding runs out, unfortunately, like in 5 to 6 months, because the company has to get paid a little bit to run the grant, So it makes it difficult. Like last week, the VNA people came because my husband's motor issues increased, and I have to bring all kinds of things into my house, like a ramp, like a Hoyer lift, and so we're just above. I worked when my husband had worked, so we're not, gonna qualify for like real poor. We're just right above that line, and but I have to budget because I also have a daughter that has 24/7 developmental disabilities as well, so I have to kind of take care of both of them in my home, and which is okay. But we appreciate the support that this offers because it helps me. Every tiny little bit helps to be able to sustain that. It's a long, like when they say it's a long journey, it's a long journey, and it's years of having to think outside the box.
But in terms of actual reporting, there's
Yeah.
not a lot of actual reporting you have to do, though.
Sorry?
You don't have to do a lot of actual reporting to.
No,
I think
which
that
is
was
appreciated.
That was Representative Palazzo's main question. So,
Oh, okay. Sorry.
Thank you.
That's
So
all right.
what, I can show you, I mean, if you guys need that type of thing,
Any
you
other
can come to
questions?
my house and I can show you
Any
what
other
happens every
questions?
day.
I'm
I
seeing no other
appreciate it.
questions, but thank you very much.
Yeah, thank you.
Best of luck.
Thank you.
Also signed up to speak is Judith Jones from New Futures.
Good morning. I'll keep my comments brief because the folks who have spoken today from their hearts have the best information for you. But I wanted to express my gratitude to this committee as you wrestle with these issues and have the expertise in policy and have had so many people come before you with complex problems. And happy to say that this bill in New Hampshire would provide direct benefit to individuals who are providing so much to New Hampshire. This bill is unique in that you're supporting individuals who've already given their time, commitment, and energy to the state of New Hampshire. You've heard some testimony about the need in New Hampshire, and I think of the word stunning. The need for these programs is stunning. If you were to ask me to choose just a few phrases, what captures the essence of these programs, the words that come to mind are well-established, proven track records, existing infrastructure, targeted to the needs of the local community, cost-effective, and the other word I have is common sense. These are common sense programs that are cost-effective. In my written testimony, what you'll find are some citations to studies that document the benefit of both of these programs. And also, of course, we're concerned about the cost of programs. And what you'll find in the written testimony is documentation regarding cost effectiveness. What you'll hear today in the testimony, what you've heard, and also through online words, is that the caregivers, they want to keep providing the care. They're here and they want to keep providing the care. What you'll hear about the senior volunteers is they're ready, they're skilled, and they're ready to fill that hole in the community. What we're asking for from this committee is to support House Bill 704. Thank you.
Thank you. Any questions? Okay, seeing no questions, thank you. Also signed up to speak is Roger DeRosiers from AARP.
Dear members of the House Health and Human Services Committee, my name is Roger DeRosier, and I'm here today on behalf of AARP New Hampshire. We want to express our strong support for House Bill 704. This bill represents a critical investment in the well-being of older adults and caregivers in New Hampshire. AARP supports House Bill 704 because it funds well-established programs that provide immediate assistance to families and helps fill the gaps in New Hampshire's long-term service and support system. These programs are essential for enabling older adults to remain in their communities, which is not only beneficial for the well-being, but also a wise use of resources. Investing in programs that support older adults and caregivers can delay or avoid the need for more costly long-term support services. The targeted programs under House Bill 704 include caregiver respite programs. These provide respite services for Alzheimer's disease and related disorders, offering much-needed relief to caregivers. Also, AmeriCorps senior volunteer programs. These include the Senior Companions, Foster Grandparent Program, and Retired Senior Volunteer Program, which provide invaluable support to older adults. Funding these programs is a smart investment for New Hampshire. By enabling older adults to remain at home and in their communities, we can reduce the demand for more expensive nursing home care. For example, getting a ride to a medical appointment or having access to respite care can mean the difference between remaining at home or needing institutional care. One program reported a 50% increase in requests for rides last year, highlighting the growing need for these services. As a caregiver for over 15 years, I can personally attest to the need for respite services. It helps sustain the caregiver and helps maintain an older adult in their home as long as possible. My dad died of Alzheimer's at age 97. In conclusion, House Bill 704 is a crucial step towards supporting our older adults and caregivers, ensuring that they have the resources they need to thrive in their communities. AARP New Hampshire urges you to support this bill and make this important investment in the future of New Hampshire. Thank you for your time and consideration.
Thank you. Any questions? I'm seeing none. Thank you.
Thank you.
Also signed up to speak is Kathleen Stewart.
Good morning, everyone. My name is Kathleen Stewart. I am the program manager for the AmeriCorps Senior Companion Program. We are one of the 3 AmeriCorps Seniors programs described today. Lily Wellington directs the RSVP and the foster grandparent. We are the Senior Companion Program. And our volunteers are all older adults over the age of 55 that receive an hourly stipend and mileage reimbursement to go into the homes of homebound seniors to provide companionship, and also rides to doctor's appointments and for groceries and maybe just out for lunch. Lastly, and very important, as we've heard a lot this morning, we provide respite to caregivers. So our volunteers are older adults that they're not trained to provide any hands-on care, but they can provide respite to caregivers who might just want to take a nap or mow the lawn or maybe go out and tend to their own medical needs. So there are so many things that I'd like to talk about today that we don't have time for. First, the health benefits of volunteering later in life. There's been a lot of research about how volunteering over in your 50s and above provides all kinds of health benefits. It gives our volunteers a sense of purpose. It also is a big cost savings, as we've discussed earlier today, and the list goes on. But there's also the numbers involved. For 50 years, approximately, our program has partnered with CAP in Concord, Belknap Merrimack CAP, to provide transportation, respite, and companionship to New Hampshire residents for nearly 50 years. Last fiscal year, we provided 32,827 hours of companionship to 343 homebound residents of New Hampshire. These aren't just numbers. These are 343 people who would otherwise most likely have little to no human interaction or access to the community. 343 people who, without the support of our program, may not have had enough food to get through the week, or access to routine medical appointments or prescribed medications. These 32,827 hours are life-sustaining, yes, but they are so much more. They are a few hours every week where the primary focus is the person, making them smile, making them laugh, reminding them that someone in the world cares about them, their existence, and their happiness matters. On the other side of things, we do the respite piece. 4,968 hours of respite was provided to caregivers in the state of New Hampshire at no cost. These hours provide caregivers the opportunity to tend to their own medical needs, to, like I said, mow the lawn, take a nap. These little small breaks in time are essential to these caregivers, as we've heard again this morning many times. And also our program contributes to their well-being and their preventing them to burnout, caregiver burnout.
Okay, thank you. Any questions? Seeing none, thank you. Also signed up to speak is Kay Taylor from the Foster Grandparent Program. Good morning.
Good morning. My name is Kay Taylor. I'm a foster grandparent. This is my 8th year in the program. The program means a lot in many different ways. I tried retirement, wasn't for me. I needed something to do and I needed a purpose. I'm currently at Beaver Meadows School. I'm split between a kindergarten class with 16 kids and a second grade class with 14 kids. The teachers all love and appreciate the help, and it's very rewarding to be with the kids, to see the smiles on their little faces. You walk in the morning, you know, they come running up, Grammy Kay, they want hugs. We do a lot of different things in the school. We help, maybe you've got a child that needs a little extra help in learning to write their letters, or maybe they just want to play a math game with you, give them some one-on-one time. A lot of our students nowadays don't have that at home. This helps them emotionally, and they appreciate your involvement in their lives. I, for one, like to bake. I'll bake mini muffins and take in for the kids. They're very appreciative. I had one child tell me they had never had a homemade muffin. For me, it has helped both emotional and physical health-wise. I get up in the morning, I know I've got somewhere to go and help the students and the teachers. In October of 23, I received an award from Spirit of New Hampshire for my work with the foster grandparent program. And I plan to stay in the program as long as I am physically and mentally capable. And I hope that you will seriously consider this and make this part of Bill 704.
Okay, thank you. Any questions? Okay, thank you, ma'am. Also signed up to speak is Kevin Moore.
Good morning, members. My name is Kevin Moore. I'm here to support 704. I have dealt with a family member who had Alzheimer's. I was trying to get him help in Claremont, New Hampshire, and he declined really bad. Ended up in Sullivan County Nursing Home, which was really wonderful to him. He could not live on his own. He was wandering around in Claremont. He got to Sullivan County. I went to visit him. He had no clue who I was. He actually raised me as a child growing up. And this bill is really important. I would encourage you all to deeply ask yourself, what does it mean to you? Because I'm sure you all must have someone struggling. And I would ask that you all would highly take this bill seriously. Thank you.
Thank you. No one else has signed up to testify. Before I close the public hearing, does anyone else wish to testify? Seeing no one, I am going to close the public hearing on HB 704 FNA and open the public hearing on 743 FN and recognize the prime sponsor, Representative Julia Sodi. And pink card is coming. Great, thank you. Okay, Representative Sodi.
Yeah.
Thank you for your patience.
Good morning, committee members. For the record, I'm Representative Julius Soti from Windham, also representing Londonderry. And, well, this is HB 743. This bill is looking to get some upfront pricing and also some pricing transparency, which the federal law requires. And I've had a few constituents who've also been, complained to me about this matter, not the least of which is my wife as well. One of my constituents writes that he got a $1,800 bill with no details, no clues what it's for. Leads to a very awkward situation when you have to call them up and battle after the fact of what's going on. What other industry gets away with this? Can you imagine a contractor building your house and then sending you the bill when it's all done later? Totally intolerable. So the bill you have in front of you is, inspired by the bill that passed in Maine bipartisanly. I asked OLS to rewrite it to maybe work for New Hampshire. I've already got some criticism about it, that it doesn't go far enough. So there's other states out there that have also done this kind of stuff. Rhode Island, Florida, Colorado. And I'd also like to point out that on the federal level, there's some more stuff coming down the pike, which gives some price transparency to every aspect of the medical community, all the way down to your doctor's office. And I think that's being inspired by Bernie Sanders, of all people. So I would suggest that maybe we could get out front on this issue. And with that, I think I'm done.
Any questions for Representative Sodi? Representative Nagel?
Thank you, Mr. Chair. Thanks for taking my question. Thank you for bringing up this topic. It's a really important one. I just had two questions, actually. What does this bill accomplish that federal law does not accomplish now?
Well, right now, it's woefully inadequate what's going on because you're not getting the prices up front. In fact, the testimony that's going to follow from my wife will be some extra examples of that. So I don't want to spoil that testimony yet.
Can I ask a follow-up?
Follow-up.
I'm just curious, why were pharmacists excluded from this?
Oh, I think there's some other bills that some other representatives are going to be working on that are going to be putting that in.
Other questions? Representative McLean?
Thank you, Mr. Chair, and thank you for taking my question. So, you say that this bill passed in Maine, but also that there are versions in Rhode Island, Colorado, and Florida.
Yeah.
How long has that? How long has that been the case? I'm assuming Maine is just very recent.
Yes, it is.
What about these other states? Can you give us some history maybe there?
Rhode Island is pretty recent as well, and I think they're all pretty recent, actually.
Okay. Follow-up question, Mr. Chair?
Follow-up.
Thank you, Mr. Chair. So have you spoken to anybody in the insurance department, or because I noticed that the first part of it kind of builds on the federal no surprises law for the uninsured, but there are certain mandates that you're putting in on the insurance companies, and I was just wondering if the insurance department had any feedback.
Oh, they're coming up. They're here.
Oh, thank
I've
you.
already got some
I'll
complaints.
hold
yeah.
fire. Thank you.
Other questions? Seeing no other questions, thank you. Also signed up to speak is Ben Bradley from the New Hampshire Hospital Association.
Thank you, Mr. Chairman and members of the committee. For the record, my name is Ben Bradley. I represent all 26 hospitals in the state of New Hampshire, as well as all specialty hospitals. We appreciate this opportunity to discuss HB 743. We are opposed to the bill, not because we oppose patient access to healthcare prices and billing practices, but because the bill is redundant and could create conflicting standards between federal and state law in a way that duplicates federal requirements for transparency and increases regulatory burden and cost on healthcare services and patients. Federal hospital price transparency rules went into effect on January 1, 2021, and require all hospitals to make available on their websites a single machine-readable digital file containing the standard charges for all items and services provided by a hospital. Federal regulations also give hospitals two options to let consumers determine their potential out-of-pocket costs for common services: an interactive price estimator tool or a static spreadsheet listing 300 common services. Those regulations are required by federal law and are enforced by the Centers for Medicare and Medicaid Services, CMS. I also want to point out New Hampshire led the nation several years ago when the Department of Insurance first published the comprehensive New Hampshire Health Cost website, which allows consumers to compare prices for various procedures across several providers, including hospitals. Contrary to the comments from advocates supporting this legislation in previous years, in New Hampshire, there are several ways for patients to view costs for services and receive a good faith estimate of those services prior to receiving care, as already required by federal regulations. While some advocates for this bill claim the legislation is necessary due to lack of enforcement and negligible fines on hospitals, data from CMS available publicly on their website shows exactly the opposite. Anyone can go on the CMS website and view the thousands of compliance notifications and fines imposed by CMS across the country since the rule took effect. This bill resembles HB 389 from last legislative session that was ITL'd by the House on the consent calendar. In previous testimony, advocates said the purpose of the bill is to hold hospitals accountable for not complying with federal law. As noted, CMS is the arbiter of compliance for these regulations, and we ask why duplicate efforts that would require state investments for the Department of Health and Human Services to do investigations into hospitals' compliance with federal transparency regulations when CMS is already doing that. Advocates for this bill have also highlighted that other states have enacted similar legislation. I've talked to my colleagues in other states around the country. One in particular said their Department of Health and Human Services has not received a single complaint for noncompliance with federal transparency regulations since their state law passed. This is a solution in search of a problem that does not exist. I've included additional material with my testimony that you may find helpful when considering this bill. During the summer of 2022, our hospitals began receiving emails from a national special interest group called patientrightsadvocates.org, making misleading claims about individual hospitals' compliance with the Federal No Surprises Act. These claims are false. I've attached a chart that shows the inconsistency and inaccurate criteria used by the special interest group in their analysis of hospital compliance with the NSA, and they do not use the same requirements in their analysis. For these reasons, we cannot support HB 743, and I'd be happy to answer any questions. Thank you, Mr. Chairman.
Thank you. Any questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, just it's my understanding that No Surprises does a lot, for the uninsured and stuff like that. But if you are insured, like an employer insured, like a lot of people, you don't get the same kind of quoting and things like that. So with the tools that we have set up in the state already, could you maybe walk me through a scenario where a person who maybe is going in for hip surgery, for example, but they have employer-based insurance, how are they, what mode would they take to go through to get the upfront pricing that they needed? So they're not uninsured, but they have employer-based insurance. Maybe just kind of walk us through what
Certainly.
that path might look like.
Thank you for the question, Representative. Sorry for rifling through my testimony. I really just wanted to make sure I got it on the record, and I appreciate the opportunity to discuss this further. New Hampshire has done a great job of establishing a health cost website through the Department of Insurance. It does afford an ability for patients to compare prices across multiple providers, and they can select whether they are insured, who their insurance provider is, and or whether they're uninsured. And it will provide estimates across several procedures, several common procedures that patients can filter through, select multiple providers that are included in that database, and then get an estimate for what that cost could be even out of pocket. I believe the Department of Insurance is here, and they may be able to speak more into the capabilities of that platform. I think it is actually probably even more useful than the federal resources that are a static spreadsheet or their price estimator tool. So this is really local. This is focused on what's going on here in New Hampshire, and I would just point patients to that, as well as our providers at hospitals who are required to provide a good faith estimate of the expected costs for those services if they are uninsured.
Follow up.
Thank you, and thank you for taking my question. So, and I'm aware of the cost estimator on the government website. But one of the things about No Surprises, it's my understanding, is that it has teeth because if the quote is provided and the final bill comes in and it has absolutely no relation to what the quote was, that there's the patient is really going to be insulated a little bit from that. Can you speak a little bit to, with the state website, is there anything binding if a provider really goes far off pace from that, from what is being put out on the website? Thank you.
I don't know the answer to that specific question, but I do want to hit on the No Surprises Act legislation at the federal level, because CMS does say that if the estimated amount is a difference of $400, one way or another, then you can dispute that price compared to the estimate that you received. You can dispute the cost if it is in excess of $400, and that then has binding expectations for the provider who provided that good faith estimate.
Other questions? Seeing none. Thank
Thanks,
you.
Senator.
Also signed up to speak is Adrian Sodi.
Red. All right. Hello, everybody. As you know, I am Julia Sodi, the primary sponsor's wife living in Windham, New Hampshire. Before I begin my testimony, I would like to quickly address actually some of the points that the Hospital Association Representative Ben Bradley just brought forward. He mentioned that consumers nowadays have multiple avenues of getting to the prices, healthcare prices, and he mentioned that website established by the Insurance Commission. Just recently, I was on that website to look for how much a particular procedure costs, which is also a matter of legislative action recently. Circumcision was not listed in there. I don't know if he can find it. I put in the word, and that's a pretty common procedure, and no price has come up on that. Another thing that women unfortunately often encounter is hysterectomy. I put in the word, nothing came up. Another procedure that I actually recently had, which I will include in my testimony, was a breast MRI. Women with dense breasts often get a breast MRI. That would be the most definitive test to determine if they have any cancer. In addition to a mammogram and an ultrasound, nothing came up on that website. I don't know if I'm doing anything wrong, but I have looked at other procedures that have come up. These have not. So just to bring that up, and what this bill would accomplish that the federal doesn't, I assume also is to provide the information to patients that they can request this, that this actually would be displayed in hospitals. Very often, patients have no idea what the federal law is. I myself didn't find out about this until recently when somebody brought to my attention Dr. Marty McCarry, who's a hot thing nowadays, who has written Blind Spots in Medicine. He also has written Unaccountable and The Price We Pay, books that I've all listened to, which all address this issue. And he was behind the federal law, which fortunately has passed. Mr. Bradley has referred to the patient advocacy organization. as a special interest group, which I have also found, and I find that they are volunteers who are doing an amazing job. I have also printed that list, which he calls misleading. I don't know, maybe that's something the committee should look into. Who am I to say if it is misleading or not? But it says New Hampshire's largest hospitals are listed over there as non-compliant on pricing data sufficiency rating, perhaps for the same reason where, which I just mentioned, that the other website has, that you can't find all the procedures. Or what I found in one, well, the 3 minute went by fast. in one situation, they say that the details are not available. So it's sort of like a caveat. There is the list, but they say, sorry, we don't have the details of the price. So something for the committee to look into. Am I able to take a few more minutes?
That was your testimony.
Okay.
If you have a written copy, we're happy to
Okay.
put it on record and or if you want to submit copies online or whatever.
Thank you.
But are there any questions for Mrs. Sylvie? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. Your husband mentioned that you had gotten into a bill dispute with the insurance company, and that it was difficult because you didn't have a breakdown of all the different items. And so it's very difficult to dispute something because I just have an overall. Did you go back and require or request a breakdown and it was not offered, or what was the situation with that? 'Cause I do
So-
think they have to provide a breakdown
Yes,
list. do they
yes,
not?
yes. And I think he was actually referring to another constituent who had that issue recently. I personally had that issue, and yes, once you request it, they will send you an itemized list. In my particular case, what they are billing me, and actually what I'm in collection for, is the doctor's reading fee. So a radiologist's fee for that breast MRI, which I had done, which Salem Radiology, the company I went to find out how much I would pay for this, as a self-pay, because insurance said they wouldn't cover it. Now they said they have a policy that if you have insurance, even if insurance decides not to cover it, you have to use your insurance. So they wouldn't give me a price at first. The technician told me, oh, if you are self-paid, did you know how expensive this procedure is? I said, yeah, probably about $1,000. I'm prepared to pay that. He's like, no, this is $9,000. I'm like, are you kidding me? So I got dressed and left and called my insurance company and said, I have to go through you. How much am I going to be liable for? And they said, we have no idea. You have to ask the provider. I said, how come the provider is not telling me? You don't know it. Could you help me? Could you call the provider to get this price? So they were on the phone with me, and they called a number of providers, some of which they couldn't reach, just like I couldn't. They wouldn't pick up the phone. They left a message. And so what I ended up doing, going into Salem Radiology, sitting down and finding a person who could actually give me a quote. They said, it's going to be $400. Big difference between $9,000 and $400. I was like, oh, sure, I'm ready for that. I'm going in for that procedure. They said, if you pay now, we even give you a 10% discount. And I said, okay, great. So here's the money. Do I owe you something for the radiologist? I'm sure there's going to be a radiologist involved. Oh, we have no clue about that. I thought there was a law. It is part of this bill that any radiologist or basically additional third-party provider will have to be displayed, or what is the word, so that the patient knows who that person is, so that at least if they don't know the price, I could call them up and say, how much are you going to charge? Interestingly, that $200 is in collection, and I just found out most people have no idea there is a law against that. So I have no idea how to fight it. So now I'm going to call the collection agency and say, New Hampshire has this law. You can't ask me for this money because nobody told me about it. Is that right? So.
Other questions?
Thank you.
Representative Weber.
Have you ever contacted the insurance department about resolving this dispute?
No, I have no idea how to access them. I don't know. Is their phone number? Do I just type into Google New Hampshire Insurance Department and that would pop up?
And would you believe that my understanding is there's somebody who's going to testify from them, but they have a very extensive website.
Yeah. Yeah, so most people, I consider myself pretty educated in health matters and being able to advocate for myself, and I had no idea. So I think the average person has no clue that they have options, that they're supposed to be given prices, that it is the federal law. They don't know. So are there notices? And one thing I wanted to mention about an ambulance fee that I got charged, it was over $4,000 for something that could have been completely avoided because I had my car and I was able to drive. But at that point, I was already in Parkland Medical's computer system, and they needed to transport me to Portsmouth Hospital. And they said, we would prefer you take the ambulance because now you're in our system, we don't have to re-register you. Nobody told me how much it was going to be. And even though the insurance paid over $3,000, they wanted to collect the $1,500 leftover, which I fought and they waived it. But what a waste of resources, even for the insurance company. I could have just driven and saved that money, and an insurance cost would be much less.
Other questions? Seeing no other questions. Thank you.
Thank you.
And speaking of the New Hampshire Insurance Department, Jason Azis from NHID, which I believe stands for New Hampshire Insurance Department. So,
Good morning, Mr. Chair, Committee. My name's Jason Azes, Director of Health Economics at NHID, or the New Hampshire Insurance Department. It's so nice to see your beautiful faces and smiles today. Thank you for the opportunity. The Insurance Department has no formal position on this bill.
excuse me, can everybody hear him okay? A little closer. Could you move the?
So the Insurance Department is neutral on this bill. As a note, there is another House Bill 705, that is within our oversight and authority. It's about price transparency. And our data unit at the Insurance Department, our central focus is healthcare price transparency. And the woman previously testifying delineated a plethora of different issues with that. And we concur it is indeed a thicket of perplexing price information, oftentimes inaccurate, that the average consumer, it's not plausible that they can navigate through that. So we acknowledge that as a problem. It's noteworthy that there are indeed two federal laws, one pertaining to hospitals and one pertaining to health insurers, that necessarily are organized like that to kind of help patients and analysts and regulators like us understand what you might expect to pay when you have a real encounter versus just reference pricing, which has lower utility for the patient and oversight individuals. Our New Hampshire Health Cost website, which is referenced in this bill, I think there's some misunderstandings about how prices get reported on there. It's a very different criteria compared to what both federal rules require for hospitals and insurers to post. The CMS, it used to be the CMS 50, it turned into the CMS 300, and now it's actually the CMS 500 medical services that meet the eligibility requirement to be reportable on those transparency mechanisms, whether they're the consumer-friendly mechanisms on their website or these machine-readable files, which the federal rules also require for both entities to report. The machine-readable files are not consumable by our public. They're really for analysts, researchers, and regulators to essentially serve as a validation data set or reconciliatory data set to ensure that using other more empirical observational data like the claims data, that there's fidelity in billing with what the self-reported data from these federal requirements pose. So that's important to understand, and it's really a key limitation of these machine-readable files. Those are self-reported by entities on what they say that they charge. The claims data is empirical, it's observational, it's what the patient is actually exposed to. It's, if you can contextualize what I'm trying to say, is they're not always equal. In fact, the insurance department's primary interest in getting the transparency and coverage data from insurers is to validate that there's great fidelity in that and what the patient might see, what they can expect to pay, and what they actually pay. But I did just want to make note
If you could
on-
start wrapping up though, please.
on the section that points out the New Hampshire Health Cost website, that is probably not comparable with regards to serving the consumer on all of the different services that are delineated in the hospital price transparency legislation, which I think this seems to parallel. With that, I'll end there if you have any questions.
Okay, thank you, Representative Weber.
Thank you, Mr. Chair, and thank you for taking my question. At the beginning of your testimony, you referenced a different bill on price transparency. Could you give me that number again? And is that a bill before the legislature right now, or is that one that we passed previously?
Currently being heard right now, House Bill 705.
705, thank you.
That regards insurance carriers, not hospital providers. I think to mirror the federal approach, it might be most suitable to keep those mutually exclusive from each other.
Thank you.
Other questions, Representative Woods?
Thank you, Mr. Chair, and thank you for taking my question. Sometimes getting data down to the public is difficult. You've alluded to that. And just to point out, and maybe you could help identify how the disparity, because and you mentioned the word charges versus reimbursement. And a particular entity may charge X for a procedure, but after negotiations are completed, accept far lower. As those two numbers sometimes really don't jive. And how is that sorted out for the person who's trying to find out what I'm exposed to?
Thank you for the question, and it's a good one, a complex one. One thing we aim to do on New Hampshire Health Costs is to do that. We stratify by insurer, type of insurance, including the uninsured, as Mr. Bradley said, as well as by provider. And tangentially, the transparency and coverage files from the insurers also are required to have 3 files: in-network negotiated rates, out-of-network maximum charge amounts, and a prescription drug file. The significance of that is that network status is a key driver to cost exposure to a patient. So if a provider is in network, they will have a contract and a negotiated allowed amount. That's the maximum amount that a provider will be required to pay for any given service. Services are classified by codes, billing codes, usually CPT codes or HCPCS codes. But so the negotiated amounts are the best approximation to the cost that a patient will be exposed to. And that's one, albeit not a perfect, but one of the most precise approaches to informing patient populations about the economics of healthcare encounters.
Other questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, we heard a lot of discussion from the Hospital Association about the state website and the amount of transparency that it provides. But your understanding of the role of that website, if I understand you correctly, is not that it is going to be giving you cost information in the same way that No Surprises would give cost information to the uninsured who are requesting a quote. It has a completely different role. Am I correct in that, your assessment of what that is?
You're really smart about insurance. Everything I've heard you say just shows how much insight you have. I agree mostly with that. I think one key thing to point out, our responsibility with New Hampshire Health Costs is, in fact, that to be responsible in publishing claims-based price estimates that are very stable. What we notice is wild price variability with providers for any given service. It's astonishing to see for any given individual CPT code, individual healthcare service, how wildly variable the prices are. That's the essence of the issue. The these other advents to communicate price information, they do not use claims-based data to do that. They use contractually based self-reported information, which presumably within each entity will not vary nearly as widely as the claims-based approach. So there's advantages and disadvantages to each. And I think after having heard some of the testimony from people from the public and members, from the hospital association, we probably can do a better job communicating that to the reader, the nature of these data and how to best interpret them to get a sense for, what their true exposure to cost implications from an individual healthcare encounter might be. But we publish the median paid amount for services that are rather ubiquitous in the state of New Hampshire. We oftentimes find ourselves censoring certain services because they start to not meet the condition of what we call kurtosis, or essentially wild price variability. We want a very narrow range of variation in the price. And when we can't ensure that, we can't responsibly share that with the New Hampshire or American public. And that's important to us that way.
Follow up.
So I think then that might be why a hysterectomy, for example, which was cited earlier, was not included on the list. But just as a different question, obviously you have no position on this bill, but is there anything about this bill that would potentially jeopardize the insurance market in New Hampshire? Do you see any concerns from the insurers about that they see red flags with respect to their ability or to deliver service in the state?
Thank you for your question. The only thing I would point out is what I previously mentioned, that there's the section on here that relates to insurance carrier price transparency. And given the fact that there already is a current bill and that the federal government has chosen to bifurcate the two entities, and rightfully so, I wholly believe in the credence of that we should aim to do the same in this state. I do laud Representative Sodi's efforts on this and think that state authority to oversee, ensure, and at times, if necessary, enforce non-compliance with these reporting standards. I think that there's merit in that. I wholly agree with Mr. Bradley's commentary about CMS reporting their non-compliance issues, and there is rather modest, if little at all, enforcement action taken on. I know 2 hospitals in Georgia had last year been fined mightily, might I say, but I think that different than how I think a lot about government, this is a good example of how state authority might better serve the citizenry, because we have a more intimate knowledge of the healthcare delivery system, and we could act more swiftly and I think have sufficient resources to ensure stronger compliance from both hospitals and insurers. And taken together, that's I'm very optimistic that there is credence here. So I think that if we separated the 2 bills and we're fortunate enough to see them move forward, then that could help citizens and the work that we do and the New Hampshire Hospital Association does.
Representative Weber. Representative Lucas, did you still have a question, or?
Representative McLean addressed my question. Thank you.
Thank you. Representative Weber.
Thank you. So if a consumer has a concern about the payments made under their employer insurance or other insurance, do you have in the insurance department, because I'm far less familiar than is my colleague to my right, do you assist people who are in dispute with their insurance carriers or healthcare providers, and is some kind of ombudsman or consumer protection available through your department?
Thank you for your question. Yes, oftentimes, multiple times a week, we get, through our Consumer Services Division, citizens call, and providers sometimes call in with grievances about those disparities. And we use many different data sets to help investigate And oftentimes it really comes down to educating the patient, the citizen. And it's not always a comfortable situation because, ouch, I mean, I'm hearing the work that we do every day to be responsible about communicating price information on New Hampshire health cost. I'm hearing that get criticized, and we become conditioned to that criticism because we've learned that it's a very challenging economic and financial construct to educate people on, and we're never dealing with people who are happy at the moment with the insurance department nor the healthcare delivery system. So we use the claims data, and we've been successful with both the transparency and coverage data and from insurers and the hospital price transparency data, finding their self-reported reference charges and comparing them to what the patient has seen on New Hampshire health cost to validate and reconcile that. And so there's high utility for us.
Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question. This is going to be wicked complex. I'm sorry. I'm a dinosaur. I've been in private practice for 35 years. The guy next to me is even more of a dinosaur, as I think you know. But anyway, I felt a need to say that. This bill really strikes a nerve with me because it's a big problem. It's forced me to do something I really don't want to do. I have to look at the insurance status of all my patients, which I really don't like doing. We're seeing a number of trends, and I think it's a good thing, but there are unintended consequences to everything. Prior authorization is a good thing. However, now I have an entire department in my office that does nothing but prior authorization, which creates cost for me and the patient and the system. Workers' compensation, same thing. IT, same thing. The reality is the dollar amount for each patient is patient-centered. It's very individual, and every patient's circumstances are different. So now we have to have a department that will talk to each individual patient at great cost. What do you see as the ramifications to cost to the system of doing this, and are there better ways to do this?
Thank you. And indeed, I agree that is a complex question. So, economic theory might posit such that the reason why that price variation exists so mightily and is in fact a problem for the whole healthcare system is the fact that we have very little price awareness, and ensuing to that is very little price sensitivity. Price sensitivity is a concept where people will seek out lower cost alternatives, holding quality constant, if they're aware of prices. We do it in all segments of our economy. And healthcare is just one of the segments where we don't do that. And I argue one of the main reasons why is because why would we if we have no idea what the price is? There's no underlying financial incentive or motivation for us to do that. So in economics too, we have short run, intermediate, and then long run effects. What you're talking about to make it better, I perceive as a long run economic effect of making all modicums of transparency available to the system so that people can get more price aware and more price sensitive. It's not going to happen in next legislative session. See, we passed these bills and the prices are the same. I knew that wouldn't work. That's not something that we should ever expect by the power of our pens in this room. Rather, we need to start incrementally and systematically making people and making entities more transparent about the prices. And over time, I think a lot of my colleagues nationwide who I work on these same endeavors think that holistically price transparency will make our system function more optimally. And that's important. It's a thoughtful question. And that's how I think of it. It's really the long run effect of multiple iterations in multiple sectors of the healthcare industry being more transparent. It's astonishing that we don't know what we're going to pay. If you go to any supermarket that has over 180,000 distinct units with distinct prices, we know within the 5-cent increment what we're going to pay. Gasoline is within the 0.9 of a cent increment what we're going to pay. Yet for something so important as healthcare, even people who are health policy experts that work on this daily don't know what they're going to pay until 3 months later when they get that hyperbolic bill. This endeavor may aim to offer relief and transparency.
follow-up?
A follow-up,
Is
Representative
it
Nagel?
fair to say then, we're looking at a short-term increase in cost for a long-term decrease in cost?
It's not unfair to say that. I think the magnitude, everything comes with a cost. Our healthcare system comes with mighty cost. I'll refer you to the insurance department's total healthcare expenditure model that we just published in our fall annual hearing that showed $13.2 billion in the small state of New Hampshire for total healthcare expenditures, $9,331 per capita. So if you're looking at the marginal cost of compliance for price transparency at the insurer level and at the hospital provider level, the marginal cost compared to the absolute cost of $13.2 billion is negligible. So that's a cost that I would be, I'm a free market conservative person and think much about incurring costs that's unnecessary. Had I thought that about this, I wouldn't have it in my heart to be able to sit here in front of you nice folks doing this great work and say that, yeah, we should do this. I would encourage otherwise. But so it's worth the cost and it's really important.
Representative Weber and then Representative Woods.
Thank you, and thank you for taking my question. And I would very much like a very short answer to this. Listening to you just now, I am remembering back that at the beginning of the testimony, you said you were neutral. And it sounded very much to me by the time that you were finished talking just recently, you were far more positive than what I would consider neutral, given, with the exception of your point about divorcing the two different components of the bill. So is the department in fact neutral, or do you in fact think this is something we should go ahead with?
I'm neutral on this bill as it pertains to hospital entities for which the insurance department has no authority over. So.
Follow-up.
Well, but you stated you were neutral on the bill. Is the department supporting the other part of the bill, or is the department neutral on the other part of the bill?
The other part of this bill, or the House Bill 705? that
I'm
you asked about?
asking, all I'm trying to do is write down on my piece of paper in front of me whether the department supports the bill or doesn't support the bill. And it sounds like you support one part of the bill and are neutral on the other. I just want to write it down the right way so I'm not misrepresenting the department's position. If you're neutral on everything, that's fine. If you're supporting part and not supporting part, that's fine.
Thank you, Representative Weber. I'm just asking you to be clear because I mentioned House Bill 705. That's an insurance department bill. We encourage the legislator to sponsor this bill. We're neutral on this bill. With the one exception is the part about the insurance. I would suggest we censor that from this, given that it's probably not in the appropriate statute and might better be served to be communicated in House Bill 705, which indeed it is. It sits redundantly in this bill. Thank you for the question.
Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. This is very short, but given the complexity and the inroads that goes into almost every aspect of medical care, how much of this would be obviated if we had single payer?
That's beyond the limits of my knowledge. That's a thoughtful question, but extends beyond the limits of my knowledge. Yeah.
Other questions? Seeing no other questions. Thank you, sir.
Thank you so much.
No one else has signed up to testify on HB 743 FN. Does anyone else wish to testify? Seeing no one, I am going to close the public hearing on this bill and open the public hearing on HB 524 FN and recognize the prime sponsor, Representative Granger.
Thank you, Mr. Chair and members of the committee. I'm going to be introducing this with Laura here. You should have her pink card up there as well. This bill repeals the Vaccine Association, and the primary reason to do that is to save a large amount of money. Because right now, the state is spending a lot of money on this vaccine association for alleged cost savings that aren't actually there. And therefore, I will turn it over to Laura, who has been on the board of the Vaccine Association in the past and can speak much more fluently on it than I can.
Good morning, Chairman McDonald and committee members. I support this bill. I do not believe that DHHS should be in the business of buying and selling vaccines for commercially insured children through the Vaccine Association. And I support repeal the law that created this costly and unnecessary association. It is best to remove government from involvement in the purchase of medical products when private business does quite well and cost effectively for vaccines for adults. In fact, the legislature rejected a bill not too long ago as too costly, unnecessary growth of government that would have swept in the purchase of adult vaccines into this program. It is especially timely at this time of significant budget crisis that legislators support the governor and look to programs that are costing taxpayer dollars that can be better done by private industry. It's time to shrink unnecessary government and vote to pass HB 524. By way of background, I am a volunteer New Hampshire Director of Advocacy with the National Vaccine Information Center, a position I've had since 2011. I work to educate the public on vaccine policy and law and advocate for informed voluntary consent. I have attended the New Hampshire Vaccine Association board meetings for probably about 15 years. In June of 2014, I was appointed by the Senate President to serve as a public member on the board, a position I served in for 5 years. I have remained a committed attendee and active commentator at all board meetings. During my time on the board, I worked on the board to adopt common sense best practices and push for greater transparency and disclosure to the public with regard to vaccine purchases and practices of DHHS and this association. I had some successes, but in recent years have found that DHHS and the board have not only backtracked on those measures, but are now actively withholding information from the public about this program, their practices and expenditures. I was actually bounced from the board in 2019 and replaced by an industry insider, a Rite Aid pharmacist, hardly representative of the public interest. You know someone is up to no good when they work extra hard to avoid transparency and disclosure. Any quasi-government association that seeks to shut out the public from truthful and proper disclosure of policies and spending deserves to be eliminated. You know someone is up to no good when they work extra hard to avoid transparency and disclosure. Why do we even have this vaccine association? In 2002, RSA 126Q became law based on the false premise that government can do this cheaper than private industry. It was based on the false representation that vaccines purchased through the CDC and the federal Vaccines for Children contract was a savings on vaccines compared to market pricing. But market pricing is just like manufacturers suggest a retail price on a car. No one is actually paying that price. In fact, vaccine providers in New Hampshire all purchase vaccines for adults through very cost-effective group purchasing organizations and manufacturer discount programs without the unnecessary costs of government involvement, saving up to 60% depending on the vaccine. Interestingly, at the same time this original legislation was being passed, a new private business was created to offer administrative services to run this association and was awarded a multi-year no-bid contract that repeated for 16 years. This private business worked to pass similar legislation in 5 other states, where it also secured the contract for administrative services. Beyond this, and a study was done that shows other states have looked into this model and have rejected it resoundingly as unnecessarily and too costly. So what will this bill do? Because there's a lot, I've seen the comments online, a lot of confusion about what this association is and what this bill will do and won't do. What it will do, it will save money by removing government employees and costs from the ordering, purchasing, distribution, marketing, and monitoring of vaccines purchased for commercially insured children. The New Hampshire Vaccine Association will claim their administrative costs are a small percentage of the cost of vaccine purchases, and that's true. But that claim completely ignores the staff at DHHS involved on this board working to purchase, distribute, and monitor this state vaccine inventory, doing site visits at doctor's offices, that sort of thing. How many employees and how much costs? Well, that's hard to know, but certainly you should be offended by the fiscal note that's attached to this bill because it fails to disclose those obvious savings. Instead, it makes two absurd claims. One absurd claim is that a part-time staffer would need to be hired to tell providers you're getting vaccines in through a different process, you'll purchase your own, instead of using one of the many employees they will no longer need. So it's absurd they would be hiring additional people by eliminating this program. The second false claim in the fiscal note is that there are additional general funds would be needed to be billed. Health insurers would be needed, to purchase vaccines during a public health crisis, outbreaks, or disaster relief effort. If DHHS has been billing health insurers for that now, they're violating state law as they have no authority to bill insurers for those government-used vaccines to the Vaccine Association. But then DHHS vaccine program has never been audited. It is a $40 million a year vaccine purchase program, and there's been no audit. And I know that for certain because I made a 91A request to DHHS, and I asked for the most recent 2 years of audits of their vaccine purchase program, and I was informed there's never been an audit. The Vaccine Association does their own audit, but that's just money going in and out. It does not tell us about the purchase of vaccines. The claim is it will put the purchase of child vaccines back in, it will put the purchase of child vaccines back in the hands of private providers, just like they purchase vaccines for adults quite effectively and efficiently. It will reduce waste, fraud, and abuse. Many vaccines can be used for children or adults. There is no control over who providers are using these vaccines for. They've got a refrigerator.
Please start wrapping up.
Okay. Taxpayers will save millions of dollars for reductions in staff at DHS. What it won't do, some people think that it's going to remove vaccine requirements. It does not. It does not make vaccines harder to get. It does not make vaccines more expensive. It does not eliminate vaccines for poor children. That's the Vaccine for Children program, entirely separate. It won't suddenly require costs of deductibles and copays. Federal law prohibits that. Vaccines still will be free for any parent who want them for their children. This bill does not take a position on the benefits of merit vaccines. It is simply a long overdue bill removing what should be a private function of the purchase of medical products from government and shifting that back to private industry. I ask that you vote to pass this bill, please.
Any questions? Representative Polazov and then Representative McLean.
Thank you, Mr. Chair, and thank you for your testimony. Could you, am I correct in understanding that most states don't have this body similar to New Hampshire Vaccine Association?
That is correct. It was initially created in New Hampshire, and then the fellow who created the business to offer his administrative services, he got a no bid contract that continued for this. He went on to other states, 5 other states, and legislation was passed there. And interestingly, he secured the administrative contracts in those states as well. So I'm not sure who this association is serving.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. You touched upon this, tangentially, but let's just say we don't need the vaccine association for, general run of the mill. But let's say there's a zombie apocalypse. I won't use COVID because that's too political. But let's say there's a zombie apocalypse and there's a vaccine that comes and we really got to distribute this quickly and efficiently. How do you see that happening in the absence of the vaccine association?
Simply the way that they would purchase any other routine vaccinations. Once it's commercially available, they can purchase it. With regard to COVID, it took some time before it was commercially available. So all the COVID shots were being purchased with federal dollars by the federal government and supplied to the state. So if it was that sort of thing, I think it would go through that same scenario. And no money goes to this association in that scenario if it was similar to COVID. Interesting that you didn't want to touch on the COVID shots, but since you brought them up, I will touch on those. I did raise the question of why the Vaccine Association is reimbursing DHHS for the purchase of COVID shots, because under the definition of vaccines in their very own statute 126Q, the $3.6 million they spend on those they do not qualify as vaccines under the definition in their own statute.
Other questions? Seeing no other questions, thank you. Oh, sorry, Representative Kofal.
Thank you, Mr. Chairman, and thank you for taking my question. So, one of the criticisms that I've heard, and I don't think I heard it in your testimony, was around audit and sort of to what extent has the Vaccine Association been audited? So I've heard that, and yet I've also heard that they have an audit. So
Sure.
I'm just trying to get clarification on, if you're familiar with that, what does it mean?
Yes, having, attended all their board meetings and served for 5 years as a public member, yes, the Vaccine Association is audited, and I've reviewed that audit. So they are audited every year, but that is simply, did we provide the money to DHHS that we collected and that they asked for? What it does not do is it does not audit that $40 million annual purchase of vaccines by DHHS. Are they purchasing and requesting for reimbursement from the association vaccine products that qualify as vaccines? Are they actually distributing those? There's no audit, zero oversight on that. There is a second report that the Vaccine Association provides to the legislature that's called their annual report. It's generally a 2 or 3 page document. It's really a marketing brochure put out by DHHS, and large part of it's a letter from DHHS. So kind of a poor report of anything that's material.
Any other questions? Representative Drew.
Thank you, Mr. Chairman. My question is this. I read through the statute on this, and it very much seems that this is, for all intents and purposes, a tax. And it's a tax that's set by the Vaccine Association, assessed from insurance companies who essentially have no choice, because if they don't pay, they lose their license. And then it's handed over to DHHS for the purchase of something. Is that an accurate assessment of how this program operates?
You could call it a tax. I mean, obviously it's called an assessment, but I'm glad that you raised that, because one of the other concerns is the entire cost of this Vaccine Association, including administrative costs, legal fees, is being written off as medical loss, and that the statute allows them to do that. So those administrative costs with any other company, the federal government requires that those administrative costs be separate, and they're limited to 15 or 20% of premium costs. Anything above that is refunded to consumers. So this artificially increases health insurance premiums to consumers unfairly, that they shouldn't be paying those administrative costs as if they were medical loss.
Other questions?
I hope that's helpful.
Seeing no other questions, thank you.
Thank you.
Thank you.
Carla Smith, is she still here? Okay. Sorry, we're behind schedule this morning. I know you're on a tight time frame.
Thank you, Chair, and thank you, Committee. I greatly appreciate you letting me present to you today. So hello, everybody. My name is Carla Smith. I'm a registered nurse here in New Hampshire. And my position is strongly about preserving access to care and maintaining cost-effective care, and thereby I am opposed to this bill. In a former role as a school nurse, I have seen firsthand the critical importance of vaccination in ensuring children can safely attend school. Vaccines protect children from dangerous diseases and historical outbreaks, such as polio, highlight just how devastating these diseases can be. More recently, we've seen an uptick in measles outbreaks, which underscore the ongoing risk of vaccine preventable diseases. When New Hampshire families have access to immunizations, our entire state benefits, creating a healthier and safer community for everyone. That's why I am deeply concerned about House Bill 524, which threatens to dismantle our state's children's vaccine program. Right now, New Hampshire's immunization system is designed to be efficient and cost-effective. Insurance companies contribute to a central fund that is managed by the New Hampshire Vaccine Association, which allows the state to purchase vaccines at a 30% discount. These vaccines are then provided to families at no costs. House Bill 524, however, would eliminate the Vaccine Association, forcing doctors' offices to manage their own vaccine inventories and bill insurance companies at full price. This would likely mean higher out-of-pocket costs for families, including copays and coinsurance, and added administrative burdens of doctors' offices. This bill would create unnecessary cost barriers for both families and healthcare providers, making it harder for children to receive the vaccines they need to stay safe and healthy in school. At a time when vaccine hesitancy is increasing and compliance in school vaccine requirements are decreasing, New Hampshire needs the Vaccine Association to avoid any contribution to these trends. We must preserve our state's immunization program to ensure that every child has access to vaccines without financial hurdles. Thank you so much for your time.
Thank you. I know you have to leave. Are you taking questions? Or do you
I'd
have
be
to-
happy to take questions.
Any questions for Carla Smith? Yes, Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. You mentioned polio elimination. So, given it was probably a long time ago, am I correct in assuming that New Hampshire Vaccine Association had no role in it? And was there any disease that was eliminated since we had New Hampshire Vaccine Association?
No, I use that as an example. I think childhood immunization requirements for schools is very, very important, and it's dear to me. In my experience as being a school nurse, I've been very fortunate. I've never seen a child with polio. I truly hope I never see a child with polio. I hope all of you in this room never have that happen. Diseases reemerge when vaccine rates go down, and we're really seeing a trend right now in measles. And I think we have to make this about accessibility to care. This is not a debate or a bill that's about whether to vaccinate or not. It's not about what to require in schools. We've had those bills. I'm sure more of those are coming up again. They always do. It's like Groundhog Day. Sorry about that. But this is a cost-efficient mechanism to make vaccines available. And I do not want to see that go away.
Other questions? Seeing no other questions, thank you.
Thank you.
Also signed up to speak are Colleen Smith and Anne Marie Mercoon from the Department of Health and Human Services.
To the New Hampshire Vaccine Association, since they'll give background on structure of the.
Okay, you want to go later on the, okay. Are we talking about Patrick Miller?
Yes, please.
Great. Good morning, Mr. Chairman and members of the committee. Appreciate the opportunity to speak today. My name is Patrick Miller. I currently serve as the Executive Director for the New Hampshire Vaccine Association. Currently, we are opposed to House Bill 524. For those of you who are not familiar with the purpose or the work of the association, it is a not-for-profit, independent 501c3 voluntary corporation that was formed under RSA 292 and created by state statute 23 years ago. The association was initially established for the convenience of health insurers and third-party administrators, payers, to ensure stable and equitable contributions to the state's universal vaccine purchase program. The UVP combines federal funds designated for the state's Medicaid and uninsured children with private funds from the association's member payers to enable provider practice locations to have access to all vaccines at no cost to them or to patients. New Hampshire was the first of 14 states to create universal vaccine purchase programs. Additionally, all 50 states and territories have programs supporting Medicaid and uninsured children with federal funds. The association has a limited role in the state's UVP. The association itself does not purchase vaccines. It does involve multiple constituencies. The New Hampshire Department of Health and Human Services. They currently have 209 pediatric and family care provider practice sites enrolled. The New Hampshire Insurance Department. There are currently 91 commercial health insurers and third-party administrators that pay into the program. Our board consists of representatives of payers, providers, and consumers, as well as the commissioners of both NHID and DHHS. I just want to take a minute to explain the mechanics of the program. They're quite straightforward. In August of each year, the association receives an annual estimated invoice of the funds it needs from the association to fund the program. In September, we calculate the rate that the insurance companies will pay and approve that. And then 4 times a year, we collect money from the insurance companies. And then in June, we get a final invoice that's been trued up from the department, and we remit a check at the end of the day. This pass-through funding mechanism helps support the Department of Health and Human Services in their ability to provide these free vaccines to healthcare providers, whether the patient is privately insured, has Medicaid, et cetera. It is expected to save about 30% on childhood immunization purchases this coming year, and has total administrative costs of less than 1%, which are borne 100% by the payers, not the state. And to put this in perspective, we spent $154,000 last year on administration on a program that had $18.3 million attached to it. I really challenge anybody to find something that is running more efficiently than the Vaccine Association at 0.84%. We do have accountability in multiple areas. We have reporting requirements in statute to the governor, the Senate president, Speaker of the House, the commissioners of DHHS and NHID. These reports are public on our website. We have an annual report, an annual financial audit, and we have 5 board and 3 audit committee meetings each year that are held online and open to the public. We're fundamentally opposed to this as it has met and currently meets its established intent of ensuring stable and equitable contributions from payers to the state's UVP. Additionally, the association saves administrative billing costs for payers and providers by eliminating them. It saves cost on immunizations, and that accrues to the payers, employers, and ultimately consumers. It allows providers to avoid the burden of inventory carrying costs. In the case of one immunization for RSV, providers would need to front $4,500 just to be able to offer a single dose of the immunization.
If you could start wrapping up, sir.
Yeah. And then ultimately, it allows providers to offer these no-cost vaccines. In summary, this pass-through mechanism has been working well for nearly a quarter of a century. As the adage says, if it's not broken, don't fix it. I really thank you for the opportunity to present this testimony. Happy to answer any questions. If there's any regulatory questions, the association's outside counsel is here today, and my contact information is enclosed. Thank you.
Thank you. Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question. This
Sure.
is kind of a crystal ball type question,
Okay.
but if you cease to exist as this bill passed, and as the first, I'm sorry, I don't remember names, well, the first person who testified suggested this could be handled better privatized. What do you envision would happen to the provision of
I think what will
vaccine
happen is the state could continue to participate in the Childhood for Vaccine program for Medicaid children. And then on the commercial side, providers would have to decide whether, one, they could afford to purchase and stock the vaccines. They'd then have to go through the administrative billing practices. If they did choose to stay and offer them, they would then have to bill the carriers, get money back from the carriers, and move forward. And what I've heard, and I believe there's people here today that will talk to this more specifically, whether it's a federally qualified health center or even large medical centers, that whole process is extremely costly for them, especially the carrying costs of the vaccines. And I think we've all, listening to the prior bill, heard about medical billing and what that entails. So this really eliminates all of that. Thank you. One more thing. not all childhood vaccines can also be given in retail, say, pharmacy locations. And so I think that's another issue that would be faced.
Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question.
Good morning.
Have any of your member providers, pediatric practices, asked to not participate and buy their vaccines on the free market?
I will defer that to the health department because they actually manage the provider relationships. Our job is really to collect funds from the insurance companies and remit that back to the department. But as far as I know, no, but when they come up, I think it'd be great to ask them. Thank you.
Representative Polazov.
Thank you, Mr. Chair, and thank you
Good
for
morning.
taking my question.
Sure.
So there was a question about assessment, whether it function like attacks. So could you confirm that if insurance some company is not paying into it, they will lose their license?
I would have to have somebody from the insurance department respond to the license. They are required under RSA 126Q, both fully insured plans as well as self-funded plans, which are typically through the third-party administrators or some of the larger carriers to participate. Again, when the program was put together, it initially was based on some voluntary funding back in the early 90s, and then everybody figured with more companies coming to the state, it made sense to standardize this to make it equitable across all carriers. And later, additional things were changed in the program to continue that, such as it's only on child-assessed lives. It doesn't include adults, as an example. So right now, it's based upon statute.
Other questions? Representative Lucas.
Thank you, Chair. And thank you for taking my question.
Good morning.
Another crystal ball question, if I may. In the absence of the association and in private practices that decide that they cannot afford the cost of carrying the vaccines, where do the patients go if they choose to have the vaccine?
Right. So currently, there is no plan for that because we've got so many practices that do participate in other outlets for them. Potentially, it would disrupt the relationship between the pediatrician and the patient because they'd have to go somewhere else to find the vaccine. And I'm not sure that from sort of a cost perspective as well, whether it may be, travel to, as well as just a general disruption, like it would create a lot of problems. And I'm guessing some folks today will also talk to that specifically that are providers, but there's no other place to go currently. And especially because of the age, you can't just walk into a pharmacy and vaccinate your child with the requirements.
Thank you.
Yes.
Other questions? Representative Woods, did you have a? Okay, Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my other question.
Yes.
So could you talk about other states? So there was some conflicting numbers today. First, I heard about 5 states have similar programs, and you told 14 or 15. So if you could help with how different states do it, and if we see different results comparing to other 35 or so states who don't have centralized purchase program.
Sure. So the Association of Immunization Managers does publish a map of the country and which states have these programs. And again, the fully universal states, which means you've got private money and money from the federal government involved, there are 14 of those states currently. And so I'm sure that could be provided to you if you'd like to take a look at that. And I apologize, I forget the second part of your question.
So if you could compare those 14 states with program, with states without program, do we see any differences in cost and immunization rates or anything?
I know there are wide variations across the country in terms of immunization rates. I'm not an epidemiologist, so I think I would defer that question to the department if that would be okay with the committee.
Anyone else? Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question.
Sure.
I don't want you to give me the entire budget, but the money you take in, where does all that come from?
So the money that we receive comes from individual insurance companies and third-party administrators. So there are currently 91 that pay into the program, and that number fluctuates. It goes up and down as carriers come in and out of the state and have pediatric patients. And so what happens is on a quarterly basis, each one of those child-covered lives that each carrier has gets assessed, and funds are brought into the association, and then we write essentially one large check to the state at the end of the year.
And can I ask one more?
Follow up.
So why is there such a large savings listed on the fiscal note to the state? That's what confuses me.
I will have the state respond to the fiscal note because that's something that they wrote, if that's okay.
Anyone else? Seeing no one? Okay, thank you.
Okay, thank you very much.
Also signed up to speak is Kim Bernard from the Nashua Division of Public Health and Community Services. Oh, if I, if Mr. Bernard, I've already called Mr. Bernard, but if he's willing to defer to you, that's fine. And what's your name? I have a card from you, right? As you can see, there's quite a few. Here we go.
Can you put your mic on, please?
Good morning, members of
If
the.
I could just interrupt you briefly, to the committee, we're going to do a rolling lunch today. We're going to continue to go, not take a formal break for lunch. If you want to go, just go at your leisure, and I'm just want to get us back on schedule. So
Yeah.
with that, please proceed.
Okay, thank you. Thank you for hearing my testimony. My name is Dr. Christine Arsenault. I'm a pediatrician here in Concord. I'm the vice president of the New Hampshire chapter of the American Academy of Pediatrics, and I'm also a mother of 3. I think that I am here to ask you to oppose House Bill 524. I think that what the New Hampshire Vaccine Association does has been well outlined. It saves money by having a group purchase for vaccines and then having those vaccines distributed to practices. If this bill were to pass, pediatric practices would have to buy vaccines and charge patient insurances for them, as has been described. This gives the insurance companies power, essentially, to charge theoretically whatever they want for those vaccines, and for that cost to theoretically be put back on the patient. Right now, these vaccines are given to patients completely free of charge. One thing I wanted to speak to is that the process of vaccine management is appropriately very heavily regimented. We have, a refrigerator that has to be kept at a certain temperature, certain humidity. I work for a small private practice here in town, and we have a employee who works 20 hours a week just on vaccine management, ordering, communicating with the state database. And that's just for our small practice that is a mere, small fraction of the number of kids in the state getting vaccines. The authors of the bill estimate that it would take a single part-time state employee to work out this transition. Based on my experience, this is a gross underestimate. This bill would require the staff support of multiple employees, perhaps a whole team, which would be very costly during that transition. As the individual from the New Hampshire Vaccine Association mentioned, the system we have works very well. It allows us to give kids who want vaccines at no cost to those families. And for this reason, House Bill 524 asks the state to spend money to create a problem. The authors of this bill agree that it will cost the state more money. We disagree about exactly how much, but I believe that it would be far more than they anticipate. And anyone who works in a medical office knows that it will hurt pediatric practices and patients. For this reason, I urge you to please oppose House Bill 524. And I should mention, I'm speaking on behalf of the New Hampshire American Academy of Pediatrics, as well as myself.
Thank you.
Yep.
Any questions? Seeing none. Thank you.
Thank you.
Okay, let me try that again. Kim Bernard from the National Division of Public Health and Community Services.
Here I am.
We have a police chief in Londonderry. His name is Kim Bernard, so if I referred to you as he earlier, I apologize.
That's okay.
I saw Kim Bernard and
I
I
have my
think of our
pronouns.
police chief, so anyway.
All right. Good morning. My name is Kim Bernard. I am a registered nurse with over 30 years' experience. I currently serve as the Chief Public Health Nurse at the Nashua Division of Public Health and Community Services. We serve the greater Nashua area, which includes the Nashua and the 12 surrounding cities and towns. We are fortunate enough in our great state of New Hampshire to have both the Vaccines for Children, the VFC program, and the state-funded program so that all children under the age of 19 can be vaccinated at no cost. Why would we want to change this? Why would we want to make it harder for parents to keep their children healthy? We do not have this equity with adult vaccines, and we see the challenges it causes. Without the New Hampshire Vaccine Association program, increased barriers may keep children from becoming vaccinated, which also opens up children to diseases that are preventable and, in turn, increases cost to the state. For example, there are actual scenarios of access barriers we have assisted with in our work as public health nurses, and here are a few. We cared for a 2-year-old boy in our clinic who needed a hepatitis A vaccine because his provider does not carry it. We've assisted a mom who brought her 1-year-old baby to our clinic to receive the COVID vaccine because his provider did not carry it. We served a family with 6 children who wanted to space out their childhood vaccines. We worked with this family, and it's very challenging for a practice to do that. In terms of flu vaccines, it's sometimes difficult for busy working families to get a visit at their provider's office. We assisted an 18-year-old going to college who needed their meningitis vaccine to complete college admission paperwork. We also recently cared for an 18-year-old who was never vaccinated, and now he is making an educated decision to protect himself and others. We also often see kids who need routine vaccines for the school year, but could not get an appointment at their provider's office due to challenges with limited workforce. As public health professionals, our core role includes protecting and promoting the health of our community. A key factor in facilitating this is through prevention. As leaders in our community, we need to do better to decrease barriers to healthcare for all people, as well as keep costs down in our state. I sincerely appreciate the opportunity to provide testimony in strong opposition of House Bill 524 and urge you to oppose this bill. Thank you.
Thank you. Any questions? I don't see any.
None.
Okay, thank you.
Thank you so much.
Okay, Colleen Smith and Anne Marie McCoon, do you now want to testify?
Good afternoon, Chairman McDonald, members of the committee. Thank you for allowing us to testify today on House Bill 524. My name is Colleen Smith. I'm the Bureau Chief for the Bureau of Infectious Disease within the Division of Public Health Services within the Department of Health and Human Services. And today I'm joined by Anne Marie Mercury, who is our Immunization Section Chief. And we are here to oppose House Bill 524. We want to echo what you have heard in previous testimony, that we believe that the New Hampshire Vaccine Association helps create the best access for New Hampshire families and children to access immunizations in our state. We also want to echo that it does save money to insurers and group health plans. And also we want to echo that Because the department is integral in vaccine management and education to healthcare providers, we assist healthcare providers in minimizing waste, which is a savings and establishes efficiencies within that provider practice. If House Bill 524 was enacted, there would be an immediate impact to healthcare providers. They would, again, have to, as was expressed in previous testimony, have to bear upfront costs for managing separate inventories of vaccine. The department did provide a fiscal note to this, and I'm going to turn it to Anne Marie to give more details on that fiscal note.
Hello. Shut myself off. Sorry about that. Good afternoon. Thank you very much. I'd like to share some information about the fiscal note, and then I'd like to provide further details from the department because I think there's been a lot of questions that we are able to answer. So regarding the fiscal note, if this bill were to be enacted, the department would no longer be able to purchase vaccines for privately insured children. So the fiscal note was entered in for $150,000 for year one and then $100,000 each year past that. And that is to prepare for an event of an outbreak. Outbreaks can be extremely expensive for vaccination. When we are looking at a vaccine of $25 per dose and we have to administer 4,000 to 5,000 doses, that comes to pretty close to $100,000. So outbreaks are very, very expensive to control. Without the Vaccine Association, we would not have the universal program, and we would need some funds if the department were to be able to assist providers and handle a vaccine outbreak. So I would like to then move into additional details about how the department works with the Vaccine Association to answer some of the questions that have come up about our role. So the Vaccine Association, as mentioned, it saves money, it reduces the provider burden, and it ensures the universal access for all children. Each year, the department estimates the number and costs of the immunizations that will be needed for children to cover the entire child population of New Hampshire. We recognize that not every child will get vaccinated, not every child will get fully vaccinated. So our estimate is based on the actual doses and cost of the vaccines that were purchased the prior year. So we have, those projections that we provide to the Vaccine Association. We do have a cost split between the federal Vaccine for Children program. They cover 40% to cover the costs for vaccinating children who are Medicaid, uninsured, underinsured, American Indian and Alaskan Natives. And then the Vaccine Association covers the non-VFC eligible children, which is primarily the commercially insured. So what we want to do is to ensure that the Vaccine Association is only reimbursing the department for the cost of actual vaccines that are administered. So what we do is we have very, very tight controls of inventory and fiscal management. We are monitoring how much vaccine is going out to each of the providers, and we actually apply a split funding per provider. So we collect data from the providers on an annual basis. They report to us the numbers of VFC eligible children, the numbers of non-VFC eligible children. That way we know that provider office has a specific percent split. When a provider places an order, the department goes ahead and applies that percent split to that actual provider's office. So in the case of an FQHC, Federally Qualified Healthcare Center, they may have more Medicaid eligible children than a provider who is in private practice. We apply different splits based on their patient populations.
You had asked for 4 minutes, so if you could start wrapping up.
Okay, thank you. So we are vigilant about controlling the waste. How the cost savings comes into play is we are a volume purchaser. We purchase through the CDC contract, which is a 27% cost savings as compared to private market. We've talked to the manufacturers. Manufacturers would consider a 4 to 11% discount based on provider volume of vaccine purchase, but there's no way near that they're going to get the savings that is afforded to the insurers through this program. And I would be happy to answer any questions because I do want to be respectful of your time.
Thank you very much. Representative Weber.
Sorry, I want to be sure that I've got my, gotten straight with the fiscal note, because they talk about $4 million decrease in federal in state spending. But am I correct in reading this fiscal note as there is an absolute wash, because you have the 24 million that comes in and the 24 million that goes out? So that is, there's no expenditure of general funds. It's all the money in and the money out. And then the vaccine is distributed to each provider according to what they have told you in advance that they need. Is that correct?
That is correct. The department does not have any financial gains or losses. It's the expenditures and the revenues are an exact wash for the New Hampshire Vaccine Association. We would need those additional funds for outbreak control, as mentioned.
Right. Thank you.
Representative Nagel.
Thank you, Mr. Chairman, and thank you, my friend, for that clarification on the fiscal note. I appreciate that. I still want to understand one thing, though. Is this functionally a self-funded organization, or is there a state contribution to it? And if so, how much is that?
So there is not a state contribution. We are funded through federal grants to operate the New Hampshire Immunization Program. And because of that work, our program and our infrastructure is in place. The additional costs of managing the Vaccine Association is fractional. We do request 60% of a few positions because we are monitoring so much more for the Vaccine Association than we are monitoring for the VFC program. But we do that in kind spirit because we're good stewards of the dollar. We don't want any wastage. We allow our providers to transfer vaccine from one another prior to expiration so that it's used. We worked very closely with the providers. We do not have them replace any vaccine for circumstances beyond their control. So if there's a power outage, they're not responsible for replacing that loss. If the Vaccine Association were repealed, they would become responsible for that. So there's extreme cost savings to the providers.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. Did I hear you correctly that your fiscal note assumes outbreaks every year? And generally, how many outbreaks did we have in the last decade?
So the fiscal note is to ensure that the funds are available in the event of an outbreak. So those funds would not be used unless an outbreak occurred. Our last outbreak, we were dealing with hepatitis A up until about 2021. We went ahead and gave thousands of doses of hepatitis A vaccine. And also, obviously, the pandemic. But in general, we do have low levels of outbreak because of our vaccine coverage. If access becomes an issue, fewer children may not have the option to get vaccinated when they choose to be vaccinated, and they're going to be more likely to be susceptible.
Other questions? No, Representative Drew.
So this is a hypothetical question that I'm asking in order to help me understand how this works. Let's say we repeal this statute. What would stop the Vaccine Association from simply continuing to operate as a private entity?
I believe without the statute, they would not have the authority to collect the funds from the assessors. I would refer to the Vaccine Association to answer that question, but it would become a voluntary contribution, and not all payers may contribute.
So there would be no problem with them giving that money to DHHS to continue the program as is?
Well, that would, if the Vaccine Association didn't exist, that would not be an option. There's no mechanism for insurers to pay the department directly without the Vaccine Association.
Okay, thank you.
Other questions? Okay, I'm seeing none. Thank you. I'm going to step out for a while and turn the gavel over to the Vice Chairman, Representative Mazur, and let her take over for a little while.
Thank you. Next, we have Damian Santana. You have 3 minutes, sir.
Thank you to the chair and the other committee members for allowing me to speak today. My name is Damian Santana. I'm the Public Health Emergency Preparedness Coordinator for the Capital Area Public Health Network. And I'm here.
A little closer to the microphone.
Yes.
Sure, happy to.
Thank you.
Is that better? My name is Damian Santana. I'm the Public Health Emergency Preparedness Coordinator from the Capital Area Public Health Network, which is one of 13 public health networks in the state of New Hampshire. And I'm here to testify in opposition to this bill. And the reason for that is one of the added benefits of this stream of funding is that it does cover privately insured children. And where we use that at the public health network level as an opportunity to both vaccinate and also train emergency responders like Medical Reserve Corps volunteers and CERT volunteers is by holding school-based flu clinics during the school season. So without that funding, we would of course still be able to vaccinate students that are VFC eligible, but that's a small portion of the students that we do vaccinate. And this creates an opportunity for the participating public health networks to carry out point of dispensation vaccination clinics in a real way that we don't have an opportunity to practice otherwise. We can, of course, set up mock drills, but it's really not the same thing. And this allows us to run through the practice of performing these in cooperation with Department of Health and Human Services and other entities. So the increased accessibility also creates an opportunity for families that for other reasons may not be able to get vaccinated at a provider's office or have difficulty. We certainly have built a lot of strong relationships with school nurses and schools that are working with our program to help us to vaccinate kids that just may have a difficult time getting vaccinated elsewhere for other reasons. That's all of my testimony, but if anybody has any questions, I'm happy to do my best to answer them.
Thank you. Any questions? Oh, Representative Polizov.
Thank you, Madam Chair, and thank you for taking my question. So we heard that most states in the United States don't have central program like that. So have you heard any problems from those states? Do they have any problem getting reimbursement for childhood vaccination or anything?
Thank you for your question, Representative Polizov. I'm afraid that's outside of my purview because I only operate at a regional level here around the capital area. So I serve 24 towns in and around Concord, New Hampshire. So I couldn't speak to what other states do or how the reimbursement process works. My testimony today is just to explain that one of the other added benefits of this is that it creates an opportunity for us to take volunteer emergency responders that would be called to action during any kind of outbreak and gives them an opportunity to put those skills into practice to be better prepared if the time needed. So just an additional benefit that I wanted to share with the committee.
Thank you. Representative Nagel.
Thank you, Madam Chairman. Thank you for taking my question. I'm just curious, out of the 13 community public health networks, how many do participate in the process?
I'm sorry, I don't have those numbers either. I work for Granite United Way, so we're an initiative of them. We share that with the Capital Area Public Health Network, so I can say for certainty that our two networks do participate. The total percentage out of the 13, I'm not sure. Mm-hmm.
Thank you. Any further questions? Seeing none? Appreciate it.
Thank you for your time.
Thank you. Next, we have Kate Frey from New Futures. You indicated 2 minutes.
Good afternoon, members of the committee. My name is Kate Fry, Vice President of Advocacy at New Futures. Thank you for your time. I know you've had a long morning. We are a nonpartisan, nonprofit organization that works to improve the health and wellness of New Hampshire residents. And in this role, we work extensively with policymakers and healthcare providers and communities to improve overall public health and improve health equity. I won't repeat what was said. I have my testimony that really spells out what the New Hampshire Vaccine Association does and what it doesn't do. I think you heard a little bit about that today. I want to be very clear that they do not set vaccine policy. They're only a funding mechanism. They don't mandate vaccines or limit parent choice. They have nothing to do with determining the vaccine schedule. Again, they're a funding mechanism only. One thing that hasn't been covered is you've heard proponents of the bill say that the state should not be in the business of vaccines. New Hampshire was the first state to create this innovative, cost-effective model. Now, 82% of states have policies to purchase vaccines beyond what is available through the federal vaccine program to reduce cost barriers. 14 have replicated New Hampshire's universal purchasing program. I think many people would agree that it is the state's business to use taxpayer funds wisely while providing equal access to life-saving immunizations and keeping healthcare costs down. This is good business, and all of this is made possible by the New Hampshire Vaccines Association role in our state's public health infrastructures. For these reasons, New Futures urges this committee to vote ITL. And I'm also going to be handing in testimony from Dr. Sue-Ann Tansky, a pediatrician and who works at Dartmouth Hitchcock, who is also opposed to the bill and has pointed out some really great what the impacts would be to providers and to families.
Woo, right on time. Thank you. Any questions from the committee? Yes, Representative Weber.
Did that start around that testimony?
I'm
are you
doing it
gonna
right
hand
now.
afterwards?
Yeah.
Okay,
Yeah,
thank you.
thank you.
I'm losing track of my paperwork here. Thank you.
All right, next we have Christine Stoddard.
If I may bring on one of our doctors.
Do they have a Okay.
Good now afternoon. It's nice to see you. My name is Christine Stoddard, and I am the Senior Director of New Hampshire Public Policy at Bi-State Primary Care Association. Bi-State has the pleasure of serving and representing New Hampshire's community health centers. There are 10 of them. They serve, including Planned Parenthood, we serve over 102,000 patients, 20% of which are children. So 20,000 kids are served by federally qualified health centers across the state of New Hampshire. 36% of their patients are commercially insured. 31% of their patients receive Medicaid. If this bill were to pass, you're asking clinicians to treat patients who have commercial insurance differently than their Medicaid patients. And I'm here to tell you in no uncertain terms, the federally qualified health centers cannot afford to buy vaccines for their pediatric patients. They cannot afford to buy vaccines for their adult patients who are uninsured. Those patients are forced to pay out of pocket, or the FQHC sends them somewhere else, like a commercial pharmacy, where they would have to pay out of pocket. We cannot buy vaccines. In 2023, the federally qualified health centers had $14.5 million in uncompensated care. This would add to that uncompensated care burden. They can't do it. They would have to shut down sites and stop serving patients. And also, as a parent, I implore you to oppose this bill. One of my kids is autistic. He is 10 years old. It has taken him 10 years to feel comfortable to see a clinician. My daughter is neurotypical. We would have to find a new pediatrician or pay out of pocket. We are not unique in this situation. There are many families with kids with disabilities in the state of New Hampshire. I don't want to have to choose a new pediatric practice when my son with a disability has learned to love his pediatric practice. It would be horrible for us. I would also want to share with you that in Coos County, the only primary care provider in Gorham and Berlin is a federally qualified health center. They treat almost 13,000 patients, many of whom are children. They cannot afford to buy vaccines out of pocket. I'm happy to answer any questions, but I'd also like to allow Dr. Peters to speak from the perspective of Amoskeag Health, which is in Manchester.
Hi, I'm Kate Peters, and I'm a family doctor at Amoskeag Health. I'm also on the board of the New Hampshire Academy of Family Physicians, and both those organizations have said that I may speak on their behalf today, as well as on my own, as a doctor, but also as a mom. We are soundly opposed to HB 524 for many of the reasons that have already been mentioned. Amoskeag Health, where I work, is a not-profit federally qualified health center, and we provide comprehensive primary care, which includes vaccines to people of all ages in the Manchester area and surrounding towns. The NHVA has been an asset to folks like us and to healthcare providers across the state since it was formed 23 years ago, and it's hard to imagine, as described, how we would survive without it at this point. You've already heard what the program does. Let me just say, from a provider perspective and from the perspective of, running a large organization that cares for a lot of people, as my bosses have shared with me, if this bill passes and the NHVA goes away, we will have to create more cumbersome systems to order and pay for vaccines, and that will be awful for us. I hope that you're already aware that we are in a time of unprecedented financial fragility for our health centers. Organizations like ours can't afford to purchase these vaccines, paying up front and not knowing whether the cost will be adequately reimbursed. We don't have a budget for it, and we don't have a system for it. So as a family doctor, I can see how that's going to cause chaos for lots of families like yours across the state. And as a mom, I can see how damaging this would be. This would result in families needing to change practices or take their kids to separate appointments to get vaccinated, which means more days off work, more stress, and fewer kids getting vaccines overall. And this is going to disproportionately harm needy families. My job as a healthcare provider at an FQHC, and your job as lawmakers, is to protect equity in our healthcare systems. And this bill does the opposite of that. It asks us to dismantle a well-established, highly effective, highly efficient organization that saves money for our state and keeps people healthy. So the obvious choice is to vote ITL, and I encourage you to do so. I'm also happy to take questions if you have any.
Thank you. Representative Polzov.
Thank you, Madam Chair, and thank you for taking my question. It's probably for first speaker, Christine Stoddard. You mentioned uncompensated care. So given that we are talking about different demographics, some people insured, uninsured, on Medicaid. So in what groups do you foresee uncompensated care? Do you expect private insurance companies denying reimbursements for vaccines? Do you expect, Medicaid not reimbursing and so on?
Sure. So this bill is only applicable to commercially insured kids. So what would happen is if the FQHC could theoretically buy vaccines, which they cannot, they would buy the vaccines magically and store them and then wait for the insurance carriers, the commercially insured carriers, to reimburse them for their vaccines. When the new RSV vaccine came out, our community health centers were heartbroken because here's a resource that they know their patients need, but they could not buy them out of pocket. So this bill would contribute to the uncompensated care of the commercially insured population, not the Medicaid population, if that makes sense.
Thank you. Any further questions? Seeing none, thank you. All right, next we have Patricia Glasstetter. If you could turn on your microphone. Thank you.
Can you hear me now? Actually, good afternoon. My name is Patricia Glastetter. I'm a public health nurse at the City of Nashua Public Health
You can
Department.
get closer to your mic.
Of course.
Yeah.
That better?
Yes, thank you.
Thank you. Again, I'm a public health nurse at the City of Nashua Public Health Department. I'd like to thank you all after this long morning and afternoon for giving me the opportunity to speak in opposition of House Bill 524. The New Hampshire Vaccine Association has created a bridge for vaccine providers to receive all ACIP recommended vaccines at no cost. And they have lowered barriers for families to help prevent vaccine preventable diseases. Now, can you imagine our world without bridges? We would all have to take the long way around, and it would cost a lot more money to drive completely around a river, if it was even possible. And would it surprise you if folks chose to drive through a river because it was faster? The New Hampshire Vaccine Association, along with the state's private insurance companies, allow public health departments, medical providers, as well as federally qualified healthcare centers to bridge a very important healthcare gap: vaccines for all of New Hampshire's children. As a public health nurse and the vaccine coordinator for the City of Nashua Public Health Department, I see the health and human worth in protecting our children, as well as the beneficial financial impact of providing vaccines to all of New Hampshire's children, regardless of their insurance status or ability to pay. Without the New Hampshire Vaccine Association, healthcare providers like myself and my colleagues would be unable to provide no-cost vaccines to all of New Hampshire's children. Shouldn't our goal be to bridge gaps and reduce barriers for our children's good health? So now I ask you to consider our great, beautiful state without our bridges. This is similar to how repealing the New Hampshire Vaccine Association Committee could affect our children. Do we need to be reminded of what life was like without our bridges, or when children were dying of polio and diphtheria? Please do not put another barrier up for our families who need help in keeping their children safe and healthy. And if you aren't able to see the health benefits of what the New Hampshire Vaccine Association does, please think about the financial benefit of keeping our children, our future, healthy, out of the hospital, and alive. Please allow the New Hampshire Vaccine Association to bridge the gap for our children and oppose House Bill 524. Thank you all for listening.
Thank
Any
you.
questions?
Does the committee have any questions? I'm seeing none.
All right. Thank you.
Thank
Thank you very much.
Next, we have the Honorable Jerry Knirk. Welcome back, sir. Good to see you again.
For the record, I'm Jerry Knirk. For full disclosure, though, I have to state that Senator Bradley appointed me to the New Hampshire Vaccine Association Board last fall, but I am not speaking on their behalf. I'm testifying as a retired physician and legislator. Vaccination is one of the most effective public health measures in history. If you've explored our old cemeteries, you'll see lots of tombstones from the 18th and 19th century with little kids' names on them. And note that frequently several children would die in the same month in the same family. Why is that? Because of communicable diseases, things that we do not see anymore. And of course, polio and smallpox are great examples of the impact of vaccination. Now, here's the key issue. The great majority of parents in New Hampshire vaccinate their children against communicable diseases. That demonstrates that your constituents need and want access to vaccination. It is our duty then to provide those vaccinations in the most cost-efficient fashion and with the least administrative burden on providers and insurers. The Universal Vaccine Purchase Program established by RSA 126Q provides precisely that, and I won't go into the details because it's already been given. The old-timers here will remember that I tried to expand the New Hampshire Vaccine Association to cover adults as well back in 2020. It was not rejected due to cost. It failed since the pharmacies refused to participate, and they were significant providers of adult vaccinations, and therefore it was just not a viable option. So if this bill were to pass, there will be one of two outcomes. Either we would not have a system for childhood vaccine, or a new system would need to be set up. In the first scenario, where there's no universal vaccine purchase program, there would be an increased administrative burden on providers for ordering vaccines, increased cost to the vaccines, and increased administrative costs associated with billing for both payers and providers. Therefore, costs was increased for insurers and providers, resulting in increased cost to all of us. It would likely result in decreased vaccination rates, leading to outbreaks of communicable diseases, and ultimately, the biggest cost: vaccine preventable deaths of our children. The other scenario in which a new system within DHHS would be created would require authorization of the department to hire individuals to perform the service, rulemaking authority, and appropriation to cover those costs. But none of that is in this bill. And there's probably not much appetite for another appropriation in this already somewhat difficult budget year. It would also take time to become functional, during which time we would see the problems of not having a system. The current system works very well with an extremely low overhead. We owe it to our providers, insurers, and our children to maintain the current system, which has given New Hampshire one of the highest vaccination rates in the nation, with excellent cost savings and minimal administrative burden. So please ITL this bill, and I'd be glad to take any questions.
Thank you. Representative Polizov.
Thank you, Madam Chair, and thank you for taking my question. Regarding the cost to DHHS, we heard in testimony that they don't expect much savings because all the current administrative cost inside the department is covered federally. So I would assume if they need to create a new system for the same purpose, it also would be covered fully federally. So I think in your second scenario, we are actually looking.
Do you have a question for him?
Would you agree that we are looking into saving hundreds of thousands of dollars of administration cost because they will be covered federally?
The federal does not cover the private insurer aggregation. So that I'm pretty sure I'm correct on that. And so as a result, the issue is, again, it was a dichotomous. Either we don't have a system or we've got to set up a system. And if we set up a system, we need to actually fund that, and that's not in this bill.
Representative Siebert.
So in your opinion, I guess overall, is it your opinion that the Vaccination Association, if dissolved, would then hold on. So if the Vaccination Association were dissolved, would all of these providers and health departments be able to absorb the costs to vaccinate children, to keep children vaccinated, or what would happen in that case?
I think that's beyond my knowledge, but you've heard multiple providers and practices and by state already explain that they will have a very hard time absorbing that. So I think that's the answer to that. Thank you.
Any further questions? Seeing none.
Thank you.
Thank you. Thank you. Appreciate it. Next, we have Robert Lawless. Is he still here? No. Okay.
Madam Chair,
Yeah.
could I just ask if Mr. Lawless, who is not here, could you tell us what position Mr. Lawless took?
He opposed the bill
Thank you.
and representing himself.
Thank you.
Okay.
That's helpful.
Next, we have Meg Overbaugh. Still here? No? Also opposed the bill. Okay. So lastly, I have Kathy Stratton. Oh, okay. From New Hampshire Medical Society. Okay. You have 3 minutes. Thank you.
Thank you.
Turn it back on. There you go.
Red means stop, I guess, in my head.
Yes.
Excuse me. Dear Chairman and members of the committee, My name is Kathy Stratton. I'm the CEO of the New Hampshire Medical Society. I'm representing the Medical Society on behalf of our nearly 2,000 members today. We strongly oppose House Bill 524, the legislation that seeks to disband the New Hampshire Vaccine Association. The Medical Society's mission is to advocate for the well-being of our patients and promote public health. HB 524 poses a direct threat to both of these goals. The New Hampshire Vaccine Association plays a critical role in safeguarding public health, particularly by increasing access to life-saving immunizations and reducing the financial burden on families and the state. We urge you to vote ITL on this bill. I'm not going to repeat a lot of the testimony that we've heard today, but I do want to highlight the clinicians and the physicians who have spoken. And I want to highlight that several of our members have also submitted testimony online today. This bill allows healthcare providers to administer vaccines to any child, regardless of their insurance status or family income. This ensures that all children have access to vaccines that prevent serious illnesses, hospitalization, and even death. Our second point today is that the New Hampshire Vaccine Association's collective purchasing power allows New Hampshire to negotiate better rates for vaccines, saving taxpayers millions each year. It's important to note that the New Hampshire Vaccine Association does not set vaccine policy or create vaccine laws in the state. Its sole purpose is to collect and distribute funding, as we've heard. So vaccines can be purchased and administered to children across the state. In conclusion, the New Hampshire Vaccine Association is a key component of our state's public health infrastructure. It increases the access to vaccines, saves the state money, and most importantly, protects the health and well-being of our children. The Medical Society strongly opposes House Bill 524 and urges the committee to vote ITL. Thank you for your time and consideration of our testimony.
Thank you. Appreciate it. Representative Polozov.
Thank you, Madam Chair, and thank you for taking my question. I have a question about insurance part. I never heard New Hampshire insurance company coming out and saying that they're opposed to vaccinations, that their data showing it's ineffective. So if they think that it's a good thing and it's helps, wouldn't they be willing to cover the bill and fully reimburse vaccination effort even without vaccine association?
Thank you for that question. You've essentially stumped me. I think I would have to go back and talk with our resources and get an answer to that.
Thank you. Any further questions? Seeing none. Are there any other people here that would like to testify? Because I don't have any pink cards left. All right. I'm going to go ahead and close the public hearing for HB 524-FN. And we are going to recess until 1 p.m. when our next public hearing is.
I don't know. I was going to ask you. Hello. I mean,
Oh, no, okay. It's like, it's this whole block? No, it's not. It's just. Here's another 548.
I don't know what that is. We see, here you go. All right. I'd like to call to order the public hearing for HB 548-FN. The prime sponsor, Representative McLean, you ready to present the bill to us?
Thank you, Madam Chair. Thank you, Madam Chair, and honorable members of the Health and Human Services Committee. For the record, my name is Mark McLean, representing Hillsborough District 15, which is Manchester Ward 8. I'm here to introduce HB 548, which builds upon the direct primary care legislation we passed in 2019 by extending that healthcare model to healthcare facilities. It amends RSA 151:2-F, one by allowing those healthcare facilities that operate on a membership-based model or exclusively take direct payment for services to be excluded from the requirement to accept all modes of payment. So the legislation is being brought forward in an attempt to drive towards increased transparency. We heard a little bit about that this morning in HB 743, to drive towards increasing transparency in healthcare pricing, but also to introduce new service models to underserved communities. I think that one of the areas where the Affordable Care Act fell short was in its promise to bring healthcare costs under control. It expanded access, but it really didn't do a lot on the cost side. In New Hampshire, healthcare costs have gone up at 1.8 times the rate of groceries, 2 times the rate of transportation, and 4 times the rate of clothing. Only housing and energy costs have gone up at a higher rate, and I think, we understand a lot of what the drivers are behind that. A key element in bringing the promise of the Affordable Care Act into reality was supposed to be the introduction of clearer, more understandable pricing information that would encourage people to shop around and enhance competition. And they did put the charge masters out there, but really, this full transparency never really happened. And as you heard from testimony this morning, healthcare billing remains as Byzantine as it's always been. So I want to give you a quick history on how I came to this bill. A few years ago, I was in a minor car accident. I felt fine. My wife, she's paranoid. You got to go down. You got to get checked out. So I go down to the urgent care and I said, hey, I was just in a minor fender bender. I'm fine, but could I get checked out? And they said, oh, sure, we can check you out. And I said, well, how much is it going to cost? And they said, well, we can't tell you until after we render service. And I said, listen, if it's going to be $100 or $200, that's fine. I'll give my wife peace of mind. But if I'm going to get slammed with a $1,200 bill or something, I'm sorry, my wife is just going to have to suffer a little bit and do without transparency. But again, they said, there's no way, we cannot tell you the price, not even the ballpark, until we render the service. And really, guys, can you imagine that happening with the delivery of any other kind of service? It's just, it just doesn't happen. So I've tried a couple times. One of my first legislative attempts at introducing transparency was a bill requiring health providers to provide a reasonable estimate of non-emergency services, kind of along the lines of what we heard this morning with 743. But I promptly got a call from the Deputy Insurance Commissioner on that one. He said, hey, because New Hampshire is a very small state, such legislation might actually lead to price increases or even have insurance companies pull out of the state altogether. And it didn't have some of the nuances that the bill we heard this morning had. But I was left in the unenviable position of that one, of going to the Commerce Committee and saying, I'm going to pull my own bill. But then no surprises became federal law. And I said, hey, maybe this is an avenue. And maybe what we can do is, New Hampshire is a small state, so we wouldn't have the firepower to do that just here. But if we can kind of move in with no surprises and build on what is already there federally, maybe we can do something. But as I sadly discovered, No Surprises only covers the uninsured and the self-insured, and it's completely inadequate as a foundation, really, on building the transparency that the majority of New Hampshire residents would want. So that's where we come to this bill. This bill, it adopts an Alexandrian approach to price transparency by just cutting through that Gordian knot of healthcare billing to go to the direct pay model. As I said, the direct pay model, this is a model that we've already seen operate successfully, when it comes to the direct primary care. Because in order for such a model to work, there truly has to be no surprises in pricing. Because most people get their insurance from the commercial market or are enrolled in Medicare or Medicaid, the usage rates, I think, for facilities using that model is going to be relatively low. It's not like it's going to be all over the state, and we haven't even seen the direct primary care go all over the state. So I think the uptake is going to be low. However, for those folks who are uninsured, self-insured, or have high deductibles, the idea of knowing upfront how much your colonoscopy is going to cost may have enormous appeal, and even a small amount of competition may start to generate change. So I kind of think this is the incremental change that the gentleman from the insurance department was talking about when he talked about 743. There's not going to be anything that kind of gets us all the way there. But this, by building on this direct primary care model that we already have, it just starts to open things up a little bit. Releasing facilities from the all-payer model will also release them from the enormous administrative burden that it engenders. And we heard Representative Nagel talk about that. Doctors become doctors because of the desire to care for others. They're not accountants. They don't want to be accountants. But close to half the administrative burden in operating a facility is tied to billing. If that can be eliminated, there's potential we may see the expansion of services in underserved areas. And again, we're already starting to see that on the direct primary care front. It won't be for everyone, but it will introduce competition, new approaches, and possibly exposure to innovative ways to deliver health care. Now, one of the main objections to HB 548, and those guys been around a little bit know, is the fear that it's going to decimate New Hampshire's critical access hospitals. Okay, that's a fear. I personally think, looking at the uptake rate on the direct primary care, it's not going to be enough that this is going to hit like a hammer. I think it's going to be slow on the uptake. And one thing to note, though, is that the benefit of being a critical access hospital and the protections of RSA 151 remain unchanged by this bill, okay? So the exclusion zone remains intact. The 100% Medicare reimbursement remains intact. The 24/7 emergency room requirement for new facilities remains intact. So critical access hospitals are still going to have a lot of insulation, a lot of armor against competition. But the question is this: are we protecting critical access hospitals merely for the sake of protecting critical access hospitals? The Federal Critical Access Hospital Act went into effect in 1997 in an attempt to preserve healthcare access in the nation's rural communities, okay? That's the real goal. The real goal is to expand and preserve access, not to preserve the critical access hospitals for their own sake. But one of the ways that I think the critical access law actually impedes the expansion of access is that it caps the amount of hospital beds at 25. So I asked legislative research about trends in the bed count in the state's hospitals and quickly discovered that the trend obviously is flat. Even though the population of New Hampshire has continued to increase, we've gone up 450,000 in the last 40 years since the last hospital was built in New Hampshire. Yet Alice Peck, 25 beds. Androscoggin Valley Hospital, 25 beds. Cottage Hospital, 25 beds. Franklin Hospital, 25 beds. All these hospitals, 25 beds. They will never have a 26th bed. They will never have a 27th bed, because if these hospitals, even if they could, if they staff beyond the 25 bed count, you know what's going to happen? They're going to lose their critical access hospital status. So I think in that way, it's actually an impediment to growth. So I think recognizing this I think if new methodologies emerge that can offer an alternative way to expand access, I think that they should be explored. I don't think this is going to happen overnight, but I don't think we should be tethered to a single path to providing health care. Medical access is increasingly a threat. We hear it on the news all the time. They're closing down this, they're closing down that. We hear that in this committee all the time. I think we should be considering an all of the above approach. And I think, just like the gentleman from the insurance department said this morning, this is kind of that incremental path, or at least a part of it. So with that, I'll take any questions. I do have some subject experts that I'm bringing in behind me, so I'd ask you to save some of your firepower for them, but I'll do the best I can to ask any questions you may have. Nope, I'm going to testify the next. They're all overlap, Jerry.
All right, thank you, Representative McLean. Representative Weber.
Thank you, and I appreciate, although I don't agree with your issue, your point about the critical access hospitals. We do have here some eloquent testimony that you probably haven't seen yet from the Roman Catholic Diocese of Manchester on behalf of Catholic Charities and the nursing homes that they run. And how do you respond to their concern, which is that the nursing homes that they run, and I think this also applies to the county nursing homes and others as well, they depend for their funding on a mix of Medicaid, a little bit of Medicare, and some private pay. And if you allow facilities completely unregulated, because it removes the regulation for private pay, cash basis payment facilities, how do you respond to their concerns that the top payment source, the ones who pay the most to their facilities, will be skimmed off, and that leaves their facilities in more financial peril with respect to the nursing homes?
So I think that most people, they have a variety of sources. Medicare, I know the Hillsborough County Nursing Home is reasonably solvent because it's got a higher percentage of Medicare. But I do believe that for most people, you're just not going to have enough people that are going to opt for that you're going to be able to make a heavy business case early on. So I don't think you're going to see nursing homes going up across the field that are all private pay. I just don't think that there's enough of a population to support that. I did ask legislative research because I'm trying to understand the penetration, and it's very hard to get. Benoit Pelletier worked on it for like 2.5 months, and he sent me the final email last night, and he said, I'm sorry, but it's a dry desert of data out there. But, based on what I do know, I just don't think that there's enough of a business case. But unfortunately, Representative Weber, I don't have any hard data to support that. What I would say, and I didn't have time to get into all my testimony, but one of the things that the bill does do is it does, ask HHS to do a study looking at the penetration of the direct pay models and the impact that it would have. This is kind of my third time coming back to the well, and I wish I had more hard data to give you that answer. But my gut is telling me that the uptake is not going to be heavy.
Oliver?
So my gut's giving me a different reaction, but that's not the purpose for right now. My follow-up is, with respect to that study, are you not putting the cart before the horse? Would it not be best to have this bill create the study, and then, based on the results of the study, decide how much and which areas? Because this bill paints with a very, very broad brush across healthcare facilities. And as I say, I'm concerned about all of them, but I'm particularly concerned about the nursing homes because I see no reason why a facility isn't going to be built that is completely unregulated because, anybody can build one and all they'll do is take the private pay. So,
And
but the real question was about the study committee.
I mean, and I understand. So, the to have the study committee would be great, and that's why we put it in. I think though that based on what we see with the primary care, but let's take your concern to its full extension. Let's say that somebody was to look at a model that says, hey, I think that there's a market here that we could have, a high-end nursing home that is going to be, just direct pay or whatever. And that could very well happen. But for your scenario to be realized, there would have to be enough of that happening that it's going to be siphoning off all of the people who are operating, that are going to be. I just don't think that there's going to be enough demand that you're going to be seeing 20 nursing homes that are all going to be on a cash pay basis. I just, based on what we're seeing with the direct primary care, I just don't see that would happen. So, based on that, I think there are states, for example, Oklahoma, that has this structure with respect to allowing for the direct cash pay model, and we just don't see a plethora of new nursing homes being built there. So it's very limited. There's not a lot of states that have this, but where it has been applied on a limited basis, I'm unaware of everything where it's just basically, run away like a chain reaction. So.
Other questions? Representative Lamontagne.
Thank you, Mr. Chair. And thank you for taking my question. I'm sort of following up on Representative Weber's questions because I see that it's very possible for private nursing homes to open up, no red tape, and they're going to take everyone that has any money. But eventually, for many people, that money will run out. As in the case of my mother right now, after all the careful planning. Or, someone, as we heard testimony this morning, someone who is in a nursing home with dementia, that's running, $11,000, $12,000 a month for care. So do you see that there's a possibility that that if this were to happen, it would create a scenario where there's high-end nursing homes for people with money, and we're reverting back to basically the poorhouse for people who are out of money?
I guess, again, my response to be the same response that I have to Representative Weber. There's not a lot of data. If you look at those few states where they've gone forward with this model, we haven't seen that. So I don't see that as being a realistic scenario with a small population like we have. What I do see it is it's an opportunity to bring in transparency and explore other modes of operation. And I think the reality is right now, with the model that we have right now, we are seeing access go down, especially in the rural regions. The bill that I'm going to be talking about after this talks about some of the disparities between the urban and the rural regions. And we have had the critical access law, and we've had these provisions. We had the certificate of need, and then when the certificate of need went away, we replaced it in 2016 with what we have now. And nothing we have done has gone to expanding facilities. I mean, or access. In fact, access has gone down while our population has gone up by close to 500,000 people. So I think that if we don't start looking at alternative solutions now, especially where we're getting into aging populations, it's going to be too late. So, I mean, I definitely support going forward with the study. I think the study is necessary. But like I said, I think on balance, I think the risk is not too great. And I do have folks coming up after me that are much better subject expert speakers on this matter than I am. So hopefully you can save that question for them and ask that question, because they may have some data representative that I do not have.
Representative Polazov?
Thank you, Mr. Chair, and thank you for taking my question. So following up on numbers from previous question, let's say if something Alzheimer's services cost like let's say $12,000, but if new facility doesn't have to spend resources on reimbursement negotiations and some other compliance stuff, wouldn't they be able to share some of those savings and lower the cost down?
Well, I think that they would definitely, and the hope would be that, you know, we would have more offerings, and that those people that are operating on that, you know, cash basis or membership basis would be able to recognize these economies and offer the services at a much reduced rate than the $12,000. Absolutely, that would be the hope. As in terms of the second part of your question, with them sharing some revenues back, I don't think that would kind of defeat the purpose. I don't know if that was what you were asking for the second part of your question. Okay.
Anyone else? Representative Nagel?
Thank you, Mr. Chair. Thanks for taking my question. Anyways, I've been in medicine for a long time. I've seen that the concept, I think that Representative Weber was alluding to, is called cherry picking, and it's a very real phenomenon that actually led to the creation of Medicare and Medicaid in the first place. I do think that there's the potential for this to happen. You know, with that said, very early in my career, the American Bar Association, the American Medical Association both said that we as providers have a responsibility to take care of 10% of the population. At least 10% of our time should be spent taking care of the poor. So what I'm wondering is if in a bill like this, to minimize the cherry picking effect, you can include language that they would be expected to devote a certain percentage of their resources to taking care of the poor, either through Medicaid like the county homes do or otherwise.
So you're saying facilities that would exist under this rubric would be, I think, I mean, if there was a certain component of that was potentially charitable, but I think if you were to go and say, no, we expect you to take 10% of your population, you know, from Medicaid or whatever, what that would do would be basically put you back into the same thing, Representative Nagel, that you were talking about this morning, where I still have to build up the infrastructure and all those things. So I think, you know, if you were looking at, you know, the expectation is that we have some kind of charitable component, maybe, you know, and we could have some discussions about that. But if it was, oh, you're going to have 10% has to be Medicare or Medicaid, now it kind of defeats the whole point of it, because now you're going to have to come and rebuild in that infrastructure. So I think at least that's where I'm on it. But I'm open to discussion.
Other discussion? Other questions? Seeing none. Okay, thank you. Also signed up to speak is former Representative Jerry Knurk.
Thank you, Mr. Chair. And for the record, yes, my name is Jerry Knirk, retired orthopedic surgeon and legislator. And I'm here, again, I was a little confused earlier because there was a lot of comment about critical access hospitals, which this bill does not have to do with, but that's the next one. But I'm here to testify against just Section 4 of HB 548, because that section would exempt nursing homes, skilled nursing facilities, intermediate care facilities, rehab hospitals and facilities which operate on the membership model or exclusively provide services on a basis of direct payment from the patient without any third-party reimbursement from the requirement for licensed healthcare facilities to provide services to all persons regardless of the source of payment. Okay, you all sit on county delegations, and you should be familiar with the finances of your county nursing home. That's where most people actually finally, understand how this stuff works. Medicaid covers about 60% of nursing home residents, but the reimbursement rate of Medicaid is significantly lower than the actual cost of nursing home care. So nursing homes rely on the revenue from self-pay patients and patients with insurance to make up that shortfall. So what's the problem with allowing some facilities to only accept cash or members? Well, first of all, healthcare simply does not function as a free market. It's a basic human need. Healthcare is not a luxury consumer good where if the cost is too high, you can just not buy it. Most of us can't afford to pay the cost ourselves. So if you're 80 years old and you just sustained a major injury or illness or had major surgery and cannot function independently at home and need rehabilitation or a nursing facility, you can't just say, well, no, that product's too expensive. I don't want to buy it. That's not a choice. You're stuck. You're going to need to go. And somebody else is going to have to pick up the bill. And that's what we see in the county nursing home with uninsured, Medicaid, so on and so forth. Now, again, the proponents of this approach often state that it just allows the free market to function. However, the free market also demands a level playing field. And I thought it quite interesting that when Representative McLean was asked about, well, what about having a 10% of the people would have to be charity care? And he said, well, that put us back in the same place. Yes, it would level the playing field, which is not what he wants. Because HB 548 would allow that small number of for-profit institutions to cherry pick the healthy, uncomplicated patients who can pay full cash price. That shifts the care of the sicker, more expensive patients and those with Medicaid, the uninsured, or insurances that pay less to the other facilities. They're still subject to RSA 121-2F, and that leads to adverse fiscal impact on those facilities and possible closure of those facilities. This bill creates an unlevel playing field that sets regular facilities at a disadvantage compared to these private ones. So in summary, for-profit facilities cherry-picking the well-paying, uncomplicated patients would have significant economic impact on our regular facilities. The losses sustained by those facilities would just be shifted to those who have insurance, or in the case of the nursing home, the county nursing home, to the taxpayers, driving up costs for everyone else and not changing total healthcare costs. The bottom line is I believe that the goal for the healthcare system should be to provide healthcare, not to provide profits from caring for the wealthy while letting those who are less fortunate suffer and die. Please ITL this bill, and I'll be glad to take any questions.
Representative Weber.
Thank you, and good to see you again.
My pleasure. Old homework.
So you stated that you opposed Section 4 because of the county nursing home issue. Does that mean that you also oppose Section 1, which is also about residential care and health facility licensing?
Well, yeah, I mean,
It exempts
yeah.
from the moratorium?
Yeah, and it actually, it's not just the county nursing homes too. It's like any regular nursing home would be potentially bothered. And yes, I would also agree, but I just wanted to focus on that cost shifting issue. But I think that it is a problem to say, oh, sure, if you want to make this one that we can just cater to well-off patients, you can build it, but for the rest of you can't. So yes, I would oppose one, but because of time, I was trying to keep myself focused.
And I'll just
follow up.
I'll just ask one more question, which is, do you have a concern that if people are able to pay the costs of a nursing home, which are steep, They also might prefer not to be housed in a nursing home where there are Alzheimer's patients who might be difficult and bariatric patients who might take up nurses' time and otherwise difficult and unmanageable or more difficult to manage patients.
Yes, in a sense. Okay, here's an example. It's the country club or the public golf course. You know, do you want to be with the riffraff or do you want to just be with people of your own socioeconomic status? It'd be nice to be the other way around. And if we had a bill, remember, many other countries in the world solve this problem by not having insurance. They just, elder care is simply something that they do. The Nordic countries being one of the best examples of that. And they don't have to fight with all this stuff. I think the other thing that was brought up was that question of what happens when they run out. So is that person just going to get booted out on the street? Oh, time to send them to the county nursing home now because they haven't got any money. We've sucked it all out. So now it's time to send them away. That's the feeling I get from this bill. I know that's not the intention. Representative McLean is a good guy. I don't think this is his intention at all. But this is still what I think will be the outcome.
Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question. This is kind of like it's not a nebulous question, but it's pertinent. I mean, it brings to the question of how we in our society view healthcare in general. Is it a public good? Is it a pseudo-public good? Is it private good? I meant to ask this question of Representative McLean, but I'm just curious where you put it, because that has dramatic ramifications for public policy and how we create things, how we visualize that answer.
Well, I think my final comment kind of gave my sense about that. I believe that it is a public good. It is actually a fundamental human right to be able to access health care. And I do not think, again, that it functions as a free market. We heard earlier today about the difficulty of finding prices. And no matter what we do about it, as long as we have a system of insurances, it's going to be opaque and nebulous and difficult. And I think that it just simply doesn't function. And the comment I keep making all the time is, I remember when the iPhone first came out, I thought it was really cool. I would actually know the Apple Watch, really cool, but it cost too much money. I didn't want it. I could make that decision. But if you're lying on a stretcher and you've got acute appendicitis or a ruptured appendix, you're not going to be able to start looking around for a better deal for who's going to do your appendectomy. And you can't say, I think I'll just skip it because it's just too expensive. Healthcare doesn't function like a consumer good. It's not a commodity. It is a fundamental human right.
Other questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Greg Moore from Americans for Prosperity.
Thank you, Mr. Chairman, members of the committee. Always great to be back in my old stomping grounds. I know Representative McKay's the only one left in the committee, but I do always appreciate coming here. For the record, my name is Greg Moore. I'm Regional Director for Americans for Prosperity, here today to testify in support of House Bill 548. House Bill 548 gets at the fundamental problem of the third-party payer. Third-party payment systems drive up the cost of care and block the relationship between provider and patient. And this bill is trying to do one small piece to get it. As the sponsor said, there's not a huge market. The vast majority of granted staters either have employer-sponsored insurance or have government insurance. And so it's a very small pool, but it is growing. I'll try to get to that. I'll just say this bill's passed the House a couple times in the last few years, so I don't want to rehash too much of what I've said in the past on this legislation. But the third-party payment system, based upon some studies, has shown to increase the cost of care by about 35%. Removing that third-party payment problem, that we have the opportunity to provide lower cost alternatives for individuals across New Hampshire. I will say that there was a trade group of independent physicians. They recommended, just to understand the scope of this, that for every independent physician, you should have 2 billing specialists. So you can imagine the cost that adds on top of care. I'd like to say there's a little more urgency this year. As many of you may know, back in 2010, with the Affordable Care Act, they created marketplaces or exchanges, and those exchanges offered subsidies called advanced premium tax credits for people up to 400%. Well, in early 2021, the American Rescue Plan lifted that cap. So there's no cap. You could get these advanced premium tax credits. That was extended 2 years. It was extended another 2 years in the Inflation Reduction Act, but it goes away at the end of this year. And according to CBO, a study that CBO did for Senator Shaheen, that's going to lead to 3.8 million more people who will not have health insurance. Now, these would be people whose incomes are above 400% of the federal poverty limit, which is $62,600 for an individual and $128,600 for families. So it's not really destitute people, but if you take that 3.8 and just smash it into New Hampshire, our share would be about 12 or 13,000 people. So we're potentially looking at having a significant number of people who don't have traditional health insurance. We're going to be looking for lower cost alternatives, and House Bill 548 would help get us there. So in the interest of time, I'll stop there and just say I'd be happy to take any questions.
You've got 20 seconds to spare. Very good. Any questions? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. I'm not being an economist or actuary or anything like that, but help me understand how creating with this bill, basically, where you mentioned third-party payers, basically creating a fourth-party payer, in essence.
I'm not sure I understand.
Well,
Because you would be paying directly to.
I understand, but but that's another mode of payment. Okay.
Well, I mean, I definitely understand what you're
Going
saying.
back to the rest of the question.
Sorry.
Is that's really basically putting it in a market base, which, and I guess I have trouble understanding, as has been outlined by Dr. Knurk, that it really doesn't fit our overall concept other than a business model. And we're trying to get away from a business model. And it seems like this is getting us farther into that perspective, but help me out if I'm really looking at this incorrectly.
Sure. This actually creates a more traditional relationship as you would go to any vendor. So when you go to the store to buy groceries, you pay them at once you buy the groceries. It would be a very similar relationship. You just pay for the services once it's provided. So it removes the third-party payment system. And I might add a couple other issues that I'd like to raise. I know that that was brought up in earlier testimony, the issue of nursing homes. Well, we have a nursing home moratorium right now. I started working at HHS in 2003, and we haven't built a new incremental nursing home bed since then because of the moratorium. So that's already in place. The second one I'd like to address Representative Nagel's question. If you look at page 2 of the bill and lines 4 and 5, you'll note that in the existing statute, you do have to have a plan for uninsured patients. So page 2, lines 4 and 5. So that part does not change.
Other questions? Representative Lamontagne.
Thank you, Mr. Chair. Well, maybe I'm reading this wrong, but it seems to me that on line 12, it's saying that in the case of the nursing home, A and B would not apply. They would be exempt from having to cover the uninsured.
I think that's probably I think you could probably just keep B in if this is the committee's desire.
And just
follow up?
Yes, thank you. But with regard to efficiency, you're saying that this bill would really, by getting rid of the third party, would really open up efficiency. I agree that if we didn't have quite so many private insurers, things would be a lot more efficient. Like Medicare, for example, their overhead is only about 3% compared to private insurance, which, is anywhere to 12 to 20%. So do you consider that maybe having a single payer program, like opening up Medicare, that would include long-term insurance, would be a tremendous efficiency savings for nursing homes, because then you wouldn't need Medicaid at all?
Well, at the potential trade-off of, for example, rationing of care and things we've seen in other nations that do that, it's particularly disturbing. I've seen some of the things coming out of Canada where they're trying to euthanize people on a regular basis. I think that's a troubling concern. No, it's a thing. I think there's a reason why people come to America for our care. People travel from across the globe to America for our care. And part of the reason why we have that uniquely is because of the payment system that we do offer allows centers of excellence to flourish. Whereas in these other countries, you see the care is spread out over the entirety of the country.
Representative Nagel.
I guess I want to just, oh, thanks, Mr. Chairman, thanks. I'm a little, having spent over 100 hours last year on creating a prior authorization bill, I guess my question is, do we not already have rationing of care in this country?
Not necessarily at the provider level. From a payment level, we do. There's nothing stopping you from getting that care. There's nothing stopping you from getting that DME. There's nothing stopping you from getting that drug. It's the third-party payment system that's creating that barrier in between the two.
Other questions? Seeing none?
Thanks.
Thank you. Also signed up to speak is Ben Bradley from the New Hampshire Hospital Association.
Thanks, Mr. Chairman and members of the committee. My name is Ben Bradley. I represent all acute care hospitals in New Hampshire and all specialty hospitals through the New Hampshire Hospital Association. We are opposed to HB 548. We have concerns that this bill could impede access to services if a healthcare facility is not required to have a charity care policy. This bill bifurcates the healthcare system into two classes of patients and sets up a regulatory framework that treats facilities differently based on whether a patient direct pays. It also appears that facilities licensed with a membership-based business model would not have to follow Center for Medicare and Medicaid Services conditions of participation, which include important patient safety and quality requirements. The way we read the bill, a healthcare facility licensed as a membership-based business model could discriminate against individuals because of the individual's inability to pay a membership fee. We do not believe this is in the best interest of the patients seeking care in these facilities, and to not be assured that the facility will treat them regardless of their ability to pay. Additionally, the bill sets up two separate patient Bill of Rights: the existing patient Bill of Rights and the one established under this bill. This creates confusion for patients seeking care at facilities that offer the same or similar services. Specifically, I'll give you my testimony, but I want to point out a couple of items. Roman 5 on page 3, line 14, does not include, no patient shall be involuntarily discharged from a facility because the patient becomes eligible for Medicaid as a source of payment. This speaks to the exact scenario that the representative pointed out earlier, and it's intentionally left out. Additionally, the patient Bill of Rights established under this bill does not include under the existing patient Bill of Rights, Roman 20, where it states the patient shall not be denied admission to a facility based on Medicaid as a source of payment when there is an available space in the facility. Two other examples. Roman 22 of the existing patient Bill of Rights indicates that the patient shall not be denied admission, care, or services based solely on the patient's vaccination status. And finally, on Roman 23, relative to a patient's right to have a visitor, which was recently enacted as well. We don't believe that this bill is an appropriate model for licensed facilities in New Hampshire, and we ask that you find it inexpedient to legislate. Thank you for the opportunity to provide comments. I'm happy to take questions.
Thank you. Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question. You brought up a lot of really neat points because I did go over all the Bill of Rights and had a lot of concerns about the differences between the two. But between your testimony and the last testimony, it sounds like there's contradictions in this bill that need to be reconciled in terms of whether someone with or without those forms of payment can be involved or not, or how they got rid of it. Am I wrong, or is that accurate? Did you read it?
Respectfully, I would stick to my final statement, which is to request the bill be an expedient to legislate.
Other questions? Seeing none. Thank you. Also signed up to speak is Nick Bayless from the Bedford Ambulatory Surgical Center.
For the record, my name is Nick Bayless.
Turn on your microphone.
For the record, my name is Nick Bayless. I'm the CEO and founder of the Bedford Ambulatory Surgical Center. Started 32 years ago, and when we opened up, the sky was going to fall, hospitals would go out of business, and all hell would break out. So, and I'm proud to tell you that that didn't happen, and there was greater access and affordability to health care. I'm not here either to support or kibosh the proposed bill. I'm here to just bring out some highlights that you should all be thinking about. I've been providing health care for 40 years. I've been in private practice. I developed surgical centers, imaging centers, labs, and I own physician practices, one recently in the North Country in Colebrook. And so I've worn many hats. Had my own insurance company, your former Commissioner of Health and Human Services. So I've paid bills as a state employee, healthcare bills, that is. I've been a patient and a provider. So with all that being said, remember this as you develop policy. The leading cause of personal bankruptcy is healthcare. Think about that. You get sick and injured, and all of a sudden, we kick you in this country, we kick you while you're down by bankrupting you. That's awful. We can do better than that. New Hampshire offers a lot of alternatives that are far lower in price point than our neighboring states because we got rid of the CON law, most of it. Remember that. Don't discard free market forces or an informed patient or consumer. But what's being presented and talked about is a broad brush here. Are you talking about nursing home care? Then you're talking about lab services. I also started one of the leading healthcare cost transparency companies in America today, Compass Smart Shopper. I think there are 93 million users today on it. People need to know what things cost if they're going to use those resources. We should be creating some natural checks and balances so that there is some competition amongst providers. But there are times in your life where you don't have any choice. I know we could do a lot better with a blend of what you're all talking about. I mean, physician offices, lab services, you can pay as little as $15 in a physician's office or $500 for the same lab. I can offer state-of-the-art MRI CAT scan services for $400 to $500 versus $5,000 in the same marketplace. I can replace your hip and your knee for less than $30,000 all in, prosthetic, physician fee, anesthesia, or pay $70,000 in the same marketplace. Half of the employers today are self-insured. They're paying the claim dollar for dollar. Price matters to them. Please consider those factors. But I would also agree that someone at the end stage of their life, they shouldn't be on the street. We can do better. And for those of you who are looking at a single-payer system, just because you now have coverage doesn't mean you're going to get the care. Remember that.
Thank you. Any questions? Representative Nagel and then Representative Kofal.
Thank you, Mr. Chairman. Thank you for taking my question. I could have paid you to say what you said about catastrophic health problems, because I've been doing it for the last 35 years and it is devastating.
Yeah.
But that's not my question. Can you do me do me a favor and describe to me what Bedford Ambulatory Surgical Center is and how it was created? Because it's my impression it's more of a cooperative venture than it's kind of its own out in the
Oh, no,
field type
no.
thing. Am I wrong?
No, it was started by a small group of orthopedic surgeons and myself, and there were no, and you know, I didn't know anything about ambulatory surgery, but it was the physicians needed to be more efficient with their time. They were losing their block time, and they didn't have any control of their schedule. And some orthopedic surgeons out in California were doing outpatient surgery. And so they came to me because they thought I had an understanding of medical business. So anyways, we went off and did it on our own. We struggled for the first couple of years. And we started out with 6 surgeons, and now we have 35 surgeon partners. But we partnered with a hospital. We partnered with CMC. But we were in a position of strength to partner with. And every physician I've been worked with cares. You all care. And, you know, you shouldn't have the mentality that you want it all, you have to do it all. And so with that, we came up with a great facility. And 32 years later, it's still around strong, and it's offering the best surgical price possible in our community.
Representative Kofal.
Thank you, Mr. Chairman, and thank you for taking my question. So, you know, understanding that there are a number of success stories from other states, like the Surgical Center of Oklahoma, and understanding that the current law, which requires multiple, basically requires you to accept all forms of payment, dates back to 2016. So you were in this market well before then.
Mm-hmm.
Did you see a problem before 2016 with complaints about, you know, sort of drawing away I guess the profitable customers, or the best, the patients who could afford to pay more?
Yeah,
Was there a problem before 2016?
Yes, there's always been a problem, obviously. There's always going to be a problem. It's a complex issue, and it's an economic issue. You may not know, there are 3 different payments of reimbursement that exist for healthcare providers. 3. Medicare puts out 3. There's a hospital rate, 3 for the same service, but mind you, okay? There's a hospital rate, there's a hospital outpatient department rate, and then there's an independent outpatient entity rate. The hospital rate for the same service compared to the independent rate oftentimes is 5x. 5x. Okay, and oftentimes, if someone doesn't have any responsibility because they're in the federal program, they're going to go to the hospital. They go to the hospital for an earache. Okay, that system needs to change. So it complicates the problems. Every physician I have ever worked with, and I today have about 90 surgeon partners, they all care. They take care of everybody. Okay, and we do our best as well as a facility. No one is scamming the system or cherry picking such on a regular basis. All right, so that is not the issue. They said that about ambulatory surgical centers in New Hampshire, okay, 30 years ago. I also forgot to tell you, I was chairman of the CON board for 8 years, okay? And I saw the shenanigans that were being played then to keep competition out. That's all it was, is protected franchises. I would see CEOs of hospitals lie through their teeth under oath, okay? Free market does have think about it, is what makes America great. Okay, we need a bit more of it in healthcare, but at the same time, we do need to take care of those who can least afford the care and to protect them. And there's a way to do it. All right, and we need some checks and balances in place. But with all that being said, it is complicated, unequivocally. All right, unequivocally.
Representative Weber.
So would you agree, based on what you just said, that it might be a really good idea to start with a study committee to study the
Yeah.
data on this?
Absolutely.
Before we, with a very broad brush,
Yeah.
suddenly change the entire
Yes, study committee with the intent to truly study this and not delay and postpone it. Absolutely. Absolutely, because it is a complicated issue, but there are solutions, and transparency is part of the solution. Okay, it's insane that there isn't any, or very little of it. It really is, and the people that are in government programs end up costing the government more because they end up going to because they have no skin in the game, and they end up going into the emergency room for their primary care.
Representative Lamontagne.
Thank you, Mr. Chair, and thanks for taking my question. But with regard to the 3 payments for service, and the hospital is paid a lot more, isn't that to try to compensate for all of the unpaid services that a hospital provides that an outpatient surgical center is not going to provide?
Great question. Many hospitals don't pay taxes. They don't pay property taxes. They don't pay income taxes. So that's one subsidy. They get paid more, like 5x. Okay. And we have the DISH payment in New Hampshire, the Metascam program. Okay. Where for uncompensated care, checks are written out to hospital systems, not to private practicing providers and I'm one of them. We treat a lot of Medicaid patients, and we get no subsidy at all, and we get paid far less. And to my knowledge, and actually we're meeting with HHS soon, we haven't been given an increase in reimbursement in decades. Okay, this is private practice. So we need to help private practitioners thrive, not just barely get by. There was a statistic, by the way, that's very important. The overhead of doing third-party billing, by the way, is about 30% now for a private practice. 30% of your overhead is pre-authorizations and chasing your money. It's ridiculous.
Other question, Representative Nagel.
Thank you, Mr. Chair, and thanks again for taking my question, and thanks again for saying what I've been saying. That was an awesome comment you just said. But anyways, with that said, this is just for clarification, because I don't know that we should be holding Bedford Ambulatory Surgical Center out like the model that what's being proposed here, but it's a good model. But I'm just curious, does CMC have any ownership interest in Basque, or is it?
Yes, 42%. We're trying to get at it because it's we're no longer partners with CMC.
Okay.
So it's now owned by HCA, and we just want to be independent for now and let the dust settle. But I do believe we need a strategic partner long term. And I'm also the CEO of the Orchard Surgical Center in Salem. I'm the CEO of the Nashua Ambulatory Surgical Center in Nashua. And so they're all, they offer a far better physician experience as well as a patient experience and a far lower price point.
Can I ask a follow-up?
Follow-up.
What is strategic?
Okay, Representative Weber, you.
Inquiry of the chair.
Sure.
We seem to have had a very far-ranging and interesting discussion about healthcare policy generally, but time is creeping on, and I'm hoping that perhaps the chair might direct all of us, because I'm one of the worst offenders, to turn our attention, strictly speaking, to this bill, because we're already over time for the next bill.
Okay, Representative Nagel. Okay, all right. Representative DeLamus, you haven't asked a question yet.
Thank you, Mr. Chair, and I'll try to be brief with this, Lucy. So, and referring to this bill, do you believe that this would encourage more centers as you have, or do you think this would increase more availability?
I'm not so sure. I think centers like I'm involved in, and as well as I'm not the only entrepreneur. There are many. They would go to where there's a possible need in that marketplace Okay, and it's a law of economics. Again, this is more elective care, not urgent, not emergency care or nursing home care. But there are elective services. It could be an urgent care center, for an example, a walk-in center that may want to go into a marketplace that may be far more affordable for the patients in that community. So it's that could possibly happen. I know there was an incident in Littleton, and it actually ended up going before the CON and got worked out. But an urgent care center ended up going to Littleton. From what I understand, Littleton Hospital is still there, and so is the urgent care center. And maybe the hospital ended up buying the urgent care center. I don't know. But when you don't have people that are in a position of strength, no dialogue takes place. No partnership gets worked out. But it can open up the market.
Thank you.
Just
Quick follow-up.
quick follow-up. Would you believe that I did use your facility? I had to drive with my back completely out. I have only paid a fraction of what I had found it would cost me elsewhere to have an MRI on my back, and I was able to deliver a disc with that information to the hospital the day that I went, and it was like that.
Glad to be of service.
Any final questions? Okay, thank you.
Thank you, and thank you all of you for your service.
Also signed up to speak are Danielle, I can't read it, and Doreen Shockley from the Department of Health and Human Services. Give them 5 minutes.
Good afternoon, Mr. Chair, members of the committee. My name is Doreen Shockley. I'm the manager of the Bureau of Licensing and Certification at the Department of Health and Human Services. And with me today is...
My name is Danielle Warvoice. I'm counsel for the Bureau of Licensing and Certification at the department and a legislative liaison. The department is not taking a position on House Bill 548, but we'd like to offer testimony.
Ma'am, 1 second. Could you spell your last name, please?
Sure. WOR, B as in boy, OYS. The department does not know what the bill means when it states membership-based business model. The department needs clarification on what those terms mean. Additionally, the department does not make licensing decisions based on funding. Licensing decisions are made to protect the health, safety, and well-being of the residents of New Hampshire. The department would not exempt a facility from licensure based on funding. The purpose of licensing is to ensure that facilities provide safe and appropriate care. Thank you for your time and consideration. We're happy to answer any questions you may have.
Thank you. Any questions? Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So I think we heard something about Oklahoma, so that other states already have system suggested in this bill. So how their departments were able to handle it?
Could you please clarify your question? Sorry.
Yeah, you say the department won't be able to accommodate this system, but we heard that other states already using it.
Thank you, Representative. I appreciate the clarification. I don't think we testified that we would not be able to do this. I think our testimony is that as written, we would need clarity and that we as a state in New Hampshire, we don't license based on funding. We license based on health and safety. We also I'm sorry, I lost my train of thought. We would not exempt any type of facility from licensing based on a type of funding.
Other questions? Representative Weber.
So I haven't actually parsed the language here in light of what you said, which was a new concept to me. But if in fact what this bill does is say there are no licensing requirements for these facilities anymore, and therefore you have no jurisdiction over them. Does that mean that these facilities have no regulation in terms of safety, patient care, and that kind of issue?
Thank you, Representative Weber. I believe, so we would, again, need more clarification. If the entire purpose of the bill is based on funding and how a patient, a client, a resident is going to pay for the services, we would not exempt such facility because it's a funding mechanism.
Follow up.
But my follow-up is that as I read the bill, and I have to say I didn't read it quite as closely as I ought to have because I've seen it before, but my understanding is that it exempts facilities from licensing requirements specifically. So although all other similar facilities have licensing requirements, these would not, because the statute says those statutes don't apply to them and there's a specific exemption. Is that correct?
Thank you. The way it is written now and is the way that we understand it as well. So if in fact you were to pass this bill as written, it appears that there would be a segment of facilities that are providing similar services to similar New Hampshire residents that would not be regulated by our Bureau.
Representative Lucas and then Representative Palazzo.
In general, hospitals are required to be accredited and they undergo inspections on a regular basis. What happens in this situation with these facilities?
So in the state of New Hampshire, RSA 151 deems all hospitals licensed and other facilities in the state of New Hampshire that are CMS certified are what we call deemed licensing, which means we issue a license and they are responsible for following RSA 151 and the hospital rules. Should our CMS, I also oversee the CMS certification state agency. So if a hospital has been determined to violate the law or the rule, then the department would have interaction. However, because federal regulations and accrediting regulations are generally more stringent than New Hampshire state law and rule, that's probably not something we would see commonly.
Follow up.
In a situation where a facility did not take, accept Medicare or Medicaid, only private insurance or cash, what would be the body that would be responsible for certification?
That's a really great question. I believe, I can't think of any hospital, and the New Hampshire Hospital Association is here, I think still. They might be better able to answer that question. I know that I'm unaware of any hospital in the state of New Hampshire currently that is not CMS certified. There are nursing homes that are not CMS certified, and those fall under the purview of our Health Facilities Administration adult licensing. So the state does have regulatory authority under RSA 151 and the New Hampshire Administrative Rules, which I think would be the same situation if a hospital were to conduct business in the state of New Hampshire and not be accredited or certified.
Representative Palazzo.
Thank you, Mr. Chair. So follow up on previous. So department does not license based on funding, but my impression is this bill asks to license based on funding. So my question is like, is it something? Does it conflict with other RSA, or is it based on some of your internal rules that you do not license based on funding? I'm just trying to understand if there are some amendment needed in different chapter of the law.
Oh, I'm sorry. I thought Representative McLean had a comment. We would be absolutely willing to work with Representative McLean and any other of the sponsors to determine what language might help the bill. And then we would be better able to comment on whether we were in support or opposition based on any amended language.
Anyone else? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. We're looking at this as an exception to being licensed. Can you think of anything similar that is similarly not licensed? Or is this the only exception that you would be aware of?
So thank you for the question, Representative Woods. There are a number of exemptions that already exist in RSA 151. Do you have the rule in front of you? The law. I'm happy to read those off to you if you would like, but there are primary care practices, like if you're a doctor that has your own practice, you are exempt from licensure. So because your regulatory oversight comes directly from the Office of Professional Licensure. And so that would be the only thing I can think of off the top of my head. I'll be happy to look at the exemptions and see if there's anything else.
I guess my question was directed to facilities. I understand the individual practitioners, they're still subject to licensing within the state by virtue of a requirement of being whatever. But I'm talking about, entities like these entities that we're describing here in this bill.
So reading out of RSA 151, this chapter shall not be construed to require licensing of physicians' offices and related facilities, offices and related facilities of other persons licensed in this state to practice a healthcare profession, facilities operating as community health clinics, and any other facilities exempted by rules adopted under this chapter might be the only ones that apply out of the entire list.
That was, what's the RSA again?
RSA 151:2, Roman 2.
Thank you.
You're welcome.
Any final questions? Seeing none. Okay, thank you.
Thank you.
Also signed up to speak is David Ross from the New Hampshire Association of Counties.
Thank you, Mr. Chair. For the record, my name is David Ross, and I am the administrator of Hillsborough County Nursing Home, and I am testifying on behalf of the New Hampshire Association of Counties. We want to register our opposition to this bill as it relieves a couple of things. One is that it relieves the moratorium on nursing home beds. The moratorium on nursing home beds was implemented to help control costs in the state of New Hampshire, and specifically to help focus development of care on community-based services. This bill proposes to increase community-based institutional services rather than community-based services, and that's contrary to the goals of the moratorium on nursing home care. It's not a transparency bill as proposed, as it was shared at the opening of this hearing today, and I was concerned about diluting the conversation into discussions about hospital services. Specifically, the bill addresses nursing home care specifically and the moratorium on beds, and that's a very grave concern for us. Representative Weber shared at the beginning of today's hearing that there was concerns about the impact to payer mix to all nursing homes, and that is definitely our concern. Facilities that accept Medicaid understand that Medicaid does not cover the true costs of all care, and it's necessary for operations for us to have a mix of payers. Providing a service provider that is only providing services in an unlicensed environment to private pay individuals will clearly deflect and divert individuals from nursing homes that require a mix of payers. As Representative Lamontagne pointed out, the concern about what will happen with folks when they exhaust their resources is a grave concern for us as well. We see that this was going to put greater pressure on county nursing homes specifically, as folks are only going to have no more resources, that they'll have to come to facilities of last resort, which are us, which will provide a greater burden on county taxpayers for sure. Discharges are certainly a concern, and we're concerned about the availability of services, but growing community-based care services is a substantial component of the System of Care bill that was passed by prior legislative act. Our objective as a state should be to develop community-based services and pour all of our resources into that. This bill also directs the department to create a study to determine feasibility of self-pay services or membership-based services. And I would suggest that that actually deflects the focus of where the department should be spending its limited resources on focusing on long-term services and supports. Long-term services and supports should be really focused on developing community-based services. Our frail elderly population is growing at an exponential rate. The moratorium on beds will help control the growth of costs in institutional care. So we have to really focus on community-based services. This bill proposes growth in institutionalized services, which is contrary to any movement that we have to make as a state to be able to provide care for our frail elderly population that is growing. I share the department's concerns that this bill does lack clear definition of the term membership organizations.
Start wrapping up, please.
Yep.
Please start wrapping up.
Okay, thank you very much.
You all set?
I am.
Thank you. Representative Weber.
I just wondered if you had any other concerns that haven't been raised already that you would like to share with us.
No, I do appreciate all the concerns that have been shared today, and I echo their sentiments.
Other questions? Not seeing any. Thank you. Okay, also signed up to speak is Brendan Williams from the New Hampshire Healthcare Association. And sir, you've asked for 5 minutes. I'd really appreciate 3 instead.
That's fine, Mr. Chairman. For the record, Brendan Williams, I'm the President and CEO of the New Hampshire Healthcare Association. We represent long-term care facilities, including nursing homes, capable of serving over 5,000 Granite Staters. We've heard a lot of interesting testimony today. A lot of it's focused on primary care for some reason, but this bill, what we choose to focus on is the exemption that it would make for nursing homes from the bed moratorium. I heard reference to the state of Oklahoma. The state of Oklahoma still has a certificate of need requirement for nursing homes. Governor DeSantis in Florida, when he exempted hospitals from the certificate of need law there that was longstanding, did not exempt nursing homes. Nursing homes are something different, and that's been recognized by other states with certificate of need laws because it really isn't a free market, given the preponderance of Medicaid as a payment source for nursing home residents. Any disruption to the nursing home market would not be unakin to sort of the child's game of Jenga, where you pull loose a log and the whole thing comes toppling down. That really is what would happen here. There's also ambiguity with respect to the bill. It speaks to a membership-based business model, but that doesn't preclude third-party payment. You could still get Medicaid payment under that because it says or exclusively provide services to those who are making direct payment. So in other words, if you were a member somehow of one of these nursing homes, you could be admitted as a Medicaid resident, which would drive up county property tax costs. And there's also a sort of, as been mentioned before, sort of a patient bill of rights light in this bill. I'm not quite sure why a lot of things were omitted from the existing patient bill of rights as it applies to nursing homes. Not simply admission or discharge based on your ability to pay, but even a host of visitation rights and other rights of human dignity that residents of nursing homes in the state of New Hampshire have come to expect. I just think that this bill is not ready for prime time. We have a lot of concerns. I've shared them in a letter. Bob Dunn with the Diocese of Manchester would have been here. He had a death and his family was not able to be here, but his testimony has also been distributed. And Catholic Charities of New Hampshire is my largest nonprofit member. With that, Mr. Chairman, I would certainly take any questions, and I thank you for the committee's time.
Thank you. Any questions? Not seeing any. Thank you, sir. No one else has signed up to testify. Does anyone else wish to before I close the hearing? Seeing no one else, I'm going to close the public hearing on HB 548 FN and open the public hearing on HB 223 and recognize the prime sponsor, who is once again Representative Mark McLean. You were wise, Representative. You stayed in the back. You didn't have to travel this far.
Thank you, Chair McDonald, members of the committee. For the record, my name is Mark McLean, representing Hillsborough District 15, which is Manchester Ward 8. I want to thank everybody for the vigorous discussion on HB 548, and I already have some notes in for an amendment on that. I'm here to introduce HB 223, the Rural Healthcare Accessibility Act, which amends RSA 151:4 to allow for healthcare facilities that are not hospitals, so ambulatory centers, birthing centers, etc., within the 15-mile radius of critical access hospitals without giving notification to the hospital. So the purpose of this bill is to allow for the expansion of healthcare access over time in the rural regions of the state by allowing healthcare facilities, such as Convenient MD and others, to open in the rural areas when a business case can be made for the opening. Building outside the 15-mile radius of a critical access hospital might seem like an easy thing to do and be, a low barrier, but 84% of New Hampshire's land mass is classified as rural, and when you overlay the exclusion zones of each critical access hospital on top of the other, it essentially leaves only the southeastern portion of the state open to unrestricted healthcare development. So the federal government, as I mentioned in a prior testimony, created the critical access hospital designation in 1997, and we adopted our current licensure in 2016. The intention was to preserve hospital access in rural areas, but the result has been that New Hampshire hasn't built a new hospital in over 40 years, in spite of the fact that the population has grown by 450,000 people over that same period of time. I've had legislative research trying to get me trend data on access, but as I mentioned before, it's really hard data to get your hands on. Nevertheless, I did provide each of you with a handout highlighting just some of the disparities between rural and non-rural care, and the anecdotal data about declining rural access is absolutely overwhelming. We hear it on testimonies in many other bills before this committee, and you can hear it on the news every day on the ride home from work. So the federal critical access law and our own facility licensure rules, I think that they've done nothing to expand or even preserve rural access. Instead, what I believe they've done is they've only insulated our rural hospitals as they've fallen through a period of very long decline while shutting out any outside attempts at reform or innovation. So this doesn't mean the hospitals and other facilities haven't made attempts at internal reform. I know they have, but I think that when they look to reform, just like any organization that looks to reform, they're going to look to reform within themselves first, as opposed to looking at the system as a whole. And I think that's what we need to do. We have to look at what we need to do to expand our access and not just look at the hospitals in isolation. So I think that's why this bill is important. I don't think that there's a business case for mass openings of clinics and other facilities in the rural areas of the state. So I don't think you're going to see a tidal wave of facility openings if this becomes law. However, as time moves on, what kind of other innovations might occur? By pulling down the 15-mile exclusion barrier today, we may be opening ourselves up to new opportunities tomorrow. So I made sure when I drafted the bill that I would not allow for the building of another hospital within the 15-mile radius. Okay, so I'm allowing clinics to open up, birthing centers to open up within the 15-mile exclusion zone, but I'm preserving explicitly the prohibition on other hospitals. And I did this out of concern that allowing the presence of another hospital would jeopardize the critical access status of our critical access hospitals and the favorable reimbursement rates that that status provides. So I think as a result, the bill tries to chart a middle path to slowly provide greater access to the rural parts of the state while still preserving the critical access status of our hospitals and hopefully discover new ways to provide service. And I hope you will support it. Thank you, Mr. Chair.
Thank you. Representative Weber.
Thank you, Mr. Chair, and thank you for taking my question. I'm just trying to work backwards in my mind about where facilities are in our state. And I think you made a statement about how much of the state was excluded by the 15-mile exclusion. Was that your point? Because I can think of an awful lot of places in the state that aren't 15 miles away from a critical access hospital.
Well, if you, and
Put your mic on.
unfortunately, I had
Mike.
Representative McLean, put your microphone.
Thank you very much, guys. Sorry. So there was a gentleman who had done a study last year, not for this bill, because this is the first time I've introduced this bill. And what he did in that study, and I wasn't able to get access to it, and he's off at a different conference, so he couldn't testify today. But that showed when you overlaid all these 15-mile discs, it pretty much covered 744 square miles of real estate, which basically just left the extreme southeastern part of the state not in an exclusion zone with respect to the 15-mile exclusion rate. So so that's kind of the state that we're in. The southeastern part of the state is open to development, but the rest of the stuff, when you overlink everything, it's kind of blocked. That doesn't mean you can't, apply, but you have to go through an onerous process. This is just trying to break that down.
Other questions? Representative Woods.
Thank you, Mr. Chair. Thanks for taking my question. In physics, we always look at how things apply at the infinity and zero, and that gives us some insight. In this particular situation, let's edge toward infinity. We have a hospital, and there's a 15-mile radius, and we have an ambulatory surgical unit come in. And then next year we have a laboratory come in. And then the next year we have a birthing center come in. And then next year we have a convenient medicine come in. Could you surmise what would happen to the critical care hospital?
If that was to happen, then that would put, I think, enormous pressure. Yes, it would. But I honestly think, for example, if you're looking at Lancaster, I just don't think that anybody's going to be able to make a business case that I'm going to be opening up a convenient MD and an ambulatory center and a birthing center and a dialysis center all in that area. If you look at, for example, we had the gentleman here talking about Basque Imaging. I think Basque is the only other ambulatory center that really has opened up in the greater Manchester area. There you've got a massive amount of population. And and not only do you have a massive population, but you're not in an exclusion zone. So you could totally flood it. But even in the most densely populated area of the state, you're not seeing the scenario that you raised out. So I think that if you were to, pull back that requirement in the extreme northern areas of the state, if it's not happening in Manchester, why would it be happening up in Lancaster or Littleton? So I just don't think that you can make a business case for a massive penetration of this. I think the fear, there's always uncertainty, but I wouldn't be too worried about that, in my opinion.
Other questions? Representative Lucas.
Yes. In a situation where there's only one critical care hospital in a large geographic area, and there would be the development of an ambulatory surgery center and maybe a birthing center. If there are untoward events at these centers, an unusual reaction to anesthesia or a complication that's unanticipated, and the patient needs to be transferred to the critical care hospital, how does this bill account for the need for those services by these putative ambulatory centers that might open? Thank you.
I mean, I think that could be addressed, you know, in the same way that the situation at Basque might be addressed. I mean, if they have that situation right there, there are hospitals in the area, just like there would be. But you're going to have, obviously, by definition of this bill, a critical access hospital within a 15-mile range, because outside of that, obviously, you're exempted. So you're going to have a hospital close by that would address that need.
Other questions?
Did that answer your question?
Follow up?
Follow up.
Thank you. Well, in the absence of the hospital services being available, should these other facilities begin to take away patients and income, how then will those facilities address these emergencies that might arise? Thank you.
I think that, as I said, I don't see that you're going to have a large penetration of these services because you're not seeing it in the more densely populated areas of the state. So I think it's going to have a modest penetration, but it is going to, I think, slowly expand service. I think, quite honestly, there are much greater stresses on critical access hospitals than the fact that a birthing center might open next door. I think, you're talking about, our reimbursement rates and the heavily reliance on Medicaid up in the rural areas of the state. I think, in my opinion, those are pressures that are going to carry a lot more weight than I happen to open, a dialysis center next to Alice Peck or something like that. That would be, I would think there are much greater pressures at play on those critical access hospitals right now.
Representative Weber?
I'm still working on the whole point of this bill. You're saying that the bill will bring more services to underserved rural areas, but for example, where I live, which is an underserviced rural area in the western part of the state, Keene, New Hampshire isn't within 15 miles of a critical access hospital, and I don't see anybody clamoring to open up a lot of these things there. We do have a different hospital there. I'm just not seeing what the need for this bill is, frankly.
Well, I mean, in a way, Representative Weber, I think you're kind of making my point, because if you're in an area that is outside of that exclusion disc, and which is, like I said, they all overlap, and if you happen to be in an area where there is no overlap, and so there is an opportunity to put something there, the fact of the matter is, it hasn't gone there. And I think the reason, if that's true, that it hasn't gone there is because there's just not a business case to do that. And that's why I'm saying this bill is not going to happen, and all of a sudden you're going to see this mass penetration. All that this bill is going to do is it's going to say that as things change and the demographics evolve, that there is an opportunity, if a facility can make a business case, hey, you know what? The demographics have changed. There's a real need for a dialysis center here. We think there's an opportunity, and so we're going to go forward with it. I think what it does is it's preemptive in that it anticipates opportunity in the future. But the fact, like you said, I don't live within an exclusion zone and there's still nothing here, I think underscores the point that the evolution is going to be slow. It's not going to be massive. And so it looks to the future.
Follow up.
So wouldn't a more sensible approach be the one that we had outlined for us with the Bedford Surgical Center, where they partnered with a hospital because it was mutually beneficial. And shouldn't we be leaving this in place and encouraging those kinds of mutually beneficial partnerships rather than freestanding competitions where everybody's building their little fiefdom?
I think and I don't want to speak. I think Mr. Vallis is going to be coming up and speaking on this bill again, so he could maybe speak to that. But my understanding from his testimony was that, he partnered with CMC. Right now, that is kind of null and void because of the merger with CMC. But he himself said, and I don't want to speak for him, but, that in the future, he's going to be looking to kind of reestablish that. And I think that reestablishment, in the case that he's saying, is one of benefit to both parties. So I think if there's a natural inertia towards that, that's not going to require any special legislation. But there may be situations where, it's beneficial or it's not beneficial. And there may be certain cases, and I don't want to micromanage, where they say maybe it's better that we kind of go alone. And this would allow for that. And I don't know with a Convenient MD, for example, if they necessarily always partner with a hospital. And there may be a case that say, we don't want to do that. So I think what this does is just gives the flexibility. But where it is beneficial, I'm sure they'll seek it out.
Any final questions? Okay, thank you, Representative McLean. Also signed up to speak is former Representative Jerry Knurk.
As Mark said, round two. So for the record, again, my name is Jerry Knurk, and I have a little bit of sort of inside knowledge in this whole process because I served on the SB 97 study committee that developed the language that is RSA 151.4. Critical access hospitals provide essential access to health care in rural areas for the residents who would otherwise need to travel very long distances for their care. This is particularly important for emergency services and maternity services. They run on razor-thin margins. They lose money on services such as their 24-hour per day full service emergency room and obstetrical services, which serve a lot of people who are Medicaid and Medicare or with no insurance. Those services are critical to have available, and they are subsidized by the higher paying services and the higher paying insurances. Just a couple of quick things to cover stuff caught earlier. The reason they don't go above 25 beds is if they do, they're no longer a critical access hospital. That's how it's defined. Second, we talked about the 15-mile discs overlaying them, 744 square miles. The area of New Hampshire is 9,300 square miles. There's a lot of room. I live in a place where I'm more than 15 miles from 2 critical access hospitals. In any case, urgent care facilities such as Convenient MD, they provide evaluation of coughs and colds, broken bones, illnesses, all kinds of good things like that, but they do not handle major trauma. And they're usually open only 8 a.m. to 8 p.m. Look at their website. As a result, they require far fewer resources for staffing and equipment than a critical access hospital, which must be ready for a motor vehicle accident, a gunshot wound, or a case of appendicitis at 2 a.m, with the staff and operating room to handle it. And regarding Representative Lucas's comment, birthing centers, they don't do cesarean sections. So you're in a birthing center, everything's going great, suddenly the kid's in distress, they go to the hospital. They need to have a cesarean section. Well, guess what? The hospital has a lot of cost keeping 24-hour-a-day obstetricians ready to do that C-section. That doesn't mean birthing centers aren't good. They're great, but they do have an impact. And we've seen that with the closure of a number of our maternity centers in various hospitals in our rural areas. So the point is that the establishment of a nearby facility providing only the relatively simple basic services from 8 to 8 a.m. to p.m., but not providing high-intensity, costly, 24-hour-a-day trauma care or complicated obstetric care will skim off patients with good reimbursement from the critical access hospital. That'll change the payer mix of the critical access hospital and possibly lead to its closure or diminished services. outside facilities cherry-picking the well-paying, uncomplicated patients would have a significant negative economic effect on critical access hospitals. The losses sustained by those providers would lead to cuts in services, as we've seen with those closure of maternity centers. As I said, this has a long history, and I served on the committee for SB 97 with Senator Bradley, the master of compromise. This was in 2019. We had multiple meetings and heard from all stakeholders, including hospitals and urgent care centers such as Convenient MD. Compromise wording was developed with all the stakeholders involved, including Convenient MD, and that resulted in RSA 151-4A in 2020. And the gist of this is just simply says, you got to let that hospital know. If they object, there's going to be an expert study. And if that expert study shows that there's a critical material adverse impact on the healthcare facility, then the new facility would not be licensed. So the point of the matter is, that's really kind of weird.
Please stop
This
wrapping
bill,
up.
well, I have 2 sentences. This bill seeks to remove from this process all of the special health services, except if you want to do a hospital. It doesn't make any sense to simply discard the compromise established by Senator Bradley, the SB 97 Study Committee, and the stakeholders without a good reason. Thank you.
Thank you. Any questions? Representative Woods.
Thank you, Mr. Chair, and thanks for taking my question. This issue of the 15 miles and, well, why don't they develop it outside? Sometimes drilling down, and you may have seen this on your committee, but malpractice insurance, physicians, facilities have to have malpractice, some kind of insurance coverage. I can envision, say, a Convenient MD wanting to do 16 miles, but their malpractice insurance says you have to be within 15 miles to get. Did you run across that particular,
Yeah.
it's something that's always in the back of the mind of practitioners, but
Yeah, that particular issue did not come up. I think it's an interesting question, but I mean, in general, again, if you have a complicated birth, hopefully 15 miles, you can get there reasonably quickly. But nevertheless, it is a bit of a concern.
Representative Siebert.
Thank you for taking my question. I'm not trying to get into the weeds with this, but is there a defined process that would go into determining the need and where that need is? And would it have to be really picky choosy? Say we have a really big need for say a maternity or this or that in this area. But if it, for whatever reason, wasn't cost effective for you, yet need is still there, would this still be able to meet the needs that New Hampshire needs by passing this?
I'm not sure I can answer that question, but the bottom line is this particular 151-4, didn't so much talk about needs. It actually talks about, as we say, protecting critical access hospitals, and they do need to be protected because they need to be there for the other basic high-level services that are needed. So what happens is, for example, let's say, where I live, which is a little over 15 miles from both Memorial Hospital and Huggins Hospital, a birthing center could be a really good idea, but it really would be great if we're paired with one of those hospitals so that they could be working together and there's an easy communication and so on and so forth. So that if the need is there, you can still build. It's just simply that we'd have to notify that hospital. And if they say, hey, not a problem, we can't keep up with this particular issue, there's no problem. If they say, this is going to really undermine our mission of providing care for our community, but again, this is not something they don't just say it and it happens. There's an expert review to look to really see, does it have an impact? Is that impact material and a materially adverse impact? If it's not, you go ahead. But if it really is a bad problem, then you'll say, no, you're not going to license that person. Of course, again, they might just jump out 16 miles, as Representative Woods said.
Representative Polazov.
Thank you, Mr. Chair. So if our goal is protecting critical access hospitals right now, we are protecting them through these restrictions. So can we monetize it? Can we put a number? If they're losing a certain amount of good paying patients, can we just subsidize them to save them in this situation? And do you have any ballpark estimation, like what kind of subsidies they would need to survive?
I don't have all those details right here, but that's indeed why if you're defined as a critical access hospital, that does give you some subsidies. That's part of their whole program, is so that they can actually exist. And that's again why you would not go to 26, because suddenly you then are, back to what any other hospital is. Sure. I mean, that if there's the appetite here to throw a bunch of extra money at the hospitals and keep them afloat, wonderful idea. But I don't think there is. We did see an enormous change when expanded Medicaid opened up, because a lot of hospitals that were in the red because they had so much uncompensated care, now they were actually able to get only maybe 70 cents on the dollar, but that's better than 0 cents on the dollar. And expanded Medicaid, helped save a lot of our critical access hospitals, or any of the hospitals, but critical access are running on margins that are generally about 1%.
Okay. Representative Lucas.
Thank you, Mr. Chair, and thanks for taking my question. So help me a little bit. I'm trying to find a way to understand the position of the ambulatory centers, in that they are wanting to operate at a profit, of course, and they're generating also a small but significant number of patients who are going to require hospitalization. But in taking the profit potentially from the same hospital that they're depending on to accept the cases that don't go well in the ambulatory surgery center or the birthing center, how do we mesh this all together?
Well, that's where you get into what was just said by Representative Polozov a couple of moments ago. I mean, if you said, okay, this is a problem, we'd like to have this thing, but we'll also subsidize the hospital so they can have staff on hand to be able to handle that cesarean section at 2 a.m, that's peachy. But do we really think we want to do that? Is there an appetite for a bunch of appropriations to do that? I doubt it. So the issue is, you don't want to just suck off all of the good paying patients and leave everything else, and well, it's actually not just the good paying patients. It's really the increased overhead of a hospital that has to be available 24 hours a day for trauma care, for maternity care. And you have to have then a bunch of obstetricians who can be taking call. That's a big difference than somebody who's working, 8 a.m. to 8 p.m. I think you know that.
Thank you. One final question? Representative DeLamus.
Thank you, Mr. Chair. So my question is, what do you do with a patient like me that had a very severe problem with my back? I had been told I needed to get an MRI, and I needed it like toot sweet. So I called around to different facilities in my neck of the woods to see how much it would cost, and it was like cost prohibitive. And then I ended up calling Basque, and it wasn't cost prohibitive at all. So I jumped in my car and, in massive pain, drove to that facility and got what I needed. If his facility had been closer, it would have been nice. But I mean, I don't know how do you handle someone who, like me, who is not going to go to a place where I can't even afford to do what needs to be done?
Well, a couple of things. One is, I'm not quite sure, were you within the catchment zone of a critical access hospital, and this other imaging center was within that same catchment zone? If we're talking about a long ways away, it's irrelevant to what this bill has to talk about. But in essence, though, it is a very mixed up, messed up system, because the insurers, and it's often even considered proprietary information as to what they will reimburse for any given study. And that's what makes it such a mess to try to find out the cost, as we already covered in detail this morning. So, yeah.
Okay, we ready to move on? I think we are.
And
Thank
thanks
you.
for letting me go early so I can go to my next
I know you have
meeting.
another hearing to go
Yeah,
to
my
at
next
3,
hearing. Thank
so
you.
Thank you. Also signed up to speak is Nick Bayless from the Bedford Ambulatory Surgical Center.
For the record, I'm Nick Valis. I'm the CEO of the Bedford Ambulatory Surgical Center, former board chair of the CON board for a number of years. And I'm here to testify in support of this bill to eliminate the halo, if you may. And I had a large primary care practice in Colebrook, and it was amazing how many times people would just drive 3 hours, 2.5 hours to find lower cost care. The interesting observation here is that the people who can probably least afford health care are paying the highest costs in health care in the North Country. Think about that. Access, affordability should be our aim. And the leading obstacle to access to care is the price of care. Leading cause of bankruptcy is medically related. People are in high deductibles, $5,000 and $6,000 individual deductible, $10,000, $12,000 family deductible is the norm. People are self-insured. I think it's altruistic to say, you know, we need to protect these rural critical access hospitals by creating all these policies, and noble intention. But the people you're really hurting are the people who need elective care. Okay? So I'll give a great example. Alice Peck Day Hospital in Lebanon, right? Critical access hospital. Guess what hospital it protects? Dartmouth-Hitchcock. Very expensive care. The people in the Connecticut River Valley are paying very high prices in health care because Dartmouth-Hitchcock is protected by the fact that it oversees Alice Peck Day Hospital. There are many physicians who would love to send their patients to lower cost centers in the Connecticut River Valley, but it's not possible. And the interesting part is the CON process is alive and well in Vermont. Vermont has one ambulatory surgical center. One. It's a hospital-dominated healthcare system. Expensive as hell for employers. So the laws of economics would govern a lot of this. People aren't going to open up an ASC. I'll give you an anecdotal funny story. Years ago, the athletic trainer for the Montreal Canadiens called me, and because of socialized medicine in Canada, they couldn't get their hockey players in time, in enough time, because time matters in sports, right? Seasons are only so long. And he said, "Hey Nick, let's open up a surgical center in Colebrook." And we met on their way down to Boston to play the Bruins, and I said, "This is impossible." I said, "You can't just make a living on the Montreal Canadiens. There's not enough population." But the interesting part about all that is volume is important. It is important to those critical access hospitals as well. But healthcare is changing. You're seeing more people. You're seeing people more medevaced out, right? And catastrophic problems. I don't believe you want to have surgeries in some of these rural health hospitals because the volume isn't there to support the excellence. So I believe laws of economics won't create a catastrophe, okay? And the fact of the matter is this issue of critical access hospital protection is also protecting some high-cost centers. So, thank you.
Any questions? Okay. Yes, Representative Lamontagne.
Thank you. And thanks for taking my question again. You mentioned that the practice in Holbrook was primary care.
Yes, ma'am.
And I don't know who passed out this. I think it was Representative McLean. But when I look through that, it mainly is pointing to the lack of primary care in rural areas, the lack of rural physicians, PAs, percentage of population without primary care. But this bill does nothing to be, as far as the exemptions that are removing, it doesn't seem like critical access hospitals, they're protecting against any other primary care. In fact, that's the problem. So changing this bill does nothing to change the situation with primary care. It's only for specialists.
I would
care.
agree
Is
with that
right?
wholeheartedly. I mean, there is a shortage of primary care, and I still own some primary care practices, but
But this,
this bill doesn't address that issue. It's the issue of costs. For an example, an MRI. All right, if you were in the Colebrook market, you'd literally have to drive as far south as Manchester, Bedford, to get a reasonable price. Now, if you're in a $5,000, $6,000 deductible and you're paying $3,500 or $4,000 for an MRI, and you can get it for $600, $700, you'll get in a car and drive. Unfortunately, many of the patients don't understand what the prices are.
wait, but just to follow up. But just to clarify, this bill won't change anything as far as primary care.
That is correct.
Representative Siebert.
Well, I also agree, like a lot needs to be done. I'm having a hard time getting past, and somebody brought it up about the liability. That's often attributes to higher costs at healthcare facilities in the first place. And we were kind of discussing that about the iffy side of that in regards to the distance. And then also, you know, what we were previously talking about, that it seems to me there would be issues with liability as well. I'm not sure how you're able to charge. I mean, do you have an example of that? If you say it's so much cheaper, are you being covered by the same type of liability insurance that can protect a consumer if there happens to be a case of malpractice?
Sure. Yeah. Yes. I don't believe to my knowledge, that there are facilities operating without medical malpractice insurance. So I think from a medical malpractice standpoint, liability is not an issue here. It's access to a more affordable care. And if you can't afford it, you don't have access, period. You may have an MRI at Upper Connecticut Valley Hospital that day, but if you can't afford the $5,000 or it's $3,500 or whatever, you don't get an MRI, period.
Any final questions? Seeing none, thank you.
Thank you.
And also signed up to speak, and actually the last speaker is Ben Bradley from the New Hampshire Hospital Association.
Thanks, Mr. Chairman. Getting a little long in the tooth here. My name is Ben Bradley. I am the Vice President of State Government Relations for the New Hampshire Hospital Association. We represent all 13 critical access hospitals in New Hampshire. The Hospital Association is opposed to HB 223. This issue dates back to 2019 when a legislative committee, as indicated by Representative Knirk, was established to study providing certain healthcare services while ensuring increased access to affordable health services in rural areas of the state. Of note, the committee recognized that critical access hospitals tend to have low patient volume paired with high fixed costs. These facilities also have a payer mix that is heavily dependent on public payers like Medicare and Medicaid, with a smaller share of privately insured patients. Rural hospitals have fewer admissions, compounded by declining rural populations in many rural communities that can make it challenging for critical access hospitals to remain financially viable, threatening total closure and access deserts for essential services otherwise only available over an hour and then some away. The Bipartisan Study Committee recommended legislation negotiated by the interested parties, which is what became law RSA 151-4-A in 2020. This included engagement with convenient care interested parties at the table. We oppose this bill because it breaks faith in the negotiated statute from 2020, which we maintain is an important and reasonable expectation for new entrants seeking to provide services within a 15-mile radius of a critical access hospital. Let me be clear about the process. This is not certificate of need. Current statute requires any person or entity proposing to establish an ambulatory surgical center, emergency medical care center, hospital birthing center, drop-in or walk-in care center, dialysis center, or special healthcare service within a 15-mile radius of a critical access hospital to give written notice of the intent to establish a healthcare facility with a description of the facility or special healthcare service to the chief executive officer of the hospital by certified mail. Once a notification is made, the Critical Access Hospital has a time-limited opportunity to share with the Department of Health and Human Services their concerns about the material adverse impact of the proposed new facility. The department would then contract with an independent third party to review and complete a report on those impacts. If the report finds the new facility would have a material adverse impact on the Critical Access Hospital's financial viability, the new facility would not be licensed. If the report does not find the new facility has a material adverse impact, the new facility could be licensed. Notably, the costs for the report by an independent third party are shared equally by the new facility and the Critical Access Hospital. The department may have further insight on how that process has gone so far. We continue to believe this is an important process that ensures critical access hospitals remain financially viable and able to maintain vital services in their communities. For these reasons, we do not support HB 223. I'd be happy to answer your questions.
Any questions? Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So, similar what I was trying to ask Honorable Mr. Nyork about, do you have a number of potential losses for a critical access hospital, like what percentage of paying clients they could lose, or like in the general revenue, how much they could lose if this becomes a law?
Well, in fact, the existing statute affords the opportunity for the Department of Health and Human Services to contract with an independent third party to make those determinations and decide whether or not it has an adverse impact on the existing critical access hospital. And so to your question, I don't have that information, but I assume that if there was a proposal, that would be contemplated and disclosed in order to make the decision on the adverse impact as intended by the existing statute.
Other questions? I'm not seeing any. Oh, I'm sorry. Representative Tejas.
We've heard a lot. Oh, no, thank you, Mr. Chair, and thank you for taking my question. We've heard a lot about the importance of critical access hospitals and how I like the way you really describe low patient volume, lower private payer mix, lower rates of hospitalizations, and yet having higher costs and having to be able to be available. What kinds of margins are the hospitals operating at? And is there any other information that can help flesh out our understanding of the urgency of making sure these stay afloat?
Well, currently, my understanding from recent analysis is that hospitals in New Hampshire are running a negative 0.4 operating margin. So they are affected by a lot of what's going on now in the regulatory environment and other pressures on the cost of providing care. Thank you.
Any other questions? Thank you.
Thanks.
Okay, no one else has signed up to testify in HB 223. I'm sensing no one else wishes to. Is that correct? Okay, that being the case, I'm going to close the public hearing on HB 223. That was the last bill we had scheduled for public hearings today. We do have an executive session coming up. I guess the question to the committee would be, do we want to take a quick break or do we want to proceed immediately? Quick break. 10 minutes? Is that enough?
5.
Yes.
5?
We gotta get moving.
Okay. Oh, the staff said till 5.
And Mr. Chair, I'll just
To call the executive session to order. We have several bills that we're hoping to discuss this afternoon. First one up is HB 54. Representative Nagel, do you have a motion?
I have a motion on a pass.
Okay, and does anyone wish to second? Representative Lamontagne seconds. I know there was a subcommittee, Representative Nagel, you were chairman, and Representative Woods was on it, Representative Kofalt.
Yes.
Do any of you wish to speak about the efforts of the subcommittee?
Do you want to speak first?
Oh, okay, Representative Kofalt.
Yes, thank you. So I had initially had some concerns that the combination of highly regulated plus profit motive could potentially be a magnet for people whose motives were not necessarily aligned with what New Hampshire has been trying to do with medical cannabis. However, in the work session, we were able to drill down to a much more detailed level, and I came to the conclusion that there are some very serious problems. Some of those problems result in patients either going to neighboring states to purchase cannabis or buying it off the street, which I think is an increasingly dangerous proposition. So I guess I feel like my concerns about what might potentially be are far outweighed by the very real problems that exist today for those who are trying to help people with medical cannabis. So I am, at this point, having been on the fence, I am at this point pretty strongly in support of ought to pass on this bill.
Representative Nagel, do you wish to speak to the motion of ought to pass, or? Representative Woods, do you, okay.
Yeah, just to add that to what Representative Kofalt said, we also considered are the proper guidelines all still in place, and indeed the guardrails don't change at all. So I think in terms of the initial purpose was to provide a product that was for patient benefit, in view of the fact that it was still a Schedule I medication. That is, I think, been satisfied both from the standpoint of providing a better financial environment so that New Hampshire can be competitive with Maine and Vermont, but also HHS has been very, having at one point been on the board, very strict in their monitoring of these programs. I think the guidelines and guardrails are still very much in place, and will preserve that aspect for this particular endeavor. I did offer one other concern, perhaps not totally apropos of this bill per se, but the viability of these entities are sort of what's in question. My real concern is the environment of re-looking at all aspects of government interactions and realizing that it's even though it's still a Schedule I, it's only by executive order that the DOJ was directed not to prosecute if in fact entities were supplying services under guidance of state legislation and appropriate guidelines therein. Given the reviews that are going on, I think there is at least some risk, because if that were ever to be rescinded, that would completely undo this program and all programs across the country.
Thank you. Representative Nagel, do you have any comments?
Sure. I really, appreciate what the state tried to do in creating this program. There were models in Arizona and Colorado in terms of the initial recreational or therapeutic cannabis laws that were really grossly flawed. So they wanted to avoid the mistakes that were made in other states. They thought they could do that by forcing it to be functionally a nonprofit. The problem is they forced it to be a nonprofit without any of the benefits that go with being nonprofit, meaning that, you know, they couldn't declare a 501c3 status or anything like that. And the problem is it really adversely affected their ability to get funding. Representative Woods and I both were on the Temescal board at one time, and I'm on the Therapeutic Cannabis Medical Oversight Board. So we have some privy knowledge to the finances, and all I could think of was, I don't know how these places are surviving. And the problem is because they can't raise revenue, they have to get it in other ways at high interest rates, and the cost gets passed on to the consumer, which means that the price is eternally high, and there's no way you're going to bring it down, which means that's why people have to go elsewhere. We were also told in the subcommittee session that about 50% of the registered patients in this state can't afford to get it here, they go out of state. And that's just a recipe for disaster. I work with a guy from the NIH, and they're really worried about fentanyl-tainted cannabis down in the DC area. And he asked me very specifically if we're seeing that here. And I said, I have not personally, but I'm sure it's going to happen. So we need to do anything that we can do to prevent that. This will allow us to provide high-quality product, hopefully at lower cost, and save our patients. So that's why we came to the conclusion we did.
Any other discussion on this motion? Seeing none, motion is ought to pass. On HB 54, I'll ask the clerk to call the roll.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. DeLamus, Rep. Kofalt,
Yes.
Rep. Nagel,
Yes.
Rep. Polizov.
Yes.
Clerk votes yes. Rep. Markel,
Yes.
Rep. McGrath,
Yes.
Rep. Weber,
Yes.
Rep. McKay,
Yes.
Rep. Woods,
Yes.
Rep. Siebert,
Yes.
Rep. Tejas,
Yes.
Rep. LaMontagne,
Yes.
Rep. Hartnett,
Yes.
Rep. Lucas,
Yes.
and Rep. McDonald.
Yes.
It's an FN bill. It's an FN.
It's an early bill, right, I believe? Representative Weber, that would have to go to finance, right? This bill, I believe.
Well, the question is, can it go on the consent calendar? If it used to be, the rule used to be, if there was no appropriation, it could go on the consent, but Representative Mazer says it's over 10,000, so I think
Right.
it's probably just better put it on the
Yeah,
regular.
thank you, Representative McKay, but I don't think they'll let us.
Have that argument.
Right,
Vote is 18-0, motion passes.
okay. And again, because it's an early bill, it'll go on regular calendar. Okay, next up is House Bill 392. Representative Mazer, do you have a motion?
Yes, thank you, Mr. Chair. I'd like to make a motion to retain HB 392-FN.
Representative Drew,
Second.
would you like to speak to your motion, Representative Mazer?
I will keep it very short and sweet. It just feels like we need to do a lot more research and digging into, there's just a lot of information we feel like we still need, and some things that aren't necessarily answered yet, and that we would like a bunch more time to do that research. And I personally would like to do that as well.
Any other discussion? Representative Kofalt.
Thank you. I agree with that statement. I'm also concerned that we might be eliminating some positions or work that is quite important to some people in New Hampshire. In other words, I'm concerned that this bill, you know, if we send it on to the floor and it gets a House vote, that we could have some unintended consequences. And I think it's incumbent upon us as a committee to do that research and be well informed before we send it on.
Any, Representative Nagel?
Thank you, Mr. Chair. I just was watching A Few Good Men last night for the 5,000th time, and I was listening to the end, and of course Jack Nicholson's speech is supposed to be the crescendo, but it's not. It's what happens after that. It's when Lieutenant Colonel or whatever,
Caffey?
Lance Corporal Dawson
Oh.
says, he goes, you know, our role as Marines is to fight for those who can't fight for themselves. which is functionally a more American statement of the story of the Good Samaritan and the greatest commandment. And I was really impressed with that. And as I look through what this department does, they do a lot of really good things for people. And I think this bill by itself, as it's written now, is potentially has a lot of unintended harmful consequences. And I would support what we're talking about here. But we have to remember the good that these people do for a lot of other people that really can't fight for themselves.
Absolutely. Representative Woods.
Thank you. Yes, I would just like to emphasize that I too feel that there are some significant risk of unintended consequences. Unfortunately, words do have meaning, but when the words aren't well defined, especially in our culture today, a lot of the words are not well defined, leads to a lot of emotional reactions. And in physics, you always look at the outlier to give you an example, and I ask my kids, what's the worst conceivable word you could have spoken in 13th century Germany? Of course, they don't know. I said that word is Zoom. Of course, it has no consequence today, but words do have consequence, even though it was the worst thing you could say in 13th century Germany. Words now might have a flip-flop. And so I really, really do support taking a look at this, and I completely agree. I think we could make this a lot better.
Okay, thank you. Anyone else? Any other discussion? Representative Weber.
I'll just say my preference would have been to kill the bill outright, but I certainly applaud the desire to know exactly what we're talking about and exactly what the consequences are. And so I will certainly support the retention and do the work.
I was leaning in that direction myself, actually, but Representative Nagel?
Sorry, I wanted to make one more comment, just because I'm the chair of the State Health Assessment Committee, Implementation Plan Committee. It's longer than that. But anyways, when I looked at the original document that had been created before I got there, the word equity and healthcare equity appeared dozens of times in the document. And, you know, I sat down at one of our first meetings and I said, what does the word equity even mean? So I dug this up from Stanford, and they said most committees that use that word have no clear definition of what they're talking about. And I think that we spent a total of 2 days trying to figure out what that word meant to us. And I think we came up with a really good working definition, but I think that word is so unclear, it's so visceral, and it's so problematic that maybe we need to include as part of our discussion going forward how we want to use that word and make it productive so that people don't get harmed by our interpretation.
And I mentioned to some of you earlier today, Governor Mel Thompson, arguably, I mean, everybody knows who Mel Thompson was and his reputation. The name of his company was Equity Publishing. So that word can mean a lot of things. Representative Kofal, did you have your hand up earlier? Did someone have your, oh, I'm sorry, Representative Tejas.
Thank you, Mr. Chairman. I would say that there's no question about the definition of health equity. We just haven't had a conversation about it. We heard over 2 hours of testimony with only one person in support, including Representative Jess Edwards. We also received almost 3,000 indications of people in opposition to the bill. So I don't really understand why we think there's much to study. We heard a lot about how it could be harmful for many different kinds of organizations and individuals providing testimony. So I don't agree that talking about it further is needed.
Okay. Representative McLean.
Just, you know, to respond to Representative Tejas as to why I think retention is important. You know, I agree with a lot of what you say, but because there is a broader perception and in some quarters a negative perception of what DEI is, if we don't retain this, it could potentially go to the floor and pass. And there are some unintended consequences here that we don't want to allow that to happen. So this, I think, you know, I think Representative Woods nailed it, and retention is the smart go.
Any other discussion? If there is no other discussion, I would ask the clerk to call the roll. Motion is to retain House Bill 392.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. Delamus, Rep. Kofalt,
Yes.
Rep. Nagel.
Qualified, yes.
It's not an option. Rep. Polzoff,
Yes.
clerk votes yes. Rep. Markel,
Yes.
Rep. McGrath,
Yes.
Rep. Weber,
Yes.
Rep. McKay,
Yes.
Rep. Woods,
Yes.
Rep. Siebert,
Yes.
Rep. Tejas,
No.
Rep. Lamontagne,
Yes.
Rep. Hartnett, Rep. Lucas.
Yes.
Vote is 17 to 1. Motion passes.
Not yet.
Oh, sorry. Rep. McDonald.
Yes. Remember Representative Weber when I used to do that to Barbara Griffin, Representative Griffin in the redistricting committee all the time?
I'm going to get Karen to rewrite this so that your name is at the bottom. But
Oh, okay. Well, I'll have to try harder. 17 to 1.
yeah, the final vote is 17 to 1. Motion passes.
The motion is retained, the bill is retained 17 to 1. Okay, next up, and we were thinking about perhaps dealing with HB 634 today. Certainly open for discussion at least as to what we want to do with it. There is an amendment that has been offered.
Right here.
Okay.
Oh, I need to take a copy. I just spaced out.
Yeah, I need a copy also. I will say that I have received a number of calls unsolicited from the parents of autistic children who think that this council should be repealed. Altogether, it hasn't met since 2019, and they feel it's been very unresponsive and ineffective. But Representative Kofalt, you've been more involved in this issue.
Thank you, Mr. Chairman. So I too reached out to some of the parents of autistic children and adults whom I know, and they, without exception, said that the work that is described in the statute for this council is duplicative of work that is described in a different section of statute for the Quality Council. I applaud the sponsors' desire to put some people on the council with disabilities or family members of people with disabilities or on the spectrum. The Quality Council already has that and has been active. This council has not met since 2019, has not delivered an annual report since 2017. And if you read the two statutes, two sections of if you read the statute on the Quality Council and the original version of bill or the House Bill 634 as filed, although the wording is different, the mission is very much the same. It's about how can we serve people with autism spectrum disorders more effectively. And so I simply think that it's duplicative. We ought to be furthering the work of the council that is already doing this work rather than sort of reviving a council that has not met in 5 years and hasn't filed an annual report in 7.
Representative Weber.
Thank you, Mr. Chairman. And I think I'm not sure that I'm where I am on this at this moment because I thought we had some pretty strong pleas from Representatives Stringham and Edwards that with these revisions, the council would be able to complete what sounded to me at that point like a relatively limited mission. And I'd love a chance to chat with them and maybe some other people before we dismiss it out of hand.
We defer
So
it.
I was wondering if we could defer it for a week and, at that point, we might have a little more information going forward.
All right. In regards to that, then, why don't we continue that discussion and defer it until next February 19th? Okay. All right.
Mr.
so
Chair?
yes, Representative Woods.
Could Representative Kofalt, he said that would be duplicative of, could you provide us what that entity and some linkage or some way we can look at that?
I will be happy to send a link. I will tell you that the Quality Council is RSA 171A 33. And so if you do it and there is a web page for it as well. So if you do, I mean, I will send the link out to the committee. But if you read 171A 33, section 4, you'll see that it's different language, but it's very much the same kind of effort that we see in the bill as introduced.
Any other thoughts on HB 634? Hearing none, let's move on to HB 724 FN. Representative Drew, did you have a motion on that?
I move to ITL HB 724 FN.
Representative Mazer?
I second.
Do you wish to speak to your motion, Representative Drew?
Yes, the majority of, I guess the Republicans on the committee at least, we felt that this bill was excessively punishing of landlords, especially the option or the procedure that allows essentially forces the inspection of all of the units in a building when a particular lead issue is found in one of those units. This is very expensive. Also, in the testimony, it came out that even if these dangers are abated for this excessive cost, it's not fully under the landlord's control to stop it from being reintroduced into the apartment, because one of the testimonies talked about simply moving some furniture around could cause that lead hazard to reappear in the unit. And so we feel that this is too much, and it's not. There definitely is a problem. We know we have a problem. There's a lot of old housing in New Hampshire, but this is not the way to address it.
Representative Weber?
I understand that this is an issue that may be of concern to landlords, and I've heard them about it over the years endlessly. But the damage to landlords is economic, and the damage to children can be lifelong. And so I think anything that we could possibly do to ensure that we're giving our kids the best possible start in life is well worth doing. I will note that the sign-in sheets were 108 in favor, 7 opposed, 1 neutral. So there's a great deal of support for this bill outside of here as well.
Other discussion? Representative Woods?
Yes, I do have concern. I understand the economic aspect, and but just being very crass about the whole thing, we're not here to protect somebody's pocketbook. As Representative Rivers said, we're here to protect the public and their, health and so forth. And in this is the meeting the new standard, and that would be pushed back. So we wouldn't meet the new national standard of 3.5. It would remain at 5 unless we do something else. So, I understand the economics and all that, but I just don't want to lose the 3.5 as the new standard. I think that we'd really be remiss.
Any other discussion? Representative Lamontagne?
Well, being a residential property provider myself, rental property and landlord, my husband and I make a lot of effort to keep apartments in good condition. And if I were to find a child in our building had high lead, I mean, I would feel it's a really responsible thing to make sure that other children in the building aren't at risk. I think we should prioritize the health of the children over the desire of a landlord to not remove risks in the building that they own when it's harming children. So I don't think it's asking too much to investigate every unit. I think it's entirely appropriate. So I won't support the ITL.
Oh, sure, Representative Drew.
As we discovered in the testimony, the risk is not removed. When you perform a lead abatement, it can happen again and again. The risk is not removed. It may be reduced, but the cost of that reduction is extremely high. And there are other better ways, simpler ways, less expensive ways to protect kids and families from that exposure.
Representative Lamontagne.
Well, I disagree. I think that it was the suggestion that kids are getting lead poisoning from applesauce lids or things like that. Those are extremely rare, right? The main cause are living in old housing where there's peeling lead paint. So one, if there's a lead abatement occurs, and then later there's a little nick on a stairwell from a piece of furniture being moved, that is not likely going to cause a new exposure for children. So I disagree with that argument.
Representative Mazer.
I recall too that from testimony that someone mentioned that when they were going to purchase a house, they actually knew, it was disclosed in the report, that there was a presence of lead, but they proceeded to purchase the house anyway. So that then the option then falls to the buyer, renter, whatever, because it seems like that is a thing now that is now reported in there. So then the decision can be made on the people buying or renting.
Representative Siebert.
They just to add to that, they, like when we bought our home, it's pretty much a warning saying your home may contain lead because it was built before or after a certain date. And so it doesn't really definitively say if you actually have lead or not. So I think that's important to point out. Another point was someone who had come, the former representative who came to testify in regards to, landlords also have the option, if they're buying a building and they get that same warning, if they ask for a lower price, it does have lead, and bargain out a lower price, which would seem economically sound, and then put that money into just doing the abatement. That's another option as well that was brought up. So,
Other discussion. See, Representative McKay.
Thank you, Mr. Chairman. It happened to me. I have very mixed feelings, and I'm worried about voting without being very clear in my mind. It was hugely expensive. It was very traumatic. We ended up in court. So that I think I'm not objective, and I don't think I should vote. But you can rule one way or the other.
Okay, well, I've never heard of recusal in committee, but I guess it can happen.
He's a landlord, and I think he's got the right to
Oh, no, absolutely. I've just never run into it before. I've never run into it.
I haven't either.
Okay, well, that makes me feel good that you've never.
You're groundbreaking.
Okay, that's fine, Representative.
Representative McKay being thoughtful about it.
Okay, any other discussion?
I believe so.
You can abstain. Right?
We don't have an abstention process in committee. You have to vote. I mean, you have to vote.
You
all
don't
the
have to
time, unless you recuse yourself for
I know.
a particular cause.
I mean,
I mean, I'll be glad to call the clerk if you want me to.
yeah, why don't you? But I'm thinking that, I know if there's a conflict on a House vote, that you should declare it, but on a committee, I didn't know that, so. But
Parliamentary inquiry.
And again, I have no objection. I've just never run into it. Well, why don't we pause for just a moment? He's available. I mean, if he's available, it won't take long. If he isn't available, then that makes it tricky. Hopefully. You're calling his cell, okay.
He did give everybody a cell.
That's true.
Oh, and he
Sounds like she's got a voicemail. They've never talked about it.
When you have a minute, if you could either call or text, we're still working you know, I'm not answering, I'll text him as well. But,
Okay.
So should I withdraw the motion?
If we're gonna move on to another bill, yeah, we can't have, so we can't.
I'll withdraw the motion so we can move on to another bill.
Okay, and Representative Meza, do you withdraw your second?
Yes.
Okay, we'll go back to this bill, at the end. All right, next up is HB 751, Representative McLean, I believe you have an amendment.
Oh, we're doing 751?
We're gonna come back to 724, because it's, just wanted to clarify with the clerk.
So, yeah, so, I'm sorry, Mr. Chair, you caught me off guard.
No, that's
So,
fine.
I'm trying to find, I did have an amendment for 751, which I handed out last week.
It's a,
And so I would like to move-
0220H, right?
Yeah, 220H.
Okay, does everybody have a copy? Do most people have a copy from last week? And 751 FM? Do we need to get any copies of the amendment for anyone?
Well, I think
I don't have a copy.
Representative Weber, she can have my copy, I can talk to it.
That's right, I was given out last week, but you weren't here. So. Representative Palazzo, if you don't have a copy either, or? Okay. Anyone else? All right, Representative McLean.
So I'll go.
Back at the end of the day.
I'll go from memory. Everybody can keep me honest. Thank you, Mr. Chair. So,
So we need a motion, Representative McLean, on this.
yes. Oh, so I moved, amendment 2025-0220H.
Motion is what, ought to pass?
Ought to pass.
And I'll second. Do you wish to speak to your motion?
Yeah, so, thank you, Mr. Chair. So this amendment, takes, we had a subcommittee, last year where we, kind of pared down the bill, and we, got rid of the residential and really, reduced the scope. But, what the amendment does is the amendment takes things even further, because what it does is rather than having the second like a new certification process, which was in the original bill as introduced after the subcommittee. This basically takes takes and rolls it into the existing regulatory framework for healthcare facilities. And so there were real opportunities with respect to efficiencies. Basically, they would just need to have one person for oversight as opposed to, maybe more people if they're creating a separate certification. And it still does retain the position of the ombudsman, subject to available funding. So I think overall, it basically, it keeps the narrowed scope, but rolls it into an existing regulatory framework instead of the separate certification, much cleaner, and I hope you'll support it.
Thank you, Representative McLean. Any further discussion on the amendment? Nothing. We will, we will wait for the chair to go further.
I'm just seeing Kristen Grant might have in terms of insight on the recusal. Sorry.
They don't go up until they're approved. Because we've had times when they've been approved.
Okay, so there's no other discussion on the amendment? Okay. No, since there's no other discussion, I'll ask the clerk to call the roll. Motion is ought to pass on amendment 0220H.
Rep. Mazer?
Yes.
Rep. McLean?
Yes.
Rep. Delamus?
Yes.
Rep. Kofalt?
Yes.
Rep. Nagel? Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markel?
Yes.
Rep. McGrath?
Yes.
Rep. Weber?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yeah.
Rep. Siebert?
Yes.
Rep. Tejas?
Yes.
Rep. LaMontagne?
Yes.
Rep. Hartnett?
Yes.
Rep. Lucas?
Yes.
Rep. McDonald?
Yes.
Vote is 18-0. Motion passes.
Okay. Representative McLean, do you now have another motion?
Yes, Mr. Chair, I'd like to move ought to pass as amended.
Okay, and I'll second. Do you wish to speak to your motion?
Yeah, thank you, Mr. Chair. I think that the testimony that we had last week was very compelling and really highlighted the fact that there is genuine need for this bill. And that just reinforces testimony that we had last year. And especially compelling for me was hearing the woman in corrections, who realized to her horror that she had sent maybe, people forever, in to be taken advantage of. And she said that sent her off on an 11-year mission to kind of put some barriers up around substance abuse treatment in this state. And her comment, we have never been this close. And that really moved me and I think renewed my sense of purpose with respect to this bill. Last year, we said no because it wasn't ready, but we did put the work in. And so I think that's the difference this year. I know that there are some people that, are a little bit skeptical about bringing in new regulations. I understand that. I just got beat up by the committee for 2 hours about trying to, go after and ease back on some regulations. But I don't think that all regulation is bad. There is a place, for regulation. If you do without any regulation, any law, you end up with something like the Sudan or Haiti, and that just kind of breeds tyranny. And I think there is a real tyranny in the substance abuse arena where people are going in and the tyranny is a tyranny of the predator, the abuser, and even falling into relapse. So I don't see this bill and the regulation it brings as being tyrannical. I see it as a defender, and I see it as actually providing freedom for some of these people that want to be able to navigate the treatment landscape without fear of being taken advantage of. So I do hope that you'll support the bill.
Other discussion, Representative Hartnett.
Yeah, I'm a big endorser of this bill, and just thinking about alcohol and drug treatment regulations, we're stunningly unregulated in this area. We have, I believe, a ton of work to do in this area if we want to realize an alcohol and drug treatment infrastructure that's integrated into criminal justice, child welfare, and the broader healthcare system. So I think this is certainly a, you know, a piece of that. So I'm a big endorser of this.
Thank you. Representative Nagel.
I just wanted to thank Representative McLean for all the work that he put into this bill. I think he did a fabulous job on a very important subject. I've been working with people with mixed chronic pain and drug addiction now for a long period of time, and it's very comforting to know that when I make a referral to somebody that I could have some willingness to know, or some ability to know that I'm sending them to a quality place. Having done pain management for a very long time, I'm also aware that the more often you see a late night infomercial or a billboard on a street, it kind of reminds you of the unsavoriness of this area. And this is a place where people do try to profit at other people's expense. And I'm really glad to see there be some level of oversight. So as a practitioner, I appreciate this.
Other discussion? Representative Polazov, I'm sorry.
Just to reiterate that I will be voting against this bill, and it's not just because of regulations, but also because I believe that this bill will lead to potentially to more abuse, because when the idea was born last session, one of the driving force was a case that was outlined on an HPR 13-step podcast, but that case was exactly what this bill will increase. That case was in facility under DHHS oversight, and currently our state is being bankrupt by other cases that were under DHHS oversight. So, and now we are punishing those who were not under DHHS oversight by bringing them into system. I think first we need to make sure that DHHS will clear up facilities under their oversight, and then we can increase, then we can give them money. But this bill will give them more power, more money when they cannot protect people under their oversight. So I cannot go along with it. Thank you.
Other discussion? Representative Kofal.
Thank you, Mr. Chairman. So I too will be voting against this motion. I appreciate the concerns that have been brought forward. I would like to see something done about it. Unfortunately, I just don't think that creating a whole new category of regulated entities is the answer. I did speak to a friend of mine who is very active in New Hampshire in addiction treatment, and I was, it was not a long conversation, but I was trying to get a sense of whether he felt this was a necessary step or not, and he was very clear that he did not believe that this was necessary. And I simply don't. I think we create a lot of potential problems when we add this much new regulation to an entire domain of treatment.
Other discussion? Seeing none, so the motion is ought to pass as amended on HB 751 FN. I'll ask the clerk to call the roll.
Rep. Mazer?
No.
Rep. McLean?
Yes.
Rep. DeLamus?
No.
Rep. Kofalt?
No.
Rep. Nagel?
Yes.
Rep. Polozov?
No.
Clerk votes no. Rep. Markell?
Yes.
Rep. McGrath?
No.
Rep. Weber?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yes.
Rep. Siebert?
Yes.
Rep. Tejas?
Yes.
Rep. Lamontagne?
Yes.
Rep. Hartnett?
Yes.
Rep. Lucas?
Yes.
Rep. McDonald?
Yes.
Vote 12-6, motion passes.
Okay, is there going to be a minority report or?
I will write a minority report.
Okay.
Who was that?
Jim Kofal's writing the minority report. And Mark, you're writing Representative McLean, you're writing the majority report, all right?
Yes, sir.
Okay, and what's the verdict?
What the clerk said is that it is entirely appropriate to recuse yourself in committee. It's best if it happens at the very beginning of the process, but there is apparently, Representative McKay, a form that the clerk will need, and you can't take part in any part of the process, but recusal in committee is entirely appropriate.
Are we able to proceed on that vote then and on that bill, or?
I think so. I didn't ask specifically about whether he needs to fill out the form before we take the vote.
Okay,
I didn't get any sense that it was a problem.
okay. Well, he sat through the hearing.
Well, he can sit through the hearing.
Anybody can-
doesn't-
Anyone.
I
can
mean,
sit through the hearing.
the people who recuse themselves on the floor of the House sit through the House too. It's questioning, making an amendment, doing those sorts of things.
Okay, well, since that's come up, then why don't we go back to 724 now? Representative Drew
I move to ITL HB 724.
and Representative Mazer.
I second.
Any other discussion beyond what we've already heard? I think Representative Nagel.
This is really more for the landlords in the room, but you know, if my kid gets exposed to lead, gets lead intoxication, and I can show it's from the apartment that I'm renting, I have legal repercussions, don't I? Does that put you at risk as a landlord that I can come after you with, you know, pretty hefty lawsuit, I would imagine? Do you guys know?
If it wasn't just.
Yes, speaking as an attorney, I think you have a pretty, absent any other circumstances, I think you got a pretty good lawsuit.
Representative Drew?
My understanding is that if it wasn't disclosed, yes.
Right.
In fact, there was a case in Manchester a few years ago that's been on TV that was exactly that. There was a young child who got lead poisoning and died, and the landlord tried to cover it up by faking the forms and essentially got caught and sent to prison.
So this is like a follow-up question. Would it not be in the landlord's best interests that this law exists to protect them from such circumstances?
There already is law in terms of lead abatement. This is adding to the existing law. It's not the only thing there.
Okay, any other discussion? Representative Woods?
Yeah, just emphasize that if we vote this down, we're also voting down the new lead level. There are two things here. One, we're talking about the financial aspect for the homeowners or for the landlords. But we're also, remember, we're talking about kids too and creating a new lead level for, as the criteria. So I'll keep that in mind.
Thank you. Other discussion? Seeing none, I'll ask the clerk to call the roll. Motion is ITL on 724.
Rep. Mazer?
Yes.
Rep. McLean?
Yes.
Rep. Delamus? Rep. Kofalt?
Yes.
Rep. Nagel? Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markel?
Yes.
Rep. McGrath?
Yes.
Rep. Weber?
No.
Rep. McKay?
Recuse.
Rep. Woods?
No.
Rep. Siebert?
No.
Rep. Tejas?
No.
Rep. Lamontagne?
No.
Rep. Hartnett?
No.
Rep. Lucas?
No.
Rep. McDonald?
Yes.
Vote 10-7, motion passes.
10 to 7 to 1, yeah.
Does the recuse count as a no vote?
I think we have to put it down as a,
Just say recused.
yeah. Put it, yeah,
It's
just,
not an abstention, it's a recusal.
right. do, I assume, a minority report, or?
Anybody want, would you like to do that? Thank you, that would be great. Representative Lamontagne is going to do the minority.
Okay, thank you. All right. So Representative Lamontagne will do the minority report. Representative Drew will do the majority report. Okay, next up is 756 FN. Representative Profalt, did you have a motion on that?
Yes, I move in expedient to legislate on 756 FN.
Okay, and I'll second that. Would you like to speak to your motion?
Yes. This bill would establish that before entering childcare or school, a child would have to be tested for lead. We already have the requirement in New Hampshire that children be tested for lead at age 1 and at age 2. Furthermore, it would impose some administrative requirements. We have heard that that's simply a checkbox, but if you read the bill, it actually says that childcare facilities and schools would be required then to send out notifications to parents. So I do believe that it creates an additional administrative burden for private businesses and schools, and it's something that should not be necessary, as we're already requiring a lead test at ages 1 and 2.
Okay, Representative Weber.
I just want to point out that as I read this, one of the concerns, and I wasn't here for this hearing, but we've heard this bill before, was that kids wouldn't be admitted to schools. And it doesn't say that they have to have, if they have not had the lead testing, which is required, all the school has to do is provide the document the notification to the parent that lead testing is required, and give them educational materials. Once again, lead poisoning is a lifelong condition, and the more we can do to abate that and ensure that kids arrive at school well able to learn and become very productive members of society, we're going to save ourselves a great deal of payment of other kinds of funds down the line. So I think that not passing this bill is not only giving up one more chance at getting that kid taken care of, but it's also penny wise and pound foolish. So I will vote against ITL.
Okay, Representative Nagel.
Thank you, Mr. Chair. Thanks. I'm taking my own question. I agree with that. The ripple effect of lead encephalopathy, lead intoxication is scary. The cost ratio for every dollar you spend for the value you save is anywhere from $10 to $200. It to me, this seems like a trivial effort to create a really substantial, to prevent a really substantial problem. And therefore I'm going to support the ITL, or whatever it is we're voting for. Against the ITL.
Representative Weber.
I also should have mentioned that the sign-ins were 94 in favor, 7 opposed, and 1 neutral.
Representative Nagel.
While he was talking while.
Oh.
Yeah, I was sorry, I was talking to Ms. Brandt.
Repeat like the whole thing?
Well, just what your end result was that you
So the motion is ITL, correct?
Yes.
Then I'm going to be opposing that. Is that what you want to know? Yeah. Is that correct? Yeah. This job's too complicated.
Any other discussion? Representative Woods.
Yes, to me, it doesn't go far enough in the sense that this is restricted to the physical exam part, and the initial part is to public schools. To me, it should be all schools. Why are we parsing out public schools? All the schools should be equally impacted.
Any, Representative Lucas?
I did make a note during the testimony that approximately 21% of 1-year-olds are not being tested currently, and 31% of 2-year-olds are not being tested. So I think a third layer is very helpful.
Thank you. Representative Mateas?
Thank you. I was impressed that Jackie Cowell, who's a really well-regarded person in the early childhood world, suggested that this would make more sense if it happened in the physician's office, because they're going to the physician's office to get the form. To get the form anyways. And so I'm wondering if there'd be an appetite for an amendment, and, for considering, because a sort of like if you map process-wise, they have to go to the doctors anyways, and the doctor could just order it, and the doctor's office could provide the handout. And so I appreciate the need to have a stopgap because of the numbers of kids who aren't getting tested. If the form is required for entrance anyways, then that seems like that would be a better place.
Okay, thank you. I saw another, Representative Nagel, did you have your hand up a moment ago? Or?
Yes, and yeah, I think I'm going to answer both of those. Or, I mean, from a public health point of view, the more points of entry that you use, the more likely you are to get the important data that you need. I mean, my kids went to Boy Scout camp, and the forms I had to fill out, you had to check all this stuff off. It wasn't that big a deal. And then if something was missing, you found out it was missing, and then you remediated it. It wasn't that big a deal. And I'd say, yeah, the doctor's office, this place, I don't have a problem with doing it in more than one place. And that's how we avoid making mistakes. We do it in the operating room all the time. The more people that ask the question, the less likely a mistake's going to happen. Huh? Oh, I do. I'm
I guess I'm glad to hear you're not retired yet.
No, I'm still making.
Good thing I don't. It's very reassuring to hear that, especially when you're not a patient. Any other discussion on the motion? Representative Lamontagne.
Yeah, I feel that if they're going to the doctor's office, they're getting the physical exam, and that is already being brought to the school, so it's just adding it on that. But I think it's one more step that if they show up at school and they happen to miss their 2-year well child and never got tested for lead, it's a way of checking for that. I don't think it's overly burdensome, just another form to make sure, but it could capture a lot more children who have high lead and there's nothing being done about it.
Representative Nagel.
Sorry, one more comment, but if you're catching this at 6, you're too late. So that's the value of childcare, because you're catching them at younger ages. I mean, 6 is way too late. You need to know this way before then. So,
Representative Woods.
Just to disagree with my colleague, it's never too late because if you're having a low level of contamination, it's cumulative. The point is, it's cumulative. It doesn't just stop at a certain level. So if you're getting a high exposure at age 1, that may be the end of the story right there. But if you've got a very low level, you have a chance to intervene. And if by age 6 you pick it up and it is at a low level, then you still have a chance to intervene. So I just offer that.
Okay, thank you. Any other discussion? Seeing none, we'll proceed to the vote. I'll ask the clerk to call the roll. Motion is ITL on 756 FM.
Rep. Mazer?
Yes.
Rep. McLean?
Yes.
Rep. DeLamus?
Yes.
Rep. Kofalt?
Yes.
Rep. Nagel? Rep. Polzov?
Yes.
Clerk votes yes. Rep. Markell?
Yes.
Rep. McGrath?
Yes.
Rep. Weber?
No.
Rep. McKay?
No.
Rep. Woods?
No.
Rep. Siebert?
No.
Rep. Tejas?
No.
Rep. Lamontagne?
No.
Rep. Hartnett?
No.
Rep. Lucas?
No.
Rep. McDonald?
Yes. 9-9, right?
Yeah.
Without recommendation.
Well, we need another motion, right, about to pass? Or do we-
Oh, that's right, you do. I'll move out to pass. or-
Okay. Representative Tellez, you second? Or?
Representative Tellez, go ahead. And I'll second.
Okay, so Representative Tellez moves, and Representative Weber seconds.
Hold on.
And you'll write the report, Representative Tellez? Okay,
Well, we have to take a vote.
well, that's true.
Hold on,
Oh,
hold on.
okay.
Sorry.
No, take
Motion's
your
ought
time.
to pass.
Take your time.
Moved by Rep. Tellez.
Representative Tellez moves,
And
and
Representative Weber seconded.
Weber. Okay.
We have to vote it both ways.
no. What would the third way be? You can't do interim study in the first year of the session, right? Wouldn't it have to be retained?
And I don't think retention is going to change a lot. for this
No,
bill.
I don't think so.
Okay. Are we ready?
We're ready. The clerk is ready to proceed. Motion is ought to pass on HB 756 FN.
Rep. Mazer?
No.
Rep. McLean?
No.
Rep. DeLamus?
No.
Rep. Kofalt?
No.
Rep. Nagel? Rep. Polizov?
No.
Clerk votes no. Rep. Markel?
No. Sorry.
Rep. McGrath?
No.
Rep. Weber?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yes.
Rep. Siebert?
Yes.
Rep. Tellez?
Yes.
Rep. Lamontagne?
Yes.
Rep. Hartnett? Rep. Lucas?
Yes.
And Rep. McDonald.
No.
Vote is 9-9, tie.
Okay, so I'll be going to the House floor with no recommendation, but the first motion be considered under House rules will be ought to pass, right? Sure.
Could we figure out who's doing the minority?
Do we have a majority report?
Well, you don't have a, what you have is you have a statement in favor of ought to pass and a statement in favor of ITL. So it isn't a minority or a majority.
Multiple,
But I
well,
think we do need to sort out who's doing the writing so that they can
sure.
get that started.
Yeah, and the vice chairman needs to know for her green sheet too.
You have mine.
Okay, great.
Okay,
Are you doing one or two?
Representative Tellez is going to do the statement in favor of ought to pass.
Okay,
All right, so
Okay.
Representative Kofalt for ITL, Representative Tellez for OTP, am I correct?
That's right.
and Representative Kofalt, you're doing 756 and 630, 634 we skipped, I'm sorry. 750,
Give him just the time to turn.
okay, yeah,
back
he's doing the
around.
minority report for 751, that's correct, okay. Okay, I have nothing else for the executive session. Are we all set? Do you have a question?
So I want to understand the reason why I'm thinking of studying for this bill is two interesting things. Public versus private, adopted versus child. The latter may have been more supported than the former, but at the same point. What's the difference between the two?
Retain is available in the first year.
Is it functioning the same thing that we can study?
Retain is available in the first year to study, and you have to report it out at a time in November. Interim study is only available in the second year, and you give a report, but you don't do anything with the bill. And interim study is a motion that has to go to the floor of the House. All bills have to be voted on by the floor. We could also just not have voted on it and spend more time on it, but my perception is that neither of the suggestions are going to change much of anything.
And with interim study, you get the decision of the interim study has to be approved by the House.
That's right.
but the final result of interim study does not go to the House floor.
It's
Mhm.
report that anybody can do whatever they want.
And the only motions that are appropriate are either to recommend or not recommend for future legislation. That's right. It pays to have a former Speaker pro tem on the committee here. Okay, again, I have no other business to come before us today, in executive session. We do have a full day of hearings for next Wednesday. Any other questions before we adjourn? Seeing none, we stand, whoop. Seeing none, we stand adjourned.
Get here safe tomorrow.